Good morning, everyone. Good morning. So, welcome to day 2 of Max Transplant Surgicon 2024. Let's start today's sessions. So, for the first brainstorming session, we'll call our chairpersons Dr. Anand Kumar, Dr. Tanabe, Dr. Raj Tobin, and Dr. PB Singh. A request to all the 4 chairpersons to kindly come to the stage, please. Dr. Anand Kumar, Dr. Tanabe, Dr. PB Singh, and Dr. Raj Tobin. So, for today's first session, the first lecture will be given by Dr. Shailendra Goyal. The topic is transplant with abnormal bladder. A word of caution, please. We are already 15-20 minutes behind the schedule, so we'll kindly try and stick with the timelines today so that we do not get late today. Thank you.
Good morning. I will be telling about what we expect and what we thought when we do a transplant. So we expect there should be a normal bladder, so there is no post-op hassle about the urinary things, post-op diuresis and things. Normal bladder is that stores urine at a low pressure to its normal capacity and empties completely when the bladder capacity is there at a usual interval without any incontinence and without any obstruction, maybe because of prostate or detrusor sphincter dyssynergia. But what we get is usually the defunctionalized bladder that has been a low urine output for years as the ESRD patient is on dialysis. So, and in this dysfunctionalized bladder, most of our evaluation usually doesn't happen, or if we do, that takes a lot of burden, lot of complications, and that may or may not be useful also. So, what has been studied that 15% adult patient have some bladder dysfunctionality, and in the pediatric population, this thing is relatively higher, maybe up to 30% of the cases having a bladder dysfunction. And that bladder dysfunction which has caused the ESRD to the patient, that may also damage the graft. So, but over the time, experience of different surgeons and studies, it has been found that abnormal bladder is not a contraindication. Of course, a proper selection, we can optimize the bladder function and good graft survival can be achieved. So what are the abnormalities we can expect? It can be a neurogenic bladder like myelomelangeal spina bifida case, or it may be a bladder outlet obstruction. We may have a patient have a history of a stricture urethra, or the elderly patient, male patient may have a outlet obstruction like a prostate enlargement. In young children, there may be a history of posterior urethral wall. Acquired voiding dysfunction, patient already have a augmented bladder, or VUR is there. Congenital abnormality like prune belly syndrome or other Oka syndrome, anorectal malformation. Acquired bladder disease, most of our patients are diabetic, and there might be a sleeping diabetic cystopathy, genitourinary tuberculosis, post-radiotherapy patient, patient have a previous genitourinary malignancies, or fibrosis because of the chemotherapy. So what evaluation we should do in a transplant patient? Of course, the history, what is the patient native disease has been, whether it is any malformation related to the bladder, there is, how is the urine output of the patient, native urine output is there. And when the urine output is good, then the workup is relatively easy. Any history of Lutz, detailed physical examination regarding is there any scar is there, stoma or some previous surgery, history of catheterization is there, or already patient is on catheter, that has to be checked. Investigation, what is recommended, maybe depend upon the case to case. That may be a urine culture. Sometimes that is not possible because the patient is anuric, or even if we get it, it may not be a representative one. But abdominal ultrasound and post-void residue is important test. And if urine output is okay, uroflow we can get. And MCU and urodynamic studies are reserved for the specific cases where it is indicated. If the patient is having a sufficient urine output, then voiding diary, uroflowmeter, and post-void residue, this is sufficient to evaluate the bladder. Detailed bladder evaluation are usually must in pediatric patients. And it has been seen that, and what we are usually following is, if the voiding patient has a history of before onset of ESRD and when his urine output was normal, if he says that there was no urinary difficulty, then much of the investigations are not required. And even if that is done, that usually causes a complication in form of UTI and not usually required. And this has been studied at Grants Medical College, Mumbai, and they have presented the paper regarding this also. And in a urodynamics, where we do the urodynamics, the parameters are, if the patient's filling pressure is more than 40, that means the poorly compliant bladder. And when the more than 40 pressure is there, then the ureteral transport of the urine ceases, and it causes the upper tract damage. Even the leak point pressure in the spina bifida or the other neurogenic bladder, where the leak point pressure is more than 40, it damages the upper tract. And when it is there, it causes the graft. There is a possibility this more than 40 pressure also may damage the graft. Or if the voiding pressure, bladder capacity is small, less than 100 ml, and voiding pressure is more than 100, this can also damage the upper tract. So in these cases, these abnormality must have been corrected before the transplant. So how to manage these patients where these urodynamic abnormality or the poorly compliant, small capacity, high pressure voiding is there? So there are the three management principles. One is we have to ensure the proper bladder emptying, bladder capacity and compliance. And if there is an incontinence, of course the incontinence doesn't damage the graft, but of course when the patient gets the transplant and all, so he also expects the continent in his life. So how to improve the emptying? And in the scenario, if the compliance is okay, then CIC is one good option. And when the urethra is normal and patient is cooperative, CIC teaching that can be started in a pre-op period so that the compliance is better in a post-op. In transplant patients who are immunosuppressed, so instead of a clean CIC, sterile CIC using the sterile catheter each of the time is better to prevent the UTI. And when the bowel segment is used, like in a patient who is on mitrophenol or ileal conduit or continent conduit is there, then even the bowel segment doesn't increase the risk of a UTI. So to enhance the bladder emptying, when the CIC is not possible through the normal urethra, then the continent ileal segment can be used, or a bowel, so normal bladder, mitrophenol can be used as a principle, and through mitrophenol, the patient can do the intermittent catheterization to evacuate the bladder. And when the appendix is not available, then the Young-Monty's procedure can be used, where the small segment of the ileum can be reorganized to form the channel so that the catheterizable stoma can be made. And how to restore the bladder capacity and compliance? And for that, the bowel segment has been used in the different procedures like augmentation cystoplasty, where the ileum, colon, stomach, and sometimes the dilated ureter can be used for the augmentation cystoplasty. And the purpose of this is so that we can maintain a good capacity, low compliant bladder, not poorly compliant, but good compliant bladder with a good bladder capacity. And when to do these surgeries? There has been studies of both. Some recommend that these surgeries should be done before the transplant, so that after the transplant patient is on immunosuppression, chances of infection is increases, and the patient become more compliant when the things has been started before. But it has been done that after the transplant, when the patient urine output is maintained and immunosuppression has decreased, so after that period, then we can also do the surgery at that time also. So this is a ureterocystoplasty. Advantage of ureterocystoplasty is there that the ureter is already in a wet condition, mucus secretion is not there, chances of metabolic acidosis are less. In incontinent urinary conduit, like ileal conduit can be used when the bladder is thimble or bladder is not usable. In that scenario, ileal conduit can be made. And when it should be made, the principle is same. They say that should be done at least 6 to 8 weeks prior to the surgery. And from technical perspective, it has been advisable that ileal conduit should be made on the same side where the transplant is expected, so that the distance between the ureter and skin for the transport of the urine is less, so that the less chance of the urine less time of the urine for the contact in the bowel, so that chances of metabolic abnormalities and electrolyte disbalance are less. And in a ileal conduit, it is preferable to place it retrocecally, and in some scenario, the kidney may have to be placed upside down. And when we have done the ileal conduit formation before the transplant, so instead of searching for the end of the conduit, we should do the transplant in the end to side manner in a single layer, so that because of adhesions in post-op and all, we may not need to search to the base of the ileal conduit to get the end-to-end anastomosis. Lot of studies has been published regarding this augmentation or continent conduit or the incontinent conduit and the results. But all these studies has a different parameters. Evaluation in these small studies where sometimes there is a 30 patients, sometimes 50 patients and all there. But all parameters are different because the renal function after the surgery depends on lot many factors. And equalizing all the factors are not possible to get a proper results of these studies. Of course, we can get an idea of what is going on and what the things can be there. In the graft survival, if we do in a study in the augmented bladder, there was no difference in augmented and divergent group. But there was a trend that you see 78% augmentation bladder has a better survival than 46%. That means it is better, the augmentation is better, where the native bladder with the augmentation is better than a divergent. And these are it has been found that when we are using these bladders where they are abnormal, the chances of urinary infections are more and symptomatic UTI are more. And it has been suggested reconstructive surgery well before the transplant to avoid the deleterious impact of immunosuppressive agents. So they recommend that these surgeries should be done before the transplant. So chances of complications, if we do a transplant in ileal conduit in comparison to the normal bladder, the chances of complications are high. So the problems in the continent reservoir, when we are using the continent reservoir, maybe with metrophenol for the young Monty procedure, the chances of complications are relatively higher in a form of obstruction or infections. And UTI, symptomatic UTI are very common in the first 3 months of the transplant. And prophylactic antibiotics are recommended at least for initial first 6 months. And it has been found that UTI has led to the graft loss in some of the patients. So, and regarding the third principle, continence, when the outlet obstruction, outlet resistance is less, maybe the urinary sphincter is not there, they have studied the bulking agents or maybe but they are usually having a low duration effect only. So the artificial urinary sphincter has been recommended, and both pre-transplant as well as the post-transplant surgery has been studied, and some advocate that it should be done before, and some recommend that it should be done after the immunosuppression is reduced and the urine output is regularize. In patient of posterior urethral wall, bladder is usually abnormal, so we must do the urodynamic studies, and it has been found that the bladder that has damaged the upper tract may also damage the graft also. And most of the time over the study it has been found that posterior urethral wall cases, that their nadir creatinine is usually high, chances of UTI is high. In patient of vesico-ureteral reflex, ureter is dilated, chances of infections are high, and when there is it has been found that infection is high, then in VUR cases we should do the native nephrouretectomy to avoid the post-op recurrent UTI. Complication, what we expect in all these extra surgeries are higher chances of reoperation like urinary leak, stenosis, UTI, metabolic abnormalities, electrolyte disbalance, calculi formation, and also these, when we are using bowel in the bladder form, then the chances of cancer also increases, then the evaluation and follow-up is that also require. Special cases of torsion of graft has been found in cases of prune belly syndrome where the abdominal muscles are lacking, and we are doing intraperitoneal transplant, then the torsion has been reported in these cases. So in conclusion, abnormal bladder should be evaluated properly for the proper rehabilitation before the transplant. Pre-op counseling is very important. Recurrent UTI is a major problem. Graft dysfunction is common, and results are inferior than a normal, but of course with the proper selection and proper management we can do the transplant, and good result has been reported.
If there is any question or comment?
A nice talk, Shailendra.
Thank you.
One place I think you said that augmented bladders have better outcomes than conduits.
Yeah, that has
seems
been.
to be a little counterintuitive because, to my mind, a conduit is the most kidney-friendly diversion that you can have. There's no storage. The urine is directly expelled versus an augmentation where you have bowel, where you have mucus collecting, where you have possibly self-catheterization, more frequent UTIs. So I just, do you have a comment on that, or sirs, or some other?
Probably the cases, in those cases where the ileal conduit has been done, there the problem might have been a multiple rather than those patients where the bladder is being used with some augmentation only. So those cases might have been, other factors might have been possibly complicated the things.
Yeah, but you are right. The published result as well as our experience is ileal conduit patient do lot better than the augmented bladder.
In our limited experience, ileal conduits have all actually been quite smooth.
Yeah.
Whereas it's the augmentations which always come back to you with issues and
yes, you are right.
and pyelonephritis and things.
Yeah, Anand, but suppose patient has got a neurogenic bladder with a high pressure bladder, and you have your decision between a clamp cystoplasty prior followed by transplant or a conduit. Do you think you'll prefer conduit?
No,
The bladder capacity is good, everything is good. Only thing is you want to make a low pressure, you do a clamp cystoplasty and later you do a transplant. Conduit is the last option. Means lower tract you cannot preserve. Yes, conduit is the best.
No, definitely augmenting, but from the point of view of not having a stoma and having normal voiding is desirable.
Yeah.
So that is what we would prefer if the bladder is not too bad, but I think it comes at the cost of slightly increased incidence of infective complications and possibly that influence the outcome of the transplant.
See, augmented bladder everybody will prefer, for the patient will prefer, but problem is because of the mucus secretion and recurrent UTI is quite common, and even though you give this prophylactic antibiotic, even if patient is doing clean, rather than we don't even advocate clean, we aseptic CIC, but still results are suboptimal in comparison to the ileal conduit. That's what the published result, that's what we are discussing, but it's not that. It's still, when you sit down and discuss with the patient opt for augmentation rather than ileal conduit.
Shailen, just one question. Can Botox help? Suppose patient is not agreeing for any augmentation or clamp cystoplasty, and he has heard that you give a Botox every 6 months, I can take the Botox, make a low pressure and do a transplant. Is that an option?
Botox has a disadvantage because its effect is limited to maybe 4 to 6 months and maybe 8 months. So he has to get it done repeated.
But
And
can it
sometimes
be-
we can see the compliance in our patients. Of course, when we see the patient in a CA prostate patient, they opt for the active surveillance. But when they came 2 years after, we found that is a metastatic CA prostate. So the surveillance and observation and low time treatment, but ultimately they came back after
So
1
better
year,
to go
and when the
definitive
problem
surgery.
is there.
Yeah, the better go for definitive surgery.
Yeah.
No, actually the Botox has almost decreased the incidence of clam intracystoplasty dramatically. Botox has always been the preferred and multiple injections are always been the preferred. Patient who cannot be managed with the repeated Botox injection undergo intracystoplasty, and intracystoplasty incidence has gone down significantly because of the Botox. But there are patients where the Botox will not be working because of the lower capacities and small.
Not thimble bladder,
Yeah,
but
not,
only
not
high pressure.
even
Yeah.
for this, there definitely augmentation have a role.
Thank you, Dr. Chan. Thank you. Next is yours. Now I would like to invite Professor Anand Kumar for recipient with the thimble bladder, really a challenge for the transplant.
And actually that Shailendra has done a wonderful job and so had taken away some of the load from our talk. But my talk is little different. It is just, I'm just trying to show that even if you know and you have dealt such patient in the past, but still you can get trapped suddenly. And if it happens, then what you should do. So I'm just talking of two patients which in last 1.5 years we encountered, and we never encountered them before, and this probably because of we missed few steps. So there was a 61-year-old lady from Africa. She was, when she came to had, she was incontinent. She had hysterectomy in 2018 and she was continuously leaking. She had tubercular treatment, anti-tubercular treatment 20 years back. The uroflowmetry showed that she was passing a very small amount of urine, and that ultrasound showed that she had a bilateral renal disease and few small cysts and bilateral hydrourethronephrosis. So we did cystoscope. She was already in renal failure and on dialysis. And so we did cystoscopy. We found that there was a significant cystocele, rectocele, severe degree of stress incontinence, and bladder capacity reduced. So which we presume that because of the severe degree of stress incontinence and all that, she is leaking urine, and that's why capacity is reduced. And there was no leak, there was no viscovaginal fistula or any other fistula. So we thought probably it is the severe degree of stress incontinence and cystocele. So we did cystocele repair and sling surgery. And after that she did improve, but still she was leaking some urine. And she was quite happy because it was a change from continuous leak to some leak. And then she underwent the evolution for the kidney transplantation. And then she was posted for the transplant. And during transplant it was very difficult to find the bladder, and then we realized that bladder is very small and very thick walled. We thought we'll put into the ureter, and the ureter was pipe stem. Then we realized probably we have missed something and what to do at that stage. So what we did, we dissected the bladder and just did the direct anastomosis with the bladder, and we came out, keep the Foley's catheter. And when the Foley's catheter was removed, she was again incontinent. And then we did the study and we found that bladder capacity was very small. And it's not that stress incontinence, the small capacity, because of that she is passing urine very frequently, and some degree of leak was still there. Probably stress incontinence was not completely taken care of. So we advise that it is better you should undergo, because ileal conduit, I thought in such a small situation, post-transplant augmentation in such a small bladder may not be a good thing to do, or if she still leaks after the augmentation, then again there will be a problem. So we advised, but she had fund issues. She went back to the country and then came back with the funds. And then we did the ileal conduit. And after that, she did very well. So still we did not learn from our past, and we got trapped again. And this time, there's a 45-year, again he came from the, I think, Somalia. And he had, when he came, he was quite sick and he had a infection and he was treated in emergency. He was in sepsis and he had a pleural effusion and left renal abscess. So renal abscess was drained and he was investigated. We always investigate for tuberculosis, but everything was negative. And when we did his cystoscopy, we did see that there was a small false passage, capacity was small, and it was difficult to keep a catheter with some urine. So it was decided at that stage that he should undergo full evolution, and same time he underwent left open nephrectomy, and histopathology did not show any, and it was infected kidney and did not show any evidence of tuberculosis. And it was mentioned that patient should undergo MCO. I don't know what happened in busy unit. Suddenly patient was posted for the surgery, and when they tried to put the catheter, they can't inflate, and whatever they were putting, it was coming out. Anyway, the patient was, and I think there was difficulty in catheterization, so they did cystoscopy, and with the help of guide wire, they could put a catheter, and they could only inflate 10 to 15 ml. And then I was called that transplant is done, but bladder cannot be identified, and we don't know what to do. So when I came, I just saw there is very small bladder. I dissected it out. Again, ureter was pipe stem. So then I thought, oh, we got trapped again. So we tried to put the ureter directly to the bladder, and this balloon cannot be inflated. So what I did, I took a stitch, catgut stitch, and tied with the catheter with the bladder mucosa, and did not inflate the balloon, put a stent, and we just came out. So that way we could salvage the situation. The patient did well, and he was on catheter for 2 weeks. After 2 weeks was catheter removed, he was completely incontinent. So he was put on diaper, and again we thought that in this situation probably we'll do the ileal conduit, and we explained to him, and I think he took 4 months to collect the fund, and then he came back for the ileal conduit, and this time the ileal it was again difficult to identify the ureter, but we know that we have put it over the bladder. So we just went to the bladder, tried to find out here was the bladder, and we could get the whatever attached to the bladder we disconnected, and we could see the ureter, and then we did the ileal conduit. It was done only 4 weeks back. He is still in post-op and he is doing well. So these two situations, it was a thimble bladder, and it is a fibrotic non-compliant bladder, and that's why they get upper tract changes and renal failure. Most common etiology, especially in developing country like India, and we have seen in Africa also, it is tuberculosis. But we had patient similar especially from Iraq. We get many patients who had schistosomiasis and presenting like that. And it can also happen post-radiation and post multiple TURBT, BCG, sometimes these patients have. We have patient post-radiation where we did ileal conduit again in a transplant patient. The recipient with small bladder, thimble bladder, they have very poor compliance, decreased capacity, and very high pressure transmission to the regenerative kidney, leading to the renal failure. And if you don't do anything and you do the transplant in such bladder, this transplant kidney will meet the same fate. It is very important to take proper history. With proper history, you will be able to get the information And then all patient who has any kind of intervention in the urinary tract or the difficulty in voiding anything should undergo MCU. This is a classical teaching everybody knows about, but sometimes you still miss it. And those patients who have hematuria, feature of low grade fever, night sweats, weight loss, prior history of tuberculosis, they should be fully investigated. And if you examine them, if there is lymphadenopathy and other feature like epididymal nodule or something, then you should suspect the tuberculosis. And you must investigate, apart from the routine investigation, tuberculosis investigation should also be done like urinary AFB, urine genetics expert, and you should also see if especially these patients do have some HIV infection also. And if the patient is coming from the Middle East area, must look for the schistosomiasis in the X of schistosomiasis in urine and stool. And when you investigate, apart from that, MCU, CT urography or MRI, and even if these patients are renal failure, you can give the contrast and get the CT urogram and IVP and dialyze them, because you will get more information than by MCU alone. Then what are the options when you see very small bladder? Then either you do augmentation. Here the augmentation is very different. Here it will be like substitution augmentation. You have to excise that bladder, only keep the supratrigonal part of it, and invariably you will also need ureteric reimplantation into the augmented bladder. So this part, and if you don't excise that and just open it and put a bowel, very soon within a few months or a year, they will come back like stenosis at the anastomotic site, and that augmented bladder will become a pouch or big diverticulum, and then it might even rupture. This happened with us long back in a tubercular patients. Simultaneous augmentation and transplantation has been done, not by one, by many people, but we don't have courage to do both the operation together. You can do the transplantation and then do the ileal conduits, which we did it when we got trapped, or you can do the augmentation later on, 3 months. We prefer to do it 3 months later, when at that time immunosuppression is minimum, patient kidney function is stable, and chances of infection are less. Augmentation first is good because that patient is not an immunosuppression, so healing will be better. Even though they are renal failure, healing will still be poor, and there is decreased risk of infection. But the problem is these patients are not making urine, are making very small urine, and there is a mucus collection. So you have to do the bladder wash. So you have to put the catheter and do the bladder wash. And we have seen, it happened with us in this situation, that even catheterization has gone through from the suture line and injured it, and the patient developed septicemia, and one patient even could not be saved. So after that we are little scared of doing augmentation, but we have done at least 14 patients of augmentation before the transplantation, and we published it also. So these are the various publications which has shown successful outcome with augmentation first. Simultaneous augmentation is also described, and these are the various publications where they have done it, but we have not done it because we thought probably it will be too complicated and may complicate the post-operative transplant period. You can do the transplant first, and 3 months later, when patient is doing well and on minimal immunosuppression, then you can do the and at that time patient condition is good, probably you will get a, and patient is making urine, so augmented pouch will be easier to wash out and things will be done. These are the various publications showing that you should do it at later on. Why ileal conduit? Ileal conduit, as we discussed just before, is the easiest thing to do, and but it is not liked by many patients because it is body image is disturbed and they are not passing urine periurethral. But it is the one of the easiest operation to do it, and long-term results are good. So first thing I would like to say that it is try to avoid this situation, take a good history, do MCU investigation, try to find out what you have and then plan it accordingly. Getting trapped suddenly is too much of stress and too much of problem for both, for doctor as well as for the patient. So proper history is important, but if you get trapped, then probably the ileal conduit is the best thing to do it and come out. Thank you.
Thank you, Doctor. And just one question. In your first two cases, ideally speaking, it should have been diagnosed prior to the transplant.
Actually, both were diagnosed, but one time, one patient we thought it is stress incontinence and other thing, and other, it is written that he will go, and I don't know what happened. That
my only question is, why didn't you thought of doing conduit immediately at the time of transplant? Because transplanting a ureter into a thimble bladder, because thick bladder, difficult implantation, number one. And secondly, when you go for ileal conduit, surgery become more difficult, particularly with the transplant ureter. Why didn't at same time we have thought of doing a conduit?
There are two things. First thing is that we have not discussed with the patient. It will be a great, when the patient wake up, patient will wake up and will see that there is a ileal conduit. So patient will
consent was a problem.
So we have not even discussed. That is one thing. Second thing is during transplant we have seen that we try to avoid any other surgery, because in the past we have done even cholecystectomy with transplant and there was a problem. So we try to avoid it, let the transplant be done, let the patient recover, let the immunosuppression come down, and then we will do the procedure as a planned procedure after discussion with the patient. You can do it, people have done it. People have done the augmentation and transplant together.
We have to judge between because second surgery is required. That second surgery will be easy afterwards or at the time of transplant. That decision has to be made.
Yeah, and because I'll tell you one patient who had a post-radiation, and he had post-radiation was given for the cancer rectum, and he had radiotherapy, chemotherapy, and bladder become thimble bladder, and he had a bilateral PCN because the ureters were all fibrosed. So in that patient, we did transplant and ileal conduit together. And he already had one colostomy, and he did well. Now he is almost 8 years of follow-up.
Yeah,
so you can do it, but that we discussed the patient and he knew about it. What is he's going to get it? Here we have not discussed all these things with the patient. So we thought let's come out of this situation, and then we will do it. You can do it, and doing ileal conduit same time is the only risk is that in immunosuppression probably the bowel leak, but with the stapler and all that situation is not bad, and transplanting native this fresh ureter into the ileal conduit is lot better than again dissect them and taking out and then putting the ileal conduit. So you can do that, but you should be prepared and patient should be prepared for that.
Can I take one question?
Yeah.
Actually, you have done these cases and you have a larger experience of that. But as far as we know that leaving a defunctionalized bladder is not a good idea, because it can be a source of pyocystis or a recurrent infection, and particularly in immunosuppressed patients in renal transplant. So I just wanted to, I think in both the cases the native bladder was left.
Yes.
You described.
Yeah.
So you think that that pyocystis or recurrent UTI is not a problem when you leave a defunctionalized bladder in the patient's body?
So these patients were hardly making much urine. And so that part was left, and after the transplant, the native kidney, whatever urine they make, they also goes down further. So probably that problem will not be there. The first lady was leaking whatever she will leak it out. Even this patient was not making much urine. So probably the defunctionalized part is still there and will not cause problem. If it will cause problem, then we'll have to remove that bladder.
That was the only concern.
Yeah.
Thank you.
So regarding ileal conduit formation, is it possible to make ileal conduit prior to transplant if it is a known case?
Yes, it is good, and then you should plan it. See, then very easy. You put it stoma little higher up because the kidney transplant will be there, and the ureter, it is better put the kidney upside down, so that your ureter is there. So you need a short ureter to put the ileum. You can put the kidney in normal way also, and ureter can go up and ileum can go down, and you can do the anastomosis. So both way you can do it, either upside down or simple way. Upside down is very easy. You can just put the ureter, and drainage is by the peristalsis, not by the gravity. So it doesn't matter. But it is easier if you put upside down and just put it in the...
after how many days of ileal condu can we proceed for kidney transplantation? Do you have any?
So 1 month is more than enough.
Okay, sir.
Thank you, Dr. Thank you
Thank
very
you.
much.
Sir, can I just ask one question?
Yeah.
Sir, if I may. In both your cases, you had to do a conduit after your kidney transplant. Was your technique any different? I mean, normally we stick the conduit to the sacral promontory. Did you have to keep to reach the lower pole of the kidney and the ureter, did you have to keep a longer length and bring the tip of the conduit down towards the lower pole? Or
No, there was like both that we dissected the ureter from the bladder and disconnected it, and then excised the part of the ureter which was like because of the inflammation or
right.
something. It was as soon as we got the good ureter, we spatulated it nicely and try to fix it with the and ileal conduit, which is, since it is you take 15 centimeter of ileal conduit, it easily comes where the ureter is. And in both the time, why I am telling that one, I did it electively, we put the kidney upside down,
Yeah,
and it
that's the
was
way
quite
you do
easy.
it.
Here is already done, but even there is no difficulty in bringing the transplant ureter to the where the ureter was available.
Thank
But
you.
it is not essential to fix to the sacrum. Yeah, if it
It's
can
not
done is
essential
okay,
to fix.
but that is not mandatory that
Yeah.
we have to do it only.
In robotic transplant,
Yeah.
we never fix to
Whenever,
the
yeah.
sacrum.
Thank you, Dr.
Is the conduit extraperitoneized, or it's like kept like a normal
It,
cystectomy?
it was lying in the peritoneum.
So that means while doing the implantation, you open the peritoneum and
Yeah, yeah.
reimplant.
Yeah.
Okay, now we'd like to invite Professor Raj for giving a talk on recipient with poor cardiopulmonary reserve, anesthesia perspective. Dr. Raj, please.
So I thought we'll show it. I know it's the next case, everything was written in the file. I don't know that stage was what happened, and there's so many people working.
You have not put my first slide. Hi, good morning, everyone. I'm Dr. Raj, and the idea is not to teach you anesthesia, and of course, I'm not going to give you any information with which you can harass your anesthetist. So this is just, skipping on the surface so that we are on the same page and you can empathize with your anesthetist. So many of our transplant patients have very limited cardiopulmonary reserve. And I would like to start this short PPT with this slide that for most ESRD patients, the greatest risk lies in not receiving a transplant. So we have to be courageous, not bold, but courageous to work these patients so that we can perform transplants in them and they can have a better life. So just to strengthen what I've said in the earlier slide, that out of 4,944 identified records in 8 studies, the conclusion was that kidney transplant recipients had significantly higher oxygen consumption at peak/max exercise. So when we talk about a cardiopulmonary reserve, basically we are talking about the oxygen consumption, optimum oxygen consumption for a particular stress level. So this is exactly what we mean by cardiopulmonary reserve. So there are 3 components of this. One is the pulmonary gas exchange. So that has an impact on the reserve. The cardiovascular performance. So this is all your basic MBBS knowledge. So there's nothing I'm adding to it. And how is the utilization in the periphery? What is the delivery and what is the uptake? So these 3 components are required for us to assess, to know that patient fits the bill to be anesthetized. So again, going further, so these are the certain comorbidities which can make it worse. Hypertension, we do get in our country many poorly controlled ESRD patients. The blood pressure is very badly managed, or there are a multitude of drugs, but no deliverability is there. They continue to go into pulmonary edema even though they are on dialysis. They may have high levels of NT-proBNP, which many people don't even bother to check. Patient will have uremic cardiomyopathy, and like a diabetic cardiac condition where patient may have a silent MI, even uremia can cause a silent MI in a patient, and we need to investigate for that. We try to target, because though body compensates by shifting the oxyhemoglobin curve to increase the deliverability of oxygen, But if you just work on anemia, we are not looking for 8, 9 HB. Even if the HB comes up to 6.5, that adds to improving our reserve in these patients. Poorly controlled diabetes, again I said, because of peripheral vascular disease, because so we cannot work much on it, but at least we must make an attempt to control the sugars. Ischemic heart disease, I'm sure I don't need to elaborate. Most of you are aware of the impact on the cardiopulmonary reserve in these patients because of low EF, because of diastolic dysfunction, akinetic, hypokinetic wall. So heart is not able to deliver the stroke volume desired for a particular MET level. High PA pressures, very frequently seen in ESRD patients. We know the normal should be below 25, so we see quite often above 45 and very often above 80. But this is not a pulmonary artery hypertension, so we must not panic, and we just work on these patients. We can improve on that with good hemodialysis, with modifying drugs for optimum cardiac function. We improve the nutrition. In many patients, ESRD patients, sometimes the focus is on what they cannot eat. Nobody puts them through a good dietary plan or dietitian who tells them what they can eat, and that results in very malnourished patients. So it may not be just one factor which is resulting in a poor reserve. So there is a cocktail, so there may be a cardiac dysfunction, there may be a lung which is totally full, patient may be malnourished, HB is low. So we cannot give optimum 100% in all of them, but we just improve 15-20% of all these parameters which are present in the patient. We can move a patient from very low poor cardiopulmonary reserve to a much higher, which makes the perioperative outcome much better. And we see that because when we do a PAC 3 months, 6 months ahead, and when they come back to us, after 3 months or so, once the nephrologist and multidisciplinary teams have worked on them, we find that even those patients which we thought, oh, no, we must only do an open, and I have argument with Dr. Anand Kumar, we find that we are more than happy to do a robotic transplant in those patients. So that is how what the approach should be. So what are the red flags as surgeons? For you, the red flags are that older recipients. We are operating I started as a junior anesthetist assisting in a transplant. Transplant patients were not older than 40 years of age, but now we are taking up 65, even 70-year-old recipients. Frailty score may be very high because of comorbidities, not really dependent on age. Patients coming for second transplants, international patients from underdeveloped countries who have been poorly dialyzed, poorly managed. Post-COVID, we see a lot of post-COVID patients with considerable chest conditions still persisting. So we ask for post-CT in these patients. Recent history of ICU admission for sepsis. So a patient gives you a history of COVID, and we almost always ask them that were you hospitalized and were you in ICU, and then we do ask for a pulmonology review or a CT test, whatever is required. Recent history of a coronary event, then you wait out that much time because the results will be much better when you operate after 6 months. History of pulmonary edema, is the patient going into it again and again. Early fatigue, you get this report, inconclusive DSC. And cardiologist may do a coronary angio or may clear depending on what is the mood of cardiologist at that time. So this is also a red flag for you that these patients are, not optimum. They do not have an optimum reserve. And of course, robotic transplants. Robotic transplants has its own set of challenges. So just to touch upon a couple of these which we come across, you all must be coming across in your daily practice. So for second transplantations, because one is apart from the ravages of ESRD, they also suffer from the impact of immunosuppression, which they've had for maybe a couple of years or several years. So it hits the cardiopulmonary reserve. Uremia is a second hit. They went through ESRD, they got transplanted, the kidney failed, so then again they're facing uremia. So that's a second hit for them. New onset cardiovascular disease, so they probably were fine when they were 35-year-old, had the first transplant. They're coming back to you at the age of 45. We know it's a severe cardiovascular disease. ESRD is a harbinger for it. Most of them, in fact, the death in ESRD most of the time is a cardiovascular event. So we need to look up these patients, do a good cardiology evaluation. They may have depression, anger, psychological impacts. So these patients probably will require counseling or antidepressants. You find that they do much better when we have attended to this aspect. They are more engaging in the prehabilitation program. That does help, because that also improves the reserve. Untreated infection. So here there's one place in medicine where we need to ask leading questions, because they may not tell you. They continue kind of accept to live with certain infections. You may not find UTI in a woman coming for a transplantation unless you really see TLC in the urine. They may not complain, or they're not symptomatic. Thromboembolism because of repeated, fistulas or HD lines or permacats, and because of disease process as such. The pulmonary embolism is not a problem if it is a DVT in the lower limb or, in the pelvic veins. You can do a CT DVT protocol and you can see them. But problem is when they have a small thrombi in the lungs, they are not going to go away. They may have a saturation of 87, 89%, and you kind of accept them, put them under molecular heparin and accept them and go ahead and do the transplant, because this will take a long time to resolve. And higher lactates in ABG. Lactates, watch tell you that patient is undergoing anaerobic. So if we can improve the lactates preoperatively, if you can pick it up preoperatively and improve it, then you have a much better patient on table for transplant. So just a slide for robotic transplantation, because now this is the flavor of the season. So when it is a preemptive transplant, if the patient is an open case, it's really not a problem. Patient is flat, it doesn't matter if patient is full. But if you're going a robotic transplant with a head low, with pneumoperitoneum, and the patient has not been dialyzed, you're taking in a patient for a longer time in steep head low position, a full patient, you have that little chance that patient may go into pulmonary edema. So we need to optimize these patients for preemptive. In fact, in our hospital, there's a protocol that even though we may clear for robotic transplant, or preemptive robotic transplant, when they get admitted, the day prior, we get an ABG done. And if the ABG shows acidosis or higher lactates, our nephrologists go ahead and do a dialysis. We don't even have to ask them. So that's because this team has worked together for almost 12 years, and so we kind of do understand this aspect of it. So, and the other problem of robotic transplant, apart from the physiological, I'm sure this you all know from MAP and SVR. I've just put an orange color slide because whenever we have an interactive session with surgeon, we like to kind of share certain things which are a bone of contention between surgeon and anesthetist, that why are we asking for an ophthalmology review. So this slide, you can see the number of cases in this, 1,978,254 participants. Now, not necessarily that patient will be on treatment for glaucoma, or patient will be suffering from glaucoma, but if you are taking up, so I'm not talking about usual nephrectomy or usual surgeries, but if it is an ESRD long-standing, please do get an ophthal review, because you really do not want to have a patient who wakes up and says that his visual acuity has subsided, has worsened. So you can document it, you can take a high-risk consent, but at least medical legally you're on the safe side. So that is why in these patients, though the head low is not as bad as it is in a RARP, but we do ask for poorly managed ESRD patients. And of course, this is another challenge now in many corporate hospitals. There's a lot of medical tourism coming from underdeveloped, poorly developed countries. There's a challenge of time and cost. They have other comorbidities other than ESRD, which they have not attended to. We have had patients who have had to stent because they came to us with 99% blockade LAD, younger patients with no peripheral, no circulation, for them to manage that LAD block. So we stent them, they come back to us after 3 months, we put them on, we sometimes operate with dual antiplatelets, or sometimes we switch them into cangrelor. We are lucky to have that intravenous medicine today. We can put them for 24 hours, do your stop it 3 hours before the transplant, do the transplant, and again put the patient on dual antiplatelets. So these we probably don't really try it on Indian patients, but in international patients, we have to empathize with their restraints. So sometimes, as I said, we need to be courageous to take these steps. The modalities available to us, so basically echo, duodenum stress, TMT, SPEC, which is the older people will remember it as thallium, so now we call it SPEC. Pulmonary function test, always do an anti-pro-BNP level. We must always have an anti-pro-BNP level, below 75 and above 75 years of age. So above 75, if 450 is acceptable, below 75, 175 is normal. We accept patients with even 800, 900, 1000 anti-pro-BNP because, one is that they are in some kind of failure and the lung is full and the LV is bad, but also because there is some impact on the metabolism of these natriuretic peptides, so they do have a higher level of NT-proBNP. Chest CT wherever indicated, as I mentioned, ABG, and last but not the least is cardiopulmonary stress testing. We used to read about these being done in the United Kingdom, but we are lucky to have it in our country now. We've just got it in our institutions. I don't have much experience in this because we have not started using it as such. It is under the domain of pulmonologists. So cardiologists are not going to be happy if we kind of just do this and don't do the DSC, but yeah, this is available and it is considered to be a better test. You can have the better test because it provides assessment of the integrative exercise responses involving the pulmonary, cardiovascular, skeletal muscle systems, which are not adequately reflected through the measurement of individual organ system function. Like just a PFT tells you about lung, a DSC tells you about the heart, but this kind of tells you about the maximum oxygen utilization that the patient can achieve. And our aim is that, because we want how much oxygen utilization, that kind of determines the MET, the cardiopulmonary reserve. That actually is the definition of a cardiopulmonary reserve. So I'm hoping that with this in our system now, we will probably next year, if we have a conference like this, may be able to present some data. So as I said in my earlier slide also, that these three factors are the ones which determine patients. If the muscles are weak, whatever may be the cardiac or pulmonary reserve, patients are not going to be having much of an output. So this is also being used in several studies to see how patients do after transplantations. And they found that patients with CKD perform better than controls with heart failure without CKD. And they've suggested that elegant studies are warranted to delineate the complex and interrelated effects of cardiac, vascular, respiratory, and neuromuscular dysfunctions, as well as the physical activity of patients with CKD on their exercise tolerance. So the idea of this lecture today was that we must not just look up one art that, okay, EF is 20% or lung is, PFT is bad. We work on it a bit by bit and we ultimately find a patient with a reserve decent enough for us to do a transplantation. So we do need a team, as Dr. P.B. Singh also said earlier, that we need a team, and we have been lucky and blessed that we have been working together for almost 12 years now. So we understand each other, understand each other's idiosyncrasies, and we have a lot of protocolized things, and that is why probably we are having. So you need to have your own Marvel team to have the best results. And that's it. Thank you for your time.
Thank you, madam. Thank you very much.
One question. In our hospital, we have a patient with severe pulmonary hypertension. It's more than 72 millimeter of mercury. It has been rejected by anesthesia for transplant.
It depends on if it is a secondary hypertension. If it should not be a primary pulmonary hypertension. So you ask your cardiologist, does the patient have a congenital heart? Does the patient have any other issues? If it is a primary pulmonary hypertension, but mostly...
It's acquired, age is 36.
Yeah, so that is ESRD related. They can work on it. It'll be fine.
Are you doing a transplant in your setup?
Yeah, 80, 85, yeah, we do. If it's a 36-year-old patient with nothing
What is
else,
your protocol, just in few lines?
So if it is a 36-year-old person, we have done all the workup, and their person should be dialyzed well. So when you dialyze well, you will get a nice trend of NT-proBNP also. Once the NT-proBNP starts coming down, you will also find that the pulmonary artery hypertension in the subsequent echo has also come down. And you transplant these patients, I would probably be hesitant to do a robotic, unless I've had a major argument with Dr. Anand Kumar, so mostly, sir? But mostly I would like to do this open, and yeah.
Thank you.
Sanai, anything else? I would do this case. I would not say no. 36-year-old, I would not say no. If it is not primary pulmonary hypertension.
Thank you. Thank you very much.
Thank you very much.
Now we are going to have lecture by Professor Kazunari Tanabe, and he is Professor of Urology and Transplantation in Sennen Kamakaran General Hospital, Japan, and he is world-renowned leader in ABO incompatible transplant, and most of the protocol was developed by him. And there is one more common thing is that he is urologist and robotic surgeons. And actually we both had training in Cleveland Clinic at the same time. He was in uro-oncology and I was with Dr. Andrew Novick in transplant and renovascular hypertension. And I have heard him number of times, and every time we learn something new. And he is always doing a lot of research to come out with the newer and newer things in ABO incompatible transplant. And somehow ABO incompatible transplant is quite popular in Japan and in India, and pair exchange program has not well developed in these two countries, and other countries are moving towards the pair exchange program. So with that introduction, I would present you Dr. Tenebe. Dr. Tenebe, please.
Thank you very much. Thank you very much. It's my great honor to be here and share this information with the colleagues in the Indian. Thank you very much. So today's my topic is our journey and the protocols for ABO incompatible transplant and current perspectives. So since a serious shortage of organ donation is still biggest barrier to increase transplant number in Japan, ABOI transplant is the effective alternatives. And of course, the KDP is currently the most popular alternative for ABOI or HLA incompatible kidney transplantation in some countries, but including Japan, some countries is very much difficult to do this. And also the outcome of ABOI transplant is early experience back in 1980s or 1990s was not good compared to ABO compatible cases because of the heavy conditioning and immunosuppression. However, recently the improvement of desensitization and immunosuppression protocols make ABOI easier and safer than in past. So back in 1969, 12 ABO incompatible kidney transplantations were performed without any desensitization, of course. And then they noticed that after transplantation, antibody titer increased so fast, rapidly. And 1981, the Dr. Srapak is in England. He performed the ABOI cadaver kidney transplantation accidentally, it's a mistake. And they performed the plasma exchange to remove antibody, blood group antibody after transplantation, and the graft functioned well despite ABO incompatible kidney transplantation. This is a mistake, but this is a key clue to the open to the ABO incompatible kidney transplantation. So back in 1987, Dr. Alexander, they performed the 26 ABO incompatible living donor kidney transplantation using the donor-specific platelet infusion, substance A or B infusion, plasmapheresis, splenectomy, cyclosporine, azathioprine-based immunosuppression, and ALG or ATG. And they found that 2 years graft survival rate is almost 90%. So we summarized the data at 1994, and at the time, the 155 cases of ABO incompatible kidney transplantation were reported, and 83% of graft survival in the splenectomy group, and 31% graft survival and non-splenectomy group. So from those data, splenectomy was considered to be the mandatory for ABO incompatible kidney transplantation. This is our protocol at that time. Back in 1989, we started after ABO incompatible kidney transplantation. So it included desensitization protocol, include the DFPP or immunoabsorption with a splenectomy. And immunosuppression includes cyclosporine, azathioprine, ALG, methylprednisolone, and then deoxyribonucleic with a local irradiation. They're quite a heavy immunosuppression. And at the time, the 3 years graft survival rate was almost 80%, which is lower than the compatible cases at the time, but it was acceptable transplant outcomes. And now, as you know, in the United States, KPD is the best option for instead of the ABO incompatible and the HL incompatible kidney transplantation. But still, they need ABO-incompatible or desensitization protocols to essential element for KBD optimization protocols. But there are a lot of drawbacks of ABOI in many literatures. Need desensitization, high incidence of bleeding, or need heavy immunosuppression, high incidence of rejection, high incidence of infectious complications, poor patient graft survival, high cost. To solve those drawbacks, the less desensitization is very important. So how often ABOI perform in Japan? The number of ABOI living kidney transplantation is steadily increasing, and in the last decade, 30 to 40% of living kidney transplantation was ABO-incompatible kidney transplantation. So ABOI kidney transplant has a strong impact on expanding the donor pool in Japan. Long-term graft survival rate is here, 20 years, almost 70%, 60 to 70% graft survival. 30 years, about 50% graft survival rate in compatible and incompatible cases. And since 2005, we started to use rituximab, and then the 10 years graft survival rate is about 90%, and there is no differences between two groups. This is a little bit old data, but the surveillance data, so not the champion data in Japan. And number of the incompatible kidney transplant increasing so rapidly. And patient and graft survival is shown here. 10 years patients graft survival is about 70% for surveillance data. And after 2001, which we started to use the tacrolimus and Cercept, the outcome improved significantly, and the 10 years graft survival rate 90%. And patient survival, and then the graft survival rate 81% since 2001. So basic immunosuppression is very important to improve the graft outcome for ABO-incompatible kidney transplantation. So the desensitization in incompatible kidney transplantation, there are a lot of different modalities. Plasma exchange, immunoabsorption, regular plasma exchange, or maybe DFPP or selective DFPP. Or those plasma exchange all remove all antibody isotypes. On the other hand, glycosob, only A or B antibodies, protein A, mainly IgG, several SOB, mostly antibody isotypes. So there are a lot of different options. But the problem is acceptable anti-blood type IgG antibody titer at transplantation. Most of the institutions, they are accepting 60 times dilution or less. We are accepting 64 times dilution for regularly, sometimes 256. This is the data from Europe. Graft survival and the patient survival is quite good. There is no differences compatible and incompatible cases. But if you look at the graft survival by anti-CD20 antibody induction, obviously there is significant differences between two groups. Anti-CD20 induction group showed a 94% graft survival rate, but a non-anti-CD20 antibody induction group showed 88%. So this data shows suggesting that a need for anti-B cell therapies in the setting of ABO-incompatible kidney transplantation. So this is another data from the other countries. There performed almost 300 cases of ABO-incompatible kidney transplantation and matched the control of a compatible living kidney transplantation and a compatible deceased kidney transplantation. You look at this, the patient survival of incompatible cases were nothing different from the compatible cases. Cumulative incidence graft failure is incompatible case, but equal to the ABO-compatible deceased kidney transplantation, which is quite good. And also we looked at the baseline characteristics of ABO-incompatible kidney transplantation according to the induction therapy. Here, the rituximab alone, rituximab, basiliximab, and alemtuzumab. And again, the graft survival tend to be superior for rituximab, basiliximab treatment, and compared to the rituximab alone treatment. And this is another data from Korea for elderly patients for ABO-incompatible kidney transplantation. Again, there is no differences, death census, graft survival, and patient survival rate. BPAR or infection-free survival is a little bit higher than the compatible cases, but still there is no big differences between among this data. And also this is data from United States back in 2020. First year, there is no difference between two groups. But if you look at the 12 years after transplantation, incompatible cases better than compatible cases. This is very interesting findings because the incompatible cases, we use the B-cell depleting treatment, so probably antibody immediate rejection for a chronic phase is a lower incidence of incompatible cases. So pathophysiology ABO-incompatible kidney transplantation, this is very interesting data. A2O incompatible kidney transplantation, if you look at the antibody titers for a long time, anti-A antibody still stayed very low levels compared to the anti-B antibody increased so much. If you look at the B2O kidney transplantation, again, anti-B antibody stays very low levels for a long time, but the anti-A antibody increased at very high levels. If you look at the compatible cases, there is no reduction of the anti-A or anti-B antibody titers for a long time. This is a one interesting case. Primary kidney is unknown. Being compatible kidney transplant, very good condition, but he stopped to come to clinic and stopped to take immunosuppression. And he showed up the endocellular renal disease. And then we looked at the anti-B antibody titer. At the transplant, 32 times dilution, but after transplant, less than 1. But at the introduced hemodialysis, it was IgM or less than 1. That means donor blood type specific clonal deletion was occurred. So role of rituximab in ABO-incompatible kidney transplantation, rituximab seems to be a very important element in immunosuppression in ABOI, since it could delete B-cell clone against incompatible kidney producing cells. So yes, this is the some protocols, but B is our protocol. It's a very simple, and just a rituximab injection a couple of times plasmapheresis and the transplant. And again, we are accepting the 64, sometimes 256. And this is a very important point to reduce the number of the plasmapheresis and improve the desensitization protocols. If you look at the number of pre-transplant DFPP or plasma exchange, last decade it was decreased dramatically, and then nowadays we do maybe 0 or 1 or 2 times at best. So immunosuppression, low dose FK, low dose MMF, rituximab, again low dose injection just before transplantation, basiliximab, no limitation of baseline antibody titers, blood antibody at time of transplantation 64 times, no plasma exchange baseline titer 64 times dilution or less, no post-transplant prophylactic plasma exchange nor IVIG. So very much simple. And number of plasma exchange according to the baseline antibody titers here, the 70% of cases are less than 32 times or dilution. 6% of recipients with 32 times or less antibody titers underwent 1 to 2 times, 0 or 1 times the plasma exchange. So most of the patients, they don't have much plasmapheresis. If you do the 2 or more times of plasmapheresis, you have a bleeding tendency. Infectious complication, again, in the summary data, they show the high incidence of infection, but some data show the no significant differences between ABO-compatible and incompatible cases. And this is our data. There is no differences in terms of the infectious complication between compatible and incompatible cases. So infectious complication, the current minimization, desensitization, the induction, immunosuppression could reduce the incidence of severities post-transplant infectious complications. Cost. This is another important factors. We checked cost between 2013 to 2014. graft and patient survival is good. Rejection less than 10%, and biopsy-proven rejection is a very low level, 10% in the compatible cases, and the incompatible cases, 20%, which is a little bit higher. And if you look at the hospital cost, which is higher in incompatible cases because of the desensitization protocols, but 1 year, second year, total 2-year medical cost is exactly the same. So in conclusion, ABO-incompatible solid organ transplant could be done with the excellent outcome and the current simplified desensitization, immunosuppression, and significantly expand the donor pool. The clonal deletion of incompatible blood type antibody producing B cells could be an important mechanism of excellent outcome of ABO incompatible kidney transplantation. So nowadays we give the rituximab low dose 2 weeks before transplant, and just before transplantation we give the additional 100 milligram of the rituximab to block the donor-specific clonal expansion of the donor type of blood type antibodies. Thank you for your attention.
Open for discussion. One question so if you have done ABO-incompatible transplant and patient develop antibody-mediated rejection, then how do you treat it at that stage? What is your protocol for treating antibody-mediated rejection?
Well, most of the time we use the additional rituximab injection, and also the mainly IVIG, high dose IVIG. 2 gram to 4 gram per kg of IVIG, we use that. So 50% of the antibody-mediated rejection, mainly the antibody-mediated rejection was caused by HLA incompatible cases. There is no antibody-mediated rejection based on the anti-blood group A or B antibody based. So again, the ABML treatment is against the HLA incompatible kidney incompatible antibodies, DSA. And again, we use the rituximab and the high dose IVIG. 50% of patients disappear the DSA after the treatment. But
so if the patient has developed in immediate post-operative period and patient already had received rituximab, you'll repeat the rituximab, or you will test the C19 level?
No, but fortunately, after ABO incompatible kidney transplant, right after that, the antibody-mediated rejection, which is a very acute type of antibody-mediated rejection, ABMR, is very, very rare. We don't have such a case recently. But the only one concern is TMA, thrombotic microangiopathy. It looks like ABMR, but most of the rapid graft dysfunction after ABO incompatible kidney transplantation, other than surgical problem, the TMA. So we always give the eculizumab for that case. Most of the cases were rescued by eculizumab. Just 1 or 2 injection of the eculizumab.
And you don't do the plasmapheresis?
No, you don't need to. But if the patient has ABO incompatible plus a cross-match positive, sometimes we have. In that case, we have to be very cautious about the ABMR caused by HLA incompatibility. But most of the time, we do a desensitization for cross-match positive patient. So antibody levels at the time of transplantation is very, very low. So it shouldn't cause the acute type ABMR. So that's the reason why last maybe 10 years, we don't have acute type antibody-mediated rejection after ABO incompatible kidney transplantation.
And so, do you frequently monitor the ABO antibody titers in the post-operative period? And if they are rising and patient is doing well, do you intervene or you just watch them?
Practically, I don't need to do this, but academically, we monitor the antibody titers for a long time because of the we are checking the how the B cell clonal deletions happens. So Even though they is increase, you don't need to do any treatment unless the graft function is stable.
Any questions from audience?
So TMA is very, very bad. So nowadays we try to give the prophylactic low dose of eculizumab at the time of ABM-compatible kidney transplantation.
In all patient or in specific some patient? You give in all patient or you give in?
Mainly in my institution, we have a lot of Jehovah's Witness. Do you know that? That religion, they refuse blood transfusions at all. So we cannot do the plasma exchange. So sometimes we have to do a very high titer of the antibody titers. So we just inject the eculizumab, low dose eculizumab at just before revascularization of the kidney. And it works very well. So sometimes we accept the 256 or maybe 1,000. And then we inject a small dose of the eculizumab at the time of transplantation. Nothing happened after transplantation.
Thank you. Yeah, please go ahead.
Sir, in ABO titers, do you give importance to IgM titers also, or you follow just IgG titers?
This is a very good question. Only the IgG titer is very important. IgM sticks to the endothelium, vascular endothelium, and cause big trouble. But IgG titer, IgG is much important for kidney transplant.
So you mentioned splenectomy in almost every patient. It was at the same time or before transplant?
No, splenectomy, we don't do splenectomy at all right now. Till 2004, we performed a splenectomy. And since 2005, we used the rituximab instead of the splenectomy. And at the time, almost 20 years ago, we injected different doses of rituximab, 10, 50, 100, 200, 375 per square meters. And we take out the spleen after the injection. And we check the B cell population. And more than 50 milligrams per body of the rituximab eliminate all B cells in the spleen. So we decided to use 200 milligrams of rituximab since that time.
Okay. Thank you.
Professor, your outcome with the idiopathic TMA after ABOI. Your experience with idiopathic TMA which develops after ABOI incompatible transplants.
Idiopathic what?
TMA basically.
TMA, okay.
And the outcomes. And how do you tackle it?
If the patient had idiopathic TMA, we use the eculizumab for prophylactically. So nothing happened, most of the cases.
Thank you.
Thank you very much.
Okay, thank you.
For the wonderful lectures. Now we are going to have another lecture by Dr. Kulwant Singh. He is a senior consultant at Max Hospital in our department in nephrology. He is going to speak on role of ATG in living donor transplant Indian experience.
Good morning, chairpersons and all the delegates. First of all, I would like to congratulate the organizing team, Dr. Anant and all his team for all the hard work to make this event a grand success. So today I will be speaking on the role of ATG in living donor kidney transplantation and what is the Indian experience on that. So if we see the NOTO data, we can appreciate that every year the number of kidney transplants are increasing in our country. In 22, we did almost 12,000 of kidney transplantation, out of them 10,000 were living donor. So whenever one living donor is involved, emotions are so high that the responsibility on the shoulders of transplant team, whether they are surgeon, nephrologist or anesthetist, are very high to give best of the results. So here come the role of induction. So induction is just like the opening batsman. If they will play well, the course will be very smooth. So it is the first phase of the treatment. So these are the drugs which are prophylactically administered in the perioperative period or immediate post-transplant period. The idea is to give one first hit which should be acute enough and short term so that it can prevent at least hyperacute and early acute rejections. So the classical indications for the induction therapies were when there are highly sensitized recipients, When second transplant is there, historic cross-match positivity is there, poor HLA matching, marginal or old donors are there, pediatric or young recipients, and when we expect there will be a higher ischemia time. So why induction agents are required? They are not just required to decrease the incidence of acute rejections. Nowadays, we are basically using them to minimize our maintenance immunosuppression in long run, so that we can taper our steroids early, we can decrease the levels of CNI, so that we now encounter less of acute and chronic problems with these calcineurin inhibitors. So basically, when we talk of induction agent, they are basically divided into two arms. One is the depleting arm and one is the non-depleting arm. Depleting means where they totally deplete the T cells. So we have 4 molecules in that: ATG, OKT3, which is now not available because it was murine, much of side effects. Lemtuzumab, only few centers in India are using. ATLG, or known as Grafalon, we are recently started using from last 6 to 7 years. Non-depleting arm are basically which doesn't deplete the T cell, they basically act on the IL-2 receptor, block it and block the activation of T cell. So when we compare them head to head, we see that the efficacy of depleting antibodies is far better than the non-depleting one. But the efficacy wise they are better, but the safety profile of IL-2 receptor antagonist, which is basiliximab or declazumab, which was available earlier, was far better than the ATG group. So to understand this, we have to understand this diagram. So this is our helper T cell. Any antigen presenting cell present the antigen to the helper T cell. So this is the first pathway where our T cells start activating. So when T cell get activated, it produces IL-2, which further activates the T cell and helps in the production and proliferation of the T cells. So our ATG and corticosteroids basically act at the first step. So their response rate, their efficacy and even side effects are higher. Whereas our IL-2 receptor antagonists, they act at the second stage. That's why they act only on the activated T cell, not on the resting T cells. So now what is the difference between thymoglobulin and ATLG, or what we commonly say as Grafalon? Some people say that they are nearly similar, but there are a lot of differences in them. Both of them are polyclonal gamma globulin. Both of them are T cell depleting agents. Thymoglobulin is produced basically by immunizing human thymocyte into the rabbits, whereas ATLG is produced by infusing human Jurkat T lymphoblastic cells into the rabbits. So one is where we are introducing central T cell and one is where we are introducing peripheral T cells. So head to head, if we compare them, thymoglobulin act against both T cell and B cell, whereas our Grafalon act only against the activated T cell. Here we can appreciate that T cell cluster differentiation antigens are higher in the thymoglobulin group. Thymoglobulin acts on multiple targets. ATLG is acting only on the activated part. So basically thymoglobulin acts on all the T cell, whether they are resting, whether they are activated, whether they are memory T cell, whereas ATLG is more powered to hit the activated T cells. The dose of ATG generally which we use in Indian setup is 3 mg per kg. Grafalon we are using 6 mg per kg. But apart from that, there is one thing which takes ATG to a leap ahead. That is production of Treg. Tregs are basically T regulatory cell. They are the special cells which have the expression of FOXP3 on them. So the role of this T cell is to give tolerance to the graft. So on one side ATG decreases the T cell, on another side it increases these T regulatory cell which helps in the tolerance to the graft. It's just like a ABO incompatible graft. We say that after some time even our titers will rise, but the graft has already accommodated. So similarly this effect is given by ATG, that even antibodies are rising, but due to these T regulatory cell the graft tolerance develops. So when ATG was compared with basiliximab, both in short term and long term, it was seen that the effect of ATG in terms of biopsy proven acute rejection even when they were studied at 1 year or they were studied at 5 years, was far better as compared to basiliximab. This is one of the largest registry where living donor kidney transplant patients were retrospectively analyzed. Almost 76,000 patients were analyzed, who were then continued on tacrolimus mycophenolate with or without steroid. And their primary outcome was seen at 1 year. This is a study from the United States. And what they found was that basiliximab induction was not associated with better outcomes compared to no induction. Whether you give induction or not, and on one side you give basiliximab, the results were similar. But ATG was proposed to be preferred induction, especially in the scenarios where we are thinking of steroid removal or we are thinking of early withdrawal of steroids. What our guidelines say? These are the guidelines which we follow. Though they are very old, they were published in 2009 and maybe the data they analyzed were older than that. So still it recommends that some or other kind of induction agent must be used in all renal transplant patients. They recommend that IL-2 receptor antagonist basiliximab should be the first line of induction agent. But in the patients who are high risk, we should go for T cell depleting agents. So now coming to Indian data, I have selected few studies. First one is our own presentation which we presented way back 10 years back in 2013 from Sir Gangaram Hospital, New Delhi, where we retrospectively analyzed almost 180 patients and we followed them for 3 years. So what we can see here is that in donor characteristics, almost 50% of the patients had more than 4 HLA mismatch. That means they were high risk, and half of them were having haplomatch. ATG mean dose in that study was 2.5 plus minus 0.6 milligram per kg. This was the graft survival which we analyzed after the 3 years. So almost 90% of the patients were having a good graft function at the end of 3 years. We lost 2 grafts early, one due to ACN and one due to AMR. In late period, we lost 4 grafts, 2 were them due to transplant glomerulopathy. And the patient who were having higher creatinine value, we sub-analyzed them and found that the donor age in that patients were higher as compared to the average age of the cohort. When we analyzed the early infection, we were not surprised, we were expecting it. The number of UTIs were very high. Almost 50% of the patients were having UTIs in the early period. Maybe that time we were using higher dose of tacrolimus, like today we use 0.08 to 0.1, that time we were using 0.12 to 0.15. We were keeping digestants for a longer time, we were generally removing at the end of 3 to 4 weeks. We are lucky enough that we don't encounter such high, or even I can say Dr. Anant must be having exact data. Very rarely we see UTI in our transplant setup. Maybe because now we are using less of immunosuppressant, surgical techniques have improved, digestants are being removed early, or we are doing a robust pre-operative evaluation of all the recipients for their urodynamics and everything. So the incidence now is very low. Even in the late part, the patients who had UTIs in early period, they kept on coming again and again due to the recurrent infections. One patient we lost due to CNS lymphoma. Patient survival in that study was 96%. Now coming to second study, this was recently published in Indian Journal of Nephrology by Jha et al. Here they studied the role of induction in haplomatch related low risk living donor recipients. Like when there is a transplantation between siblings or between the parents or between the kids. So they studied 350 patients retrospectively. 143 patients were not given any induction, 112 patients were given basiliximab, 95 patients were given thymoglobulin. So they head-to-head compared the patients between no induction and thymo, no induction and basiliximab, and between basiliximab and thymoglobulin. What they found was that in terms of biopsy proven acute rejection, the number of rejections, you can see the blue line, number of rejections in thymoglobulin group was significantly lower as compared to no induction and basiliximab. In basiliximab and no induction, the number of rejection was almost similar. In terms of infection, all these arms were comparable. in terms of CMV infections, it was amazing to see that the number of CMV infections were actually less in the patients who were given ATG. Maybe they were religiously given CMV prophylaxis, that must be one of the reasons. So they concluded that even in low risk haplomatch related donors, biopsy proven acute rejection was significantly lower with thymoglobulin as opposed to no induction of basiliximab group. Basiliximab did not provide any benefit over no induction. So they concluded that if you are thinking to give basiliximab or you are confused between no induction, so no induction should be the better option because it doesn't provide any benefit. This is a study which was published from Medanta in Indian Journal of Nephrology, where they head-to-head studied between the grapholon and thymoglobulin. It was a single center retrospective study where they did the median follow-up for around 36 months, and they found that the number of rejection in ATG was less as compared to grapholon, and the side effect profile, whether infections or other thing is considered, that was comparable. So they also did the cost analysis between the groups. They found that the cost of grapholon is low, but the dose of grapholon requirement is double. So the cost of grapholon in this study or otherwise also when we routinely use is higher than rabbit ATG. This is another study, Indian study from Cuttack, outcomes in live related allograft recipient and different modalities of induction. So this is one of the studies from government hospitals. So where they studied almost 150 patients, 50 patients were given basiliximab, 50 patients were given no induction, 21 was given grapholon, 21 was given ATG. They concluded that in low risk group, induction modalities does not provide any advantage over no induction. Whereas in high risk group, all the induction therapies had a similar outcome, but the patient who received ATG or ATLG had higher incidence of septicemia, and they lost many patients due to that. This is another study which was presented from our institute only by one of the transplant fellows last year in ISOT Kolkata, where they retrospectively analyzed 2 doses of ATG, one lower dose from 2 to 2.5, actually the median dose was 2.1, and the standard dose of around 3 milligram per kg. So primary objective is to study the occurrence of acute rejection between both the arms, and the secondary outcome was to see the other parameters like infection. So almost 200 patients were enrolled and they were followed up for 5 years, and they were comparable in both the arms whether they were recipient or donors, and what the authors found was that in terms of acute rejection or graft survival or patient survival, both these arms were equal, and the infection rates were also comparable in both the arms. They finally concluded that the lower dose was non-inferior and comparable with the standard dose. So conclusion is that now there is proven data that ATG decreases biopsy proven acute rejection and improves the long term graft survival. We are only worried about its complication. So the side effects, first side effect is leukopenia, that is generally transient. If you follow absolute lymphocyte count with experience, you are able to judge whenever the leukopenia is bound to happen, and you generally avoid your second or third dose, or you can stagger them to some other date. Now coming to infections, when I prepared for this presentation, I found 2 types of data. One was from the government hospital, one was from the private hospitals. The government hospitals always showed that the infection with ATG and ATLG was higher, whereas the private hospitals showed that the data of the infection is comparable. Maybe it depends on the set of patient which we are receiving. Maybe at private corporate level hospital we are receiving a good healthy or preserved patient, which is not the case in government hospitals. So how we can prevent infections? We should vaccinate our patients prior to transplant. We should give the prophylaxis of Septran and Valganciclovir. We should try to minimize or maintenance immunosuppression. We should decrease the steroid dose as early as possible. PTLD, I personally have not encountered PTLD in last 10 years. Very rare incidence of PTLD in India. What we can do to avoid that, like we are doing the CMV serology, we should go for EBV serology also. If our donor is EBV positive and recipient is EBV negative, that time we should not give induction. If we are giving induction, then we should monitor that patient every 3 monthly for the EBV PCR. If the titers are rising, we should decrease our immunosuppressants. There is also a role, like we are giving valganciclovir for CMV prophylaxis, we can give a long-term acyclovir for EBV prophylaxis also. So what is my P drug concept? P drug means personal drug concept. This is a little bit irrational thing which you can avoid. Like for a same situation, I may be using amlodipine, but some physician may be using cilindipine. So if I have a prospective transplant patient who can afford and tolerate induction therapy, whatever risk profile he is having, whether he is a low risk haplomatch or he is a high risk patient, keeping in mind his previous infections and general well-being, I would offer him ATG only. If he is a low risk, I will opt for a low dose 2 mg per kg dose divided in 2 doses. If he is a high risk, then standard 3 mg per kg which we are using for our Indian patients divided over 2 to 3 doses, but keeping an eye on the absolute lymphocyte count. So the take home message is induction is like a wedding. It can be a boon for many, but it can be a curse for few. So we should individualize our patients, we should individualize them whether they need induction, what dose of induction they are requiring. We should optimize our immunosuppressants, maintenance immunosuppressants accordingly. We should not be afraid of remote infection which may occur, which may not occur, or which can be controlled by smaller antibiotics. But we should try to offer some kind of induction to them depending on our institutional policies, whatever experiences we have. So with this slide, I thank you all. Too much of everything is bad, but too much of good induction is barely enough. Thank you.
Thank you, Dr. Kulwant Singh, for excellent lecture. And one thing I just like to comment, PTLD is not so uncommon in India.
Yes, sir.
Currently, we have 5-6 patients under treatment, but as you follow them for longer period, more and more patients you will encounter. So is there any other question? Otherwise, our operative workshop is ready. But if anybody has questions, you are most welcome to ask.
Sir, since last few years, when nephrologists switch from basiliximab to thymo, it is my genuine observation that incidence of post-transplant UTI has gone up. We do not put in stent routinely. Stent is rarity in our center. So in spite of no stent, whosoever gets thymo, many patients of thymo get UTIs. What is your comment on that? Is thymo making them prone to more UTIs?
Sir, thymo generally make patient prone to all the infections. It's not UTIs, even LRTIs and all the infections. But I personally feel that if we have done the proper evaluation for the patients in terms of their urodynamics, you generally encounter less of UTIs. I joined Max Saket in January. I was surprised to see very low rate of infection, at least in acute period, because I don't know which patient is coming to which consultant in the follow-up, but in the acute period, the number of infections is very less. We generally have a fight with Dr. Anant when he sees the recipient in the pre-transplant period and he orders cystoscopy or urine for PCR, that why you are investigating him more. But I think these small things definitely make a difference.
Dr. Rahul?
We all started with an ATG dose of 6 mg per kg. Gradually it has come down to 3. Now at my center I use a 2 mg, even 1.5 mg for a low risk patient.
Yes, sir.
And CD3 count is a very important clinical marker when you can judge on a daily basis. The CD3 count is less than 50. Then you need not to give another dose of an ATG. What's your practical experience or any experience?
Sir, we are following 200, sir. So whenever, and also see the fall in trend. Like the day before yesterday is 200 and suddenly it decreases to 100. That means the next day it will fall further. So we hold the dose of ATG. We don't give that second or third dose. We generally stagger it to 4th day whenever the titers rises up.
So basically for 7 days you maintain this and then obviously things will take over.
Yes.
Thank you.
Actually in Sanjay Gandhi, we used to do routinely absolute T cell count. And when it was And the second dose is only given when it was above 50, and you will be surprised many patients received only 2 doses of
Yes, sir.
ATG, and the interval between maybe for 1 day and 7 days, and it was very efficiently used. But T cell count was done daily at that time.
Yeah, that's a very important marker. I mean, we don't
Yes,
do it
sir.
routinely. One should do. One start doing it, then ATG dose will gradually reduce, and we'll get more data maybe.
Okay,
in
thank
time.
you. I think the operation is ready, and the first
Thank you.
case is we are showing is the robotic kidney transplantation. The recipient has a very small upper polar vessels. We will see whether it will be sacrificed or reimplanted. So it is all ready, and we will go for the operative session. Thank you.
Thank you, Dr. P.B. Singh, Dr. Anand Kumar sir, Dr. Tanabe, and Dr. Raj. So we'll be heading to the live operative session right now. Before I call on the chairs, I'd just like to brief you about the case that we are currently operating. So we have a 28-year-old female donor who's donating one of her kidneys to her husband, who's a 35-year-old male. The donor has a BMI of 30.05, while the recipient has a BMI of 23.6. It's an ABO incompatible transplant where the donor's blood group is AB positive and the recipient is O positive. The pre-op titers in the last week of July were 1:256 in IgG and 1:128 anti-B IgG. The donor is a 28-year-old female, like I said earlier. Our routine labs were all normal, and she only had a comorbidity of hypertension, which was also recently diagnosed. There was no significant clinical finding on examination. Her DTPA showed a GFR of 49.5 on the left hand, in the left kidney, and 50.2 on the right side. On the CT scan, both the left and right kidneys had 2 arteries, the right one being more prominent, supplying the lower pole, whereas the upper polar left-sided accessory artery is not clearly visible. If you can localize on this CT, there's one upper polar artery which has an ostial diameter of 1 mm. The recipient is a 35-year-old male with a BMI of 23.6 and a blood group of and O positive blood group. He was initiated on dialysis just 2 months ago and has been on twice weekly dialysis with a native urine output of less than half a liter per 24 hours. The flow cytometry and CDC cross match were both negative, and he received a desensitization protocol of 120 mg of rituximab 2 weeks prior to the surgery, and 48 hours prior to the surgery his antibody titers were 1:32 IgG for both anti-A and anti-B. So we started him on tacrolimus and mycophenolate immunosuppression 48 hours prior to the surgery, and he received injection basiliximab 20 mg in the OT today along with 500 mg of solumedrol. So the donor has been planned for left lap transperitoneal donor nephrectomy, and we'll see whether the vascular reconstruction is required for not for the upper polar accessory. And the recipient has been planned for robotic right renal allograft recipient surgery. So for this operative session, I'd like to call on the following chairpersons, please. Dr. Manas Ranjan Pradhan, Dr. Bijay Man Singh Katwal, Dr. Muruganandam, and Dr. Priyadarshi Rajan. Sir, if you can please join us on stage, please.
So are we connected to the OT? So who are the surgeons? Who is doing the donor nephrectomy and who is doing the recipient? May we know the name of the surgeons?
So currently the donor is being done by Dr. Pragnesh Desai, and Dr. Samit is in the robotic OT. Dr. Anand will be going to the robotic OT in some time.
So is Samit connected with us?
We are trying to connect, sir.
So on behalf of the organizing committee, I extend a very warm welcome to all the delegates to this academic feast, and special welcome to Dr. Tanabe for being here, being our guest.
And every time I listen to his lecture, I get more stimulated about the ABOIs, and I keep I keep seeing the bar of titers rising. So such a good sight to see you're transplanting even at 256. So this is an ABO incompatible transplant, and it's being done with the robotic way. So how many of us are convinced with robotic transplant and we want to practice robotic transplant in terms of the future, or how many of us think that robotic transplant is going to be the future of kidney transplantation? Can we have a poll in the house? How many of us believe that robotic transplant is going to be the future? Wonderful. So it's a lovely surgery, and once you cross the initial learning curve, I think this is the future of transplantation. As Dr. Samit is beautifully dissecting the bladder, he has dissected the bladder for the anterior ureteroneal cystostomy, and probably is going to make the tunnel for the mucosa to pout.
Hello.
Hello, Samit.
Aji sir, good morning.
Good morning. How are you?
All the chairpersons.
Good morning.
And we welcome you all to the operative session. My name is Dr. Samit. We have just started off about half an hour ago. You must be seeing us on the screen. We are doing this patient a transperitoneal robotic kidney transplant surgery. If the cameraman is kind enough to show the position of the ports, do you see the outside view?
Yeah, it is visible, but we need to enlarge the caption.
थोड़ा बड़ा कर दीजिए उसको और पास से.
Swap the screen. So which system is it? This is XI?
It's an XI Da Vinci. The advantage of XI is that the port placement can be in a straight line. You don't need to work too hard for the port placement, whether the instruments are going to clash or not, because it's got a boom which aligns the arms according to the center. So we have placed 5 ports. 4 of them are robotic and 1 is assistant port on the right hand side. Center is the camera port, to the right is scissor, left is bipolar, and a ProGrasp is in the last 4th arm. So this is the port placement. We started off initially with the creating pneumo using Very's needle and then putting in ports. You incise the peritoneum over the vessel slightly on the medial side, because it anyways goes to the lateral once you cut it open. Then you go straight between the artery and vein, this part, so that most of the lymphatics can be kept laterally to prevent lymph leak. And then you, as you can see here, free the artery and vein all around for your anastomosis. You can see the artery here and the vein all around. Once you do that, you make this flap, so that later once you put the kidney, you need to cover the peritoneum back on the kidney. So you make adequate space in the iliac fossa, enough for your kidney to sit in. Particular care must be taken to take care of the ureter here on the medial side of the flap. So you free part of flap so that the ureter is down when you are clipping both the things together. And then you drop the bladder a little. We have done little more this time to show everybody very clearly. Otherwise, you don't drop from here down. You drop it till here on one side, and you make a detrusor tunnel from here to here to do the ureteric reimplant, anti-refluxing when possible. If there are any questions, I'd be happy to answer.
So I can see your flap is just a lateral flap. Routinely, what we make is a T-shaped flap. So
yeah, you're right, sir. There are many ways to do this flap. Some drop the bladder from here and make the whole flap from this area down, and then in the end do a suturing. We find that this is the most convenient because it does not take much of your time, and they are easy to approximate once you put the kidney back in. You don't have to close the whole thing. We don't close the whole thing. We leave a part of this window open. If there is some lymph leak or anything, that can be absorbed through the peritoneal cavity. You can say the disadvantage that if there is some bleeding, it can get into the peritoneal cavity, yes. So, but this method has served us well for last about 450 cases, so we are okay with that. But little changes are welcome, yeah. According to your own preference, you can make those changes. I agree completely.
So we are almost all set with the recipient. So Samit, just for the sake of our experience or our knowledge, just let us know how is a donor nephrectomy different in cases of a robotic transplant versus a normal transplant? What are the precautions or extra any special steps you take in the donor nephrectomy when you're putting a kidney?
We'll show you as well. The donor nephrectomy surgically is the same. The difference is on the bench.
Yeah, benching.
Because when you are doing an open transplant, everything is in front of you, so a little bit of oozing or small bleeders, you can tie it off once you declamp, you're done with the transplant. Because the kidney is in front of you, you can move the kidney medially or laterally, and you have the liberty of doing that. In robotic transplant, we don't want to fiddle with it once we have done the declamping. So on the bench, all the lymphatics and small vessels are clipped or tied. Even the fat around the kidney, when we remove it, we tie it. Nothing is left for us to, take care of it later. The other important thing that we do in all our robotic cases is do a leak test. Push custodial through the artery, clamp the vein with the forceps gently, and see whether there are any leaks or not. So, and we spatulate the artery. We spatulate the ureter also at bench because in our initial experience, it was difficult for us to do it inside the recipient robotically because you may tend to, get confused about the orientation of the ureter. We also take a small suture at the artery and vein on the upper side to help us, manipulate the artery and vein while suturing, because we don't want to catch hold of the artery or vein with these instruments because they don't have a haptic and you don't know, you can crush the intima. So these are small little modifications that we'll show you when we are doing the bench after we take out the kidney. Because we would like minimal manipulation inside the recipient once the kidney is put in and it is declamped and it is perfused well. Because manipulating the kidney here or there using robotic instruments can injure the kidney. So whatever needs to be done, kidney needs to be perfect at the bench when we put it in the recipient. That is the difference, sir.
So you're going to make the tunnel?
Yes, sir. So we are going to make a tunnel. So first we mark it. Because most of these patients, as you can see, compare it with the donor on your screen, other screen. The other side looks, more reddish because of good hemoglobin. This patient has hemoglobin of 7, so you can see the tissues are a little pale.
Plus she has received plasmapheresis also.
Yeah, plasmapheresis also, so you can see them a little watery and edematous.
So what are the current titers of the recipient?
1:8. Last titer was 1:8.
And while the case was being presented, I saw that the dose of rituximab was just 120 milligrams. So is there any specific criteria for that dose? Or routinely we give 200 or 500 milligrams. So why was specifically 120 milligrams given?
I need to check, sir. I didn't check because I was. I'll let you know shortly.
Yeah.
Excuse me, one request, sir. Can we transmit one side donor and one side recipient?
All right, Samit, can you ask the camera person and the logistic person to put one side screen for the donor and the other for the recipient?
Sure, sir.
At this point of time, we are seeing both the recipient screens. Samit, Dr. Batyal sir is asking about the length of the tunnel which routinely you make for a robotic.
Usually 5 to 7 centimeters.
5 centimeters?
G, 5 to 7 centimeters.
Because this looks slightly longer.
Yeah, because I want it to be perfect, so I kept it a little longer. But usually, if you can guess, once the ureter will be implanted here, then you need to have at least 5 centimeter more for the tunnel to bury it in.
And in general, sir, the tunnel is kept slightly longer because once the kidney is flipped, you never know which part of ureter is going to come, because ureteric anastomosis is done after flipping the kidney.
Yeah.
So once the kidney is flipped, you never know where the lie is going to be.
That is why we will not open the mucosa till we keep the kidney in, done the transplant, and we see where the ureter is falling. One or two times initially when we used to open it up here, we had to close it and make another tunnel. So we try not to open the mucosa till the very end.
Because in a routine transplant, we know the length of the ureter, we know that this is the likely place where we are going to implant it. In the robotic, once you flip the kidney and you fix the kidney, it readjusts its position, so the exact site of ureteroneocystostomy cannot be predicted as.
And one more thing, everything when you do it robotically looks bigger than it actually is.
Yeah. Yeah, sir. So it looks pretty long and pretty anterior as well. So Samit, just for the sake of the audience, can you please tell us the instruments which you are using?
Scissor and fenestrated bipolar.
So the instrument in the left hand is a fenestrated bipolar forceps.
Yeah, this is fenestrated bipolar, this is monopolar scissor, and this is a Cadere or a Progress.
So that's the fourth port you are using to retract the bladder.
Yeah.
Samit, Dr. Muruganandam here.
Yes, sir.
So you keep the bladder filled when you drop the kidney, or it will be deflated? Or this gives a good position?
We are just doing it to make the tunnel. Once we are done with that, we will
deflate.
Take out the saline, and the bladder will be deflated.
Because that place
only take it back again once the anastomosis is done.
Okay. Yeah, because this space you need for the kidney to go.
Anastomosis.
And you always try to make the anti-refluxing very
Yeah.
methodic.
We try to, but most of the time
Okay.
it is not.
Actually, there was an interesting data from Brazil last year in which they compared almost 2,000 patients head to head with refluxing versus non-refluxing, and they found no difference.
Actually, we routinely do the non-refluxing, simple
yeah.
and straightforward.
Yeah.
We don't try to this thing.
Sir, is there any effect of pneumo? Like, what are the pressures kept? And because we do open uretrovesical anastomosis in fear of pneumo, so
The pressures initially when we are putting the ports are 15, then they are between 10 to 12.
okay. So, do you think is there any effect of extra time spent during the uretrovesical anastomosis on the flow to the kidney?
Samit, the question being asked is that you're doing the arterial and venous anastomosis under the pneumo, and when you're doing the ureteric anastomosis in the pneumo, then is it going to affect the blood flow in the kidney?
Yeah.
In the neo-anastomosis, that's what you're asking.
Yes.
No, we haven't seen any such effect on the kidney.
Okay.
So you do ureteric anastomosis with the incision which you
Yes, sir.
you will put
So
the
through the, I mean,
Yeah,
the bladder
here
comes
the
through the
incision
gel
will be
point,
made.
so it will be open
Yeah.
and we can do it.
See, that is one more school of thought. What Dr. Kishore practices is that you do the arterial and venous anastomosis under the pneumo, and then you open the cap of the gel point, and the ureteric anastomosis is right in front of you.
Yeah,
So you can do it open. It saves time and it adds to the training of the residents as well.
That makes sense.
It's not looking very interior now.
Maybe. Basically, the concept is that the pneumo, once we have done the anastomosis, many a times the blood flow is not that good, the patient is not that well hydrated. A lot of fluid mechanics, I think, is very important in robotic transplant because the patient is in steep Trendelenburg position. So the blood flow has to go up. And many a times the kidney, if there is some volume deficit, then additional pneumoperitoneum might hamper the blood flow to the kidney. If your anesthesiologist is not cautious enough to go, because normally what I realized in the initial few cases, our anesthetists were very afraid because the patient was in steep Trendelenburg position. They were afraid to give fluid because otherwise the face will get suffused like this. So that is a very fine balance which we have to strike out, and I think with increasing coordination between surgeon and anesthesiologist, that point can be tackled. But then both schools of thoughts are there.
I think there were various studies are there that if you keep the pneumo pressure between 10 and 15, there is hardly any known effect on the perfusion on the kidney.
Exactly.
When you do donor nephrectomy routinely,
there are other aspects to that, because when the kidney is in Trendelenburg position and you flip the graft to the other side, okay,
Yeah.
so there's a traction on the artery actually, so that produces spasm. So I've seen, especially in very thin patients, no, it's like it's very steep, it produces traction and produces a lot of spasm actually. So that is one advantage of doing it. No, you make the patient straight and do that. But in very obese patients, it's difficult to do through the gel point. But moderate BMI and thin patients, it's quite easy to do that.
I think that's a very important point and well taken.
So there one addition. You were asking that rituximab was given 200 mg only. There was, I think, typographical error in this.
Okay. Good.
Hello,
Thank
can
you,
you
sir.
hear me, sir?
Yeah, Samit, we are.
We have removed, de-docked the robot for you to see the ports. Port placement, if you can, are you able to see?
Yeah.
Now they slightly shifted. Yeah, now it's correct.
Okay, now we are going to make a fan and steel incision. Initially we used to use gel port, but because of the cost constraints, we have started doing it through putting the kidney through the fan and steel incision. Because the gel port initially used to cost 55,000, now it is 78. For our extraperitoneal approach, we have started to use Alexis port, which is a little cheaper, around 28,000, 25 to 28,000. So, but most of our transperitoneal patients, we don't use any gel port or Alexis. We just simply make a phalansteal incision and drop the kidney through that incision and close it up. So now we will be making a small 7 centimeter, 8 centimeter incision, phalansteal, and then we are ready for the kidney to come.
See, this is again one more very important advantage of robotic transplant. When we compare the length of the incision, usually what is debated is that the length of incision is hardly different between an open and a robotic transplant. But apart from the length, the site of incision also matters. In this phalansteal incision, this is absolutely painless for the patient. No muscles are cut. You just split the rectus and you can push in the kidney. Vis-a-vis an open transplant incision, which actually cuts the obliques. So the pain, hernia formation, all those complications are likely to be much, much lesser with a robotic transplant.
No, actually, non-muscle cutting incision and phalansteal incision, we bring it for lean and thin and smaller patients, and that gives equally good results, even in open surgery, because the lean and thin patient is a small phalansteal, or if it is a small non-muscle cutting incision. However, there were reports that in non-muscle cutting incision, there were some cases of hernia, because by retraction, some nerves are injured in those cases. We have presented these things. So that is not there. Only thing is, incision certainly is much smaller in robotic transplant, particularly so in large volume and in obese patients. It is quite useful in those cases.
I think we should do much beyond that, because advantage of robotics is that you have a stable system. You can suture it. Magnification is much higher, and I mean ease of anastomosis in especially in obese patients. So it's just not the incision alone. I think once you're beyond the learning curve, I think it's much more useful.
You'll find it easier to do robotic than open, especially in obese. It's very.
Eventually, I think it will surpass your open skills. The robotic skills will be better with open surgery once you are beyond the learning curve. So.
I would like to ask you a question. How would you like to judge that your vessel is absolutely normal? There are no plaques in that. If you have not been able to see them on angio, if you perceive it before that, you might do a plain X-ray to see calcifications. You might do an angio if you are, worried about that part in selected cases. But on the table, you can't have that feel, and sometimes it may be a surprise to you that you open up and there's a plaque there. You can't be making arteriotomies here and there. So how would you ensure that your vessel is absolutely pliable?
I think routinely a Doppler is a must before a robotic transplant. So a Doppler, and if there is any suspicion, then a plain CT of the recipient can reveal the calcific. That is one aspect which all robotic transplant surgeons should be very, very careful of, because you don't have the liberty to go here and there and do multiple arteriotomies or.
No, but what sir is asking, I think we sometime in open we just put with the finger we check the suppleness where we choose, but this is not there. Kishore can answer that.
No, there are people in robotic surgery, as they are doing the open incision, you can always put your hand inside. There are, my colleagues are doing that, and you can feel the vessel in case of any doubt you have.
Yeah, this particular case is absolutely clean, neat. Visual clues are there.
No, there is a 3D augmentation model by Breda and colleagues from the Spain. They have proposed it, which is probably, it will superimpose on the plaque area. But what I feel is that more than that, you get the visual cue. You can actually see the plaque with robotics. If you just you get like a small pinch on the artery, you can feel it actually. I mean, with the visual cues. I'm not saying that you have the tactile feedback, but still you can feel it. And even if it's a plaque, even open surgery, you will fix the plaque. The same thing you can do for the robotic surgery. So it's not really an absolute contraindication, I would say.
I think the plaque case should come after doing 200 cases.
Maybe, yeah.
Otherwise, it becomes.
So the optic will surpass the haptic with experience. That's what you are telling. So, can the donor surgeon can brief till now what has been done, what happened to the upper pole artery, what they are going to do? Dr. Pragnesh? Are we connected to the donor side OT? Audio?
Hello.
Yeah. Yes.
Am I audible?
Yeah, clearly.
Yes. Good morning, everyone. So the donor is a 29-year female.
Yes.
You already know that it's a ABO incompatible transplant. And we have done till now dissection of the kidney all around.
Okay.
We ligated the gonadal vein, we ligated the lumbar vein, we ligated the adrenal vein, we have identified the main renal artery, we have identified the renal vein, we have looped the renal vein. Now we are in a plan to search an accessory artery.
Yeah, which was seen on the CT angio,
yeah.
The smaller one. Okay.
I don't know whether it is available or not.
There was some bleeding in upper pole where you kept the Surgicel. Is that same location or higher than that?
Yeah, it was a minute bleeding, yes.
Ranjan was asking Samit, do the donor nephrectomy any different for a robotic kidney transplant compared to open during the laparoscopy, or is the same, just the same principles?
It's the same principle. The only principle is different that whenever we dissect the kidney on the bench and prepare a jacket at that time, we need to
that
do
Dr. Samit has described.
maneuver. Yeah.
Dr. Samit has mentioned it, what we do in the bench.
What are your criteria? This upper polar branch, which is a cortical branch, which is 1 point something only millimeter.
Okay.
So would you really like to spend so much of your energy to save 1 millimeter
in our experience, either we will sacrifice or it will be sacrificed on its own. It's too small, yeah.
But I think
very difficult.
the criteria is, in some papers also, we also try to do, if it is more than 2 millimeters, 2 or 3 millimeters, then we should try to, revascularize that particular portion. More so if it is a lower polar, that you can never ever sacrifice.
Correct.
Sir, in our unit, we try to preserve the artery during donor.
All artery.
On bench, we see how much it's supplying, and as per need, we can sacrifice it. Supposedly, we sacrifice it just now, and on bench, we realize it's supplying a significant portion. That will be a point of no return.
Yeah, that decision not during the donor nephrectomy.
Yeah,
but
and during donor, we try to preserve all the arteries. We safely take them out. We perfuse, we see. If it's supplying less than 5% of cortex or something like this, we sacrifice it then and there. That's not a big deal.
Yeah, that's a point well taken. During donor nephrectomy, you clip all the vessels close to the aorta, so we deal with it later on. Still have option of reperfusing. This particular case, it appeared very small. I don't know. Even this, you will try to preserve, and there, what are the options? Ruchir?
It's around 1 millimeter.
Yeah, this particular case appeared too small. Suppose you see that, okay, you are seeing some spot on the top. So where will you put that upper pole?
No, sir, we try to preserve it till the donor is complete.
Only?
Yeah, we try to preserve it till the donor is complete. If there is some accident, then it's an entirely different thing. But mostly we try to preserve it. We see on the bench, Sometimes we feel that on CT and visualization it appears to be very small, but on bench under loop when we see it applies significant parts, or it's a good caliber, we can reconstruct it.
Yeah, but what I found is two small arteries difficult to put on the external iliac artery due to the thickness of the vessel alone, not only the lumen.
Yeah.
So unless the inferior epigastric artery it's making another hole in the external iliac artery.
No,
the thickness will be different for both arteries.
If there is a very small artery, but it's supplying significant portion, we do end to side to the main renal artery in that.
Okay. But again, this particular case, it was too far from the main renal artery. Anyway, that you will judge on the bench.
Yeah, we'll decide on the bench how things are going.
Fine.
So in these cases with small accessory arteries, so what is the role of ICG? Like on table, we'll get to know the supply. So
I think
does anybody use that regularly, or
I think technically it should be possible, but I have not. We have never done it.
Okay, thank you.
Anybody has got have used ICG?
No, not ICG, but there were certain papers when I was presenting these multiple arteries and all these things. I just came across that the criteria that there was a group which would say that 2 millimeters and above, he will always save the artery. Okay? And then he would say that if it is less than 10% of the cortex supplied, if the artery is straightway going to the cortex, he will sacrifice that. But if it is more than that, then he will save it. Why? Because there is a fear of what they call as
nephrocortical fistula.
Fistula. Blowout of the fornix. Fornicial blowout. I was trying to get that word to me. Fornicial blowout is known in those cases if it is more than that. So one has to be careful about that. That's all.
I think when I was in CMC Ulur, one case was that the second artery to the upper pole that got thrombosed after anastomosis. Then that patient had a fistula directly urine coming from that upper pole. That patient was there for a long time, I remember.
Because idea of putting the small vessel in the main renal artery, I'm not very much convinced with that, because many a times you just put the main renal artery and then you realize you don't need to do anything. The kidney is well perfused. With the CT appearance of this kind of artery, I have a feeling that we might just sacrifice it right away. Because many a times the pain, the labor it takes to preserve a small artery might land up with problems with the bigger artery. So it's better to let it go.
Yeah, that's the point I was trying. Screwing up the main renal artery or the external iliac artery, another opening. So this, so Dr. Pragnesh, you have to flip the kidney to reach the second artery.
So this is something which we do not practice, to do the posterior dissection by flipping the kidney, especially on the left side. What is your experience, sir, about flipping the kidney during laparoscopic donor nephrectomy? Because I believe it might lead to unnecessary spasm and kinking of the main renal artery.
Sir, for the right side, I think routinely we flip in all cases. For retrocaval dissection of the artery.
Yeah, but not on the
left side. But few times when you are not able to see the artery properly, some difficult lumbar veins, we have done it. But of course, the fourth port may keep it holding not to rotate.
Over to you, Dr. Pragnesh. Sir, whenever we do not identify we are not able to identify the upper polar artery or any accessory artery, you know that the artery arises from the aorta and it usually behind the renal vein. So in that scenario, we have to identify the renal artery from behind on left side also. So I did not use the flipping of the kidney for the main renal artery.
Okay.
I was able to identify from anterior only.
Yeah, that we saw. With the hook,
Yeah.
nicely you dissected the artery.
But when I was unable to identify the accessory artery, so I want to make sure that if there is any artery available or not. So that is why I have flipped the kidney completely.
Okay.
Anyhow, we have to flip the kidney before procuring the kidney, before ligating the pedicle, so that the warm ischemia time is decreased.
Oh, great. What's your routine protocol? The medial dissection of the vein up to, with respect to the aorta?
Just medial to the adrenal, insertion of the adrenal vein.
Medial to the adrenal, okay.
Yeah.
So if you are cutting at the adrenal vein, you are fine.
Yeah, we'll clip it here.
Okay.
Just medial to the adrenal vein. So we will have a stump of the adrenal vein which will be identified as a upper part of the kidney while putting an engraftment.
This is a landmark during the recipient surgery.
Yes.
And I would also beg to differ on this application of hemolog clips on the tributaries of the left renal vein, especially the gonadal, the lumbar and the adrenal, because
yes,
it
I
might,
understand,
yeah, it
but
might.
We don't encounter any difficulty till now by applying the clip on adrenal as well as lumbar.
Yeah, well, your
But
point
even
of
if we
view.
have to put few clips on a twig which is arising from the aorta but not going into the kidney, we clip it just 5 mm lateral to the region so that it will fall down and it will not come in front of the when we clip the artery.
No, it's not in the donor. I'm talking in the recipient. Once you take this kidney in the recipient, many a time the thread gets entangled during the anastomosis with this clip.
Yeah, I understand, but we remove that clip and we will suture it, ligate it with the suture on bench. We don't let it there in bench. We will remove the clip and we will ligate it with a 3-0 silk.
All right.
Even during donor also, it has happened to me, just placing a Surgicel, when we took it out, it just pulled the hemolog. So it's always that risk.
Okay, routine things. Yeah, what's the advantage of Surgicel over routine gauze, in this? Because normally people gauze.
Cost is there.
Yeah. Dr. Pragnesh,
Yes, sir.
is there any advantage of this Surgicel over routine gauze that we use in donor nephrectomy? Because that probably adds to the cost another 3,000 to 4,000 rupees. Is there any particular advantage of using that?
Yes, but we have a routine protocol not using gauze and using Surgicel. That fiber of the gauze will stay inside if we do not remove it completely. So that's a foreign body. So Surgicel is an acceptable foreign body and it will use as a cleaning material as well as hemostatic material also.
Okay.
So you are afraid about leaving it behind and forget.
I think that at the time of bench, one other thing that they do these days is at the superior adrenal end of the vein, they also tie a small proline suture. So instead of just, with the help of the forceps or the grasper, you don't have to directly, take control of the vein. You can just use that small proline suture for, just placing your vein. So that is also, I think that they might do it. But this
I
is
think
what
Dr. Samit has mentioned that during the bench, they put 2 on the upper end to identification, then to do minor manipulations during the surgery.
Actually, the anastomosis with the black diamond forceps is just like a beautiful. It's a beautiful forceps for vascular anastomosis. You can hold the wall of the vein. The thread is placed more for the orientation.
Yeah.
Where is the superior pole? Where is the inferior pole?
Because you have you have the gonadal and the adrenal, so you're not sure whether which is one. So that's why it's always better to put that small pole in thread.
One way of circumventing that problem is that you can put, he says there are clips on the adrenal vein, you can put 3 clips on the adrenal vein and 2 clips on the gonadal, so that you don't get confused. So,
Or
So I think they are finding the second artery, the accessory artery. Have they dissected the accessory?
Right.
It's not seen till now.
Right angle though.
So again, in these cases where we are finding it difficult to find the accessory artery, so why don't we just clamp the main artery and put an ICG and see if there is any other part of the kidney which is being supplied, or if you would have accidentally cut it already.
so this camera should be ICG enabled. No, it should be.
That will take time, no?
I
That will increase
think
the
I've never
warm
used.
estimate time also.
Yeah.
Then
So tell us your experience about use of ICG, because I think most of us have never used it.
Sir, actually, I mean, we have not used it regularly, only in case of accessory arteries when the arteries are really small. On CT, it looks like a cortical branch and it is around 1 to 2 millimeter. We'll be in confusion whether should we really sacrifice it or not. So in these cases, we have used in few cases where if it is really not supplying much, so we would sacrifice it on table. But not, like if it is more than 2 millimeter, we would try to preserve it and then take a call on the bench. So.
No, he's asking on the overall the usage of ICG in your center and experience. Partial nephrectomy.
Yeah, in partial nephrectomy we use it regularly, sir, so that we'll understand whether, like on CT sometimes, like especially if the CT is not done in our center and we don't have the CD and the patient comes with only the films, so we'll not be really sure as to whether the like arteries are single or double. So in these cases, when we find the main artery and instead of dissecting and spending time in dissecting the whole of the upper pole, so we'll just clamp and then do an ICG, so we can preserve some time and also we can preserve the dissection.
Another thing which I have found useful is ureteric reconstructions. When you are worried about vascularity, that also helped.
Okay.
Dr. Deepak Dubey also showed in one of the videos.
Yes, sir.
So after that only I started using. So when we are cut end-to-end ureterostomy or interposition,
yes,
even
sir.
in bowel they use, the GA surgeons, the edges of the bowel, whether it's vascular or not.
Yes, so we do it regularly even for the robotic radical cystectomy to see for the uteric canals.
Good.
Yeah.
Custodial.
I mean, what is the cost? I did not know. What is the cost of the ICG per usage per? Okay, that's okay. Okay. So, maybe equal to Surgicel. No?
Surgicel भी महंगा हो गया.
It's quite useful in robotic transplant also, the ICG, because once you're off the clamp, if there is some vascular spasm or there is some question in your mind that there is no perfusion, you can give ICG, see the graft is perfused or not. So that is one advantage with ICG. Instead of, probably it might score over the Doppler, I think, because Doppler also can be sometimes a little bit in the gray area. So. On table.
Doing Doppler before you take out the pneumo, is it easy or difficult? Doppler.
Yeah, Doppler.
You can do.
Drop down ultrasound probe. It's quite good.
Drop down.
Drop down ultrasound probe. So.
Can you hear me?
And
Yes,
even
yes.
after dropping the pneumo, should use the same because air comes in between.
Yeah.
So you can't do the abdominal probe. You have to do a intraoperative drop down.
Retractor, please. दिखाऊंगा. ये तो लाओ. You can see the diuresis.
Yes, yes.
Suppose no diuresis, what will you do routinely?
We will wait, we will hydrate. If not possible, we will give another 10 milligram Lasix or we will use vasodilator.
Still not coming?
Then we will remove the kidney.
Why not?
In fact, many a times
we don't see routinely. Yeah.
Exactly. Many a times, once the hilum is too much dissected, it also leads to kinking of the artery by the time you are giving the incision. So I don't prefer to dissect the hilum completely bare before giving the incision, because once the artery is bare, it gets kinked.
What we routinely do in our center now, that we keep some tissue at the upper pole of the kidney so it doesn't hang around,
Yeah,
and it's easy for us to
Correct.
clamp the main vessels.
Exactly.
And we also don't cut the ureter. We comparing it with that thing. We don't cut the ureter beforehand. We ligate the pedicle, cut the pedicle, and then cut the ureter. So we haven't found any problem whatsoever. Of course, we have not carried out a study, but on table we haven't found any
So
problem.
slightly longer warm ischemia, maybe half a minute or so.
Yeah, hardly anything. After the vessels are cut, it just takes about a couple of seconds more.
I think the hemolock is too flush to the aorta.
It gives you little stability.
You just keep. It is also risky. I think applying the clip too flush with the aorta is
Can be dangerous at
yeah,
times.
can be dangerous.
Sometimes it can be,
Yeah.
but you can apply this clip before
Metal clip.
because it reduces the pressure in the artery,
Yeah.
and it becomes easier to put the clips.
Because metal clip we will have a control how much to give pressure. For the hemolock we have to crush it more for the lock. So some atheroma it can just break it.
बुलाओ मेहरा जी एंडोविजन में क्या प्रॉब्लम है जल्दी आर्टरी कट गई है मेहरा जी आर्टरी कट चुकी है
क्या अच्छा विशन इज नॉट
हाँ राइट एंगल नीचे क्लिप हाँ 15
Murphy's law.
यार जल्दी से एंडोविजन चेंज कर दो यार नहीं तो
I think it's a rule. The instruments don't support you when they are needed the most.
Yeah, that's a modification of the Murphy's law.
So this is in our setup only or in everybody's experience?
Everywhere.
This is universal.
If something can go wrong, it will go wrong. There is a, yeah.
But I think that these hemoclop clips, still they are not FDA approved for donor nephrectomies.
Yeah.
If you look at the, so that's why one of the reasons for putting a metal clip is, paradoxically, metal clips are approved by the FDA. So if you go to the US, then they will, even though they know that they are the safest, but they'll apply one metal clip. And I totally agree about the icy green that you were saying, that it is used well in the ureters, especially when you're doing ureteric strictures. You know, we also started using it. And we use it in the department, very expensive, manufactured by Akron, 25 milligram vial comes something around $730 US. It comes in the form of a powder, but problem is that it has to be used completely within 6 hours of reconstitution. So it's a little expensive. So if you're doing multiple cases in a day, then it seems to be okay, but that is the cost, $700, $800.
ECG is telling, but he said is 2000 or something.
Start the beta.
Nothing.
I had done an uncontrolled survey on WhatsApp regarding use of hemolocks and complications associated with it. So we got out of all responses, there were something 17,000 odd donors in which hemolock clip was applied across the country. And there were around 4 or 5 incidences of malfunction. Mostly there were 5 mm clips. There's no malfunction with 10 mm clip. and out of this 17,000 odd donors, there was single mortality. That was an earlier experience. So I think this is pretty safe.
Yeah.
My fault that I didn't send it for publication, so we have got not published data about it.
Sir, what was the cause of mortality in that patient?
It was only single clip was applied with the zeal to preserve the single lumen in an early bifurcation of the artery.
So that too yearly experience, you said?
Yeah, that was a very early experience.
Long time.
In fact, the US FDA actually doesn't approve a hemolog clip for the vein. It approves it for the artery.
No, FDA said it's class B recall, in which they have not exactly said it's not approved, it's a class B recall.
So they say for the vein you should use a stapler. And for the artery you can use a clip.
The US is a strange country.
Yeah, exactly.
Dr. Rajiv might not agree with it.
I think US they routinely use the staplers for both.
More than the dislodgement problem feared with the hemolog clips, what I have personally experienced more is, which you cannot actually predict it, it gets stuck. You have applied it and now you are opening it, the clip is not coming off.
Exactly.
Now it's a very dicey situation. What you do most of the time, you become lucky and it comes off.
Yeah.
But I have seen presentations in conferences where it is stuck, you have to use another instrument to manipulate it. That's really dreaded situation.
Yeah.
I think it's more with when we are using the
Indigenous.
applicator is not original.
Exactly.
With the original Teleflex VAC applicator, these things do not happen until unless it goes, it's an old one and it malfunctions.
It
All
depends
instruments
upon
become old with time.
Then you have
On
to replace
table
it.
you check it, it works. Then we started wasting one clip. Once it happened, next 3 to 5 cases, same applicator we used it worked fine on table because it's just little bit misalignment. It somehow gets stuck, and you don't know in which case it will.
Misalignment is different, but as it gets old, it gets jagged, then the problem starts. If it's happening, better change it.
Mainly, see, we have to focus on the technicians and nurses who are taking care of our instruments. Once the instrument is, once we are done with the case, the instrument has to be thoroughly washed, rinsed, remove all the stains, blood stains in open and closed, and it has to be air dried before with a gun, air gun. Then you put it for autoclave. So most of the times जल्दी cases करने के चक्कर में वो धुला और खट से डाल देते हैं बिना dry किए. That is why these problems become more common.
Yes, sir. Yes, sir.
Yeah, it's not only with the hemorrhage. No, there can be many things. You know, even your movements of your hands. When you put the clip inside, there are so many factors which have to be evaluated. So the only thing is the one has to be extra careful, as you very rightly said. Look after the instruments. Look, your assistant or the sister should look after how to load it and how you get inside and how you apply it. All those factors have to be taken into consideration.
So I can share some of the anecdotes like I had during my whole career. So once it happened, I clipped the artery. Okay, then some sister moved across and the monitor went off. So you're not seeing. You clip the artery. There is nothing in the camera. Luckily, there was one sister. She somehow fixed it. It took about 2 to 3 minutes for the monitor to log back. That is one. Second time, I clipped the renal artery, renal vein. Suddenly, the patient fell down. In sense like. Patient got off that front position because at that time we were doing a transvaginal extraction. She was in lithotomy, so that one of these stirrups went off. So and after that there was some bleeding. Eventually, when I went to the somehow I fixed it. Eventually, and went to the recipient side, I saw there was a big tear in the renal vein. So much more than the instruments during the extraction, sometimes even pneumo can go off. At that time, in the initial period, we don't have the central gas supply, we used to get the oxygen cylinder. At that time, the pneumo can go off. Suction may not work, so quite a bit of things to be fixed during that time. So
which suction are you using? Because I just want to have a word on suction because till now I was using the Lina suction. It was very effective for donor nephrectomy. But for the past 3-4 months, the supply is off the Indian market. So which suction do you find most comfortable for laparoscopic donor nephrectomy? The standard trumpet suction or some modification?
I think it's a personal choice. I use a trumpet suction,
You use the
routine
trumpet
metal
suction, I
trumpet
think.
suction.
I think it is a personal choice. Trumpet is easy, it releases automatically. The lever you have to press forward and back. I think most of the companies they make the trumpet section.
I think I fully
don't
agree
know.
with him. Somebody should publish a paper and all these tidbits, what happens. It is not your fault. The monitor doesn't show off, the thing doesn't work, or the gas, the inflation doesn't suit you. All these things have to be taken into consideration.
And what he said, sir, actually happens most of the times that when you're clipping the artery, somebody moves and the entire endotar goes off.
Once somebody hit my elbow just before putting a clip to the vein, just that they hit the elbow. So I had to, instead of completely putting the vein, half vein I had to put, it started bleeding from there. So at that time we can't shout also, so you have to control that.
Ironically, the staple malfires more than this one's Hemolock clips, because I had used staplers very few times, but still I had 2 malfires so far. Once, way back, right donor nephrectomy, we were doing the staple did not come off. I think it's probably more in India because we reuse the handle. In US, they don't reuse. And we tend to ETOs, the clips and all these things, probably that's what is more for us. And we use a combination. They use completely staplers. We use clip on the artery, stapler on the vein. All these things, can add on to the complications with stapler, especially in the Indian setting.
Can we go over to the bench now? I think there are a few important points.
Yes. Samit, are we with you?
Yeah, we are doing the bench here. We have perfused the main artery. Can you see the main artery?
Yeah.
Here, this is the main artery. Here is the vein. Can you see the smaller one?
Yes. Yes.
Which is really small. So I don't think it's going to be of much use as you guys were discussing earlier.
But if he says the line of demarcation, you can see here little bit. Yeah. Sister?
Can you hear me?
Yeah, Samit, we are with you.
Yeah, so in the meantime, when we are doing in the bench, I would like to introduce the team that we have here in the OT. Dr. Puneet here is the main anesthetist and donor.
बेटा पानी कम करो.
And we have Dr. Braj as assisting us in the donor.
और कम करो पानी.
And Renuka also with on the nursing side, and the whole staff is here. On the
bench side,
we had Dr. Vikram, our chief anesthetist there, who is giving anesthesia in the recipient side, and our technician, and Dr. Sapnil, our robotic fellow, is there assisting.
Full karo, khali karo.
Big thank you for them, to them. You can see here it's very small artery. The chances are, and you hardly see any tissue which you feel that it's not being perfused. So you were absolutely right. In those small arteries, most of the time, when you perfuse the main, you don't see any areas unperfused. So most likely we'll try until unless Dr. Anand decides otherwise, because he doesn't like to waste even a single nephron, so he might consider re-implanting this in the main renal artery.
So you have perfused the main artery?
Yeah, we have already done that. Now we are perfusing the smaller little one, just in case. So what we do is we perfuse all the arteries, smaller, bigger. Then if we feel that the area is more than 5%, then we try and dilate the smaller artery and see whether the lumen is enough for us to use it for either the implant or anastomosis to inferior epigastric or directly to the external eyelid. And this being a robotic case, rather than doing two anastomosis, if we have to use this, we would rather do a re-implant than do a smaller vessel anastomosis robotically, separately. So transplant can give their opinion what
इससे बड़ा करना भी नहीं है.
practice.
So routinely as a practice you dilate these arteries with these dilators?
Yeah, we do.
For open transplant as well?
Yeah, even open also we do, not over dilatation, but yes, we use dilator.
चलो डिसेक्शन करना शुरू कर दे. वो दे दो बैठने के लिए दोनों साइड
Then
पे.
we will dissect it now to prepare it for the robotic recipient.
उधर जगह करो. एक सर को दे दो, एक मुझे दे दो. वेन पकड़िएगा दोनों साइड से सर. बेटा लाइट इधर. हाँ.
For open transplant, do all our transplant surgeons are using magnifying loop or no? Can I ask this question to the audience?
At least, Samit, you have worked with me for a long time. Till today, yesterday I did 2 arteries. I never used any magnification. God has given me that gift. I'm quite happy with whatever I am having to see all of you.
You're getting younger and younger day by day, Patel sir.
Your association.
To answer Samit's question, I would say that magnification gives you a different kind of confidence and your results really improve. I can compare my career before magnification and after magnification. I find that the incidence of complication has gone down drastically, especially the vascular and anastomotic complications. So to all younger colleagues who are embarking on their transplant career, I would suggest that buy a magnification loop, whatever you can afford, and once you move in higher echelons or higher orbits of practice, buy costlier ones, but don't operate without magnification. That is my suggestion to everyone.
No, for the this thing, for the debate purpose, sir.
Accessory artery.
Sir,
I use 3.5x designs for vision. So that is my current loop. The old loop was Carl Zeiss 2.5. So 3.5 expanded field of vision, that gives nearly this much of window. So that's most comfortable and most luxurious.
No, your result, you said with the usage of loops, your results improved.
Yes.
That the improvement results, maybe your more experience, you are doing better.
That is possible.
If you do now with loop and without loop, that's the correct time to see whether it makes a difference.
Now without loop, even skin stitching is not possible for me.
So you have to get used to that. Now we cannot see without loops, you know.
So you buy a robot to get off that loop.
Sir, I'll give a different analogy. Until you drive an automatic vehicle, you don't realize the importance, what the trouble was with the manual one. So I am using a 3.2x Carl Zeiss, and it's more than 10 years since I am using. So yeah, definitely blown out or magnified vision is an advantage, no doubt about it.
Yeah, there is no doubt.
Magnification has its role, unless we may get away so many times. That's a different scenario. But anything above, if there is problem of adjusting, I suggest anybody to start using at least 2.5. It is very easy to adjust. Then you can go for higher magnification. But the problem is your field of vision becomes more restricted. So you have to get used to it. You can't ask instruments like you have to just gesture, give me this, give me that. So, because you can't go and look things what others are seeing. That is another limitation of magnification. And having said that, even when you use magnification, you start using for other surgeries, urethroplasties, AV fistulas, and particularly even circumcision. I mean, I am not able to see without, I want my loop here, let me just do
circumcision.
It looks beautiful, right?
The problem with loop is that the power goes on increasing every 2 years. So you have to upgrade, keep on upgrading your loop as your presbyopia progresses.
No, I don't think so.
Can we ask one question to Dr. Samit? as to how much of defatting he would like to do on the kidney. Would he like to keep all the fat around, or how much he would like to keep behind? I think let's get over the loop now.
Samit, are you listening to the question?
Can you hear me, sir?
I think we are getting looped into this.
Yeah.
So, Samit.
But the answer is to the rescue as always.
Yeah.
Sir?
No, we just want to know how much, how would you do we all do that thing during the bench, but do you have different criterias to defat the kidney for your robotic implants?
Sir, we will defatten the kidney completely except for at the lateral part, the lateral border of the kidney at 2-3 places where we leave the fat and tie it. We just don't leave it, but tie it so that we can use to manipulate the kidney rather than handling the kidney directly with the robotic instruments, because that can cause injury. So rest all of the fat is going to come out, as you will see right now.
Yeah, that's what we also practice now, because even in open transplants, the more you take care of all these things, the less it gives you problem after you have implanted the kidney. These small little bleeders, they really bother you, and at times they might retract inside, and it becomes very difficult, you know.
Yeah, in fact, in robotic transplant, it becomes all the way more important, because you have to rely on visual inspection of a turgid kidney. So once you have perfused the kidney, you have to rely how beautiful the kidney is looking.
We can use a harmonic scalpel to take out the fat, so it doesn't.
That's what I was coming to.
Yeah, in fact, what Dr. Kishore is suggesting,
and I think bipolar is much better, because Dr. Jamal was telling they even the lymphatics get closed with the bipolar.
And it gives an absolutely clean field.
We haven't tried that.
With LigaSure.
LigaSure.
With LigaSure.
I have
the only device which can close the. They claim that it can close the lymphatics as well, small size lymphatic. We anyways will tie all the lymphatics around the main vessels, and not so much in open surgery, but in robotic surgery we are extra careful to tie everything off or clip everything. Don't leave it for later, so that when you are when you declamp and the kidney is turgid, you have to use 1 or 2 places only, the bipolar or any hemostatic. The rest of the kidney does not require any hemostasis. So that is the aim.
The defattening has specific purpose. I'm not sure about the robotics, but in open surgery around the hilum, whatever fat is there, many times if you have less space, it falls onto the vessels, and many times it limits your view. So once you try to defatten more, you tend to open up more small vessels which are mostly coming out from the vein. So they tend to ooze. But personally, I try to defatten as much as possible close to the hilum. It gives extra length, plus it gives the practice of doing defattening more often. Because when you actually need it, a very small vessel, you want longer length. But if you are not doing regularly, there are very small vessels which tend to ooze on table.
Yes, but Aditya, I came because you said that you have to remove the fat next to the hilum. On the contrary, sometimes if you start removing too much fat on the hilum, then they are very, very small vessels. And sometimes if you open them up, then what happens is that during reperfusion, the sinus starts to bleed. And then what is happening is that you're taking your, forceps and your cautery, and you're in a, so that's why if you go too deep into the sinus fat, then sometimes on contrary you can have problems with these small, vessels which are anastomosing. So that is also, I agree with your point that, that fat can fall on the vessels, but at the same time, going too deep into the sinus can also be a little wrong.
Dr. Samit?
That's the whole point of using magnification again. You use the magnification, you see those small vessels, you get the habit of clipping them. I am doing it in almost all the cases, and very rarely you will find bleeding. But it gets extra length, but that's a personal practice, I agree.
Yes, but can we see the donor fossa before you close it?
Yeah. You can see Dr. Braj here is closing the incision, the phalangeal incision through which we took out the kidney. Once in another 2 minutes, he finishes the rectus sheath closure, we will have a look inside and let you see the fossa as well. Just give us 1 minute.
Practically speaking, for lymphatics, everything is going to fail. Any energy source is going to fail. You use any. So on table, you won't get bleeding. But for lymphatics, one has to tie, one has to clip, one has to do something.
Exactly. Ligation.
Just a moment, please. So first of all, I would like to thank our chairpersons, Dr. Manas, Dr. Bijay Mansingh, Dr. Priyadarshi and Dr. Muruganandam for this wonderful discussion on donor and robotic renal recipient.
Can this excision of fat and fascia not be done by ligature or harmonic?
Yeah, that can be done. That's alternate way of doing it. Many people do that way. In fact, I also do that way.
Samit, you are dissecting and taking the silk using the scissors.
We tie it off with this silk suture.
So,
but you are
Samit is saving money.
So I'd like to invite Dr. H.S. Bhatyal, Dr. Rajiv Sharma, Dr. Nachiket Vyas and Dr. T.A. Kishore to be the chairpersons for our next session.
Sir, how much perfusion solution needs to be infused through the kidney for satisfactory cooling and satisfactory perfusion of the kidney?
I think over all these years, I think for me it is about 33 years now. We have been using Ringer's lactate earlier, reconstituted, and now of course whatever is available. Till the time the effluent is clear, that's what it is. And by and large it is about just less than a liter. Am I right, Aditya? Around about. Yeah, half a liter or whatever it is. And then of course we use the same irrigation fluid to find out if there are any leakage here and there. You perfuse through the artery, clamp the vein for a shorter while and see if there's any little bit of leak, because that is very troublesome once you have implanted the kidney. I think Samit, you are doing a very wonderful job. And
Sir, Dr. Pragnesh who is doing a wonderful job. I'm just taking the credit for it.
That's all right. Somebody takes the credit, somebody does the job, but then it's a mutual understanding.
Yeah.
I think so that one of the other advantages of doing a good internal perfusion is that you bring down the core temperature of the kidney also, because I mean it's always beneficial to keep the core temperature as lower as possible. So a clear effluent would, I think, come in just 100 200 ml, but yes, 500 ml, 700, 800 is a good. Just give some time for the temperature further in the because outside the temperature is an ice bath. But this perfusion would take care of your inner core temperature and bring it down slightly more for a better maybe ischemia time.
The lowest volume will get custodial or any solution is 500 ml. So 200, 250 ml is sufficient. So less 200 ml, the rest remaining amount will keep it as such. Maybe you may need it later or sometime. And regarding the core temperature, one has to achieve a 13 to 14 degree of core temperature. But the kind of perfusion we use, the core temperature goes down to even 2 to 3 degree also. But that will help us. I mean, we get enough time while so-called warm ischemia to put the kidney.
Yeah, we haven't observed all these things over so many years. We have been doing all these things. We never noted how much time we really require to perfuse the kidney. What I personally feel is the moment I find the effluent is clear and I find the kidney is perfused, that should be fair enough.
Yeah.
Sir, many concepts in my opinion, we try to extrapolate from one place to another. The idea of the core temperature is when we try to cool down a human body. There is a skin and you want to cool down the central core of it. Kidney is not that much of tissue. Even a minute of perfusion, within 60 seconds, the temperature, you are using 3-4 degree temperature fluid, plus kidney is in ice, it will only take less than a minute to cool it down to 4-5 degrees. So as such, trying to perfuse more and more liquid, it is just a theory which I feel we are extrapolating to this, but how much it is actually useful, we would never know.
I think one of the other advantages at that time is that once you've done your bench surgery, which I think another point to be discussed is that you can also test for your leaks and all, just close the vein and then see that we were talking, Aditya, about, if there are any small oozes inside the hilum or if there are any small, rents inside the vein at that time also. So it's important the dual purpose is to cool the kidney and also to see for any leaks inside the vein or etc.
I'll differ here a little. I mean, as Sir said that effluent should be clear. I'll put another 50 to 70 ml more to have a more core temperature, and after defattening, I'll again perfuse the kidney with another 30, 40, 50 ml to have achieve a core temperature of around about 3 to 13 degrees Celsius. But it's all subjective. Everything is subjective.
It's subjective, Rahul, but I totally agree with you. Another 100, 200 ml is not going to, hurt the kidney and it's just going to take another maybe 2 or 3, 4 minutes.
That's an individual practice.
Yes.
No, it is for the younger colleagues of mine. Over the years, we have seen these things that when we started these things, when we are doing the anastomosis, we used to take a little more time. And every time somebody is pouring ice cold water on the kidney, and you're not getting the killer field and all those things. But over the years, we have learned that if you have perfused the kidney very well, and you start the anastomosis, in 20 minutes or so, you are over. And I don't think you're required to pour in too much of cold water over the kidney. This is just for my younger generation. You really, if your anastomosis time is absolutely perfect, and you don't take unusually long time. And for me, I don't know, many people may say, so to wrap around the kidney with a gauze piece and this and that, I hardly ever do it. Kidneys never had a frostbite. I've never had a frostbitten kidneys so far.
Sir, I feel in our practice we have the problem of plenty. When we worry about something, we try to overdo it so much. The cooling becomes in, extra cooling. Many times the kidney comes in totally in ice. We have the problem of overcooling of the kidney. It goes into a spasm, and I have seen the kidney. Then we started making a protocol that it will only be in ice cooled water. No ice should come in contact with the kidney. The initial function of the kidney is much faster compared to when trying to cool it, put it in the ice, bury it in the ice, then you get it. Sometimes if it is late, one cadaveric case, the first team, they were from the liver side. They just put everything packed in the ice and gave us, and by the time we got it, it was frozen.
And also to bring out the semantics of this, on the 13th of August, we received one cadaver kidney from Jodhpur, and it took 4.5 hours, and the kidney just came inside, ice. There was no continuous perfusion. We do not have continuous perfusion, and once it was transplanted, then that kidney did very well. So I mean, the whole concept of perfusion and all, it goes haywire once you are getting a cadaveric kidney in ice. 4.5 hours taking from Jodhpur. So, I think that you have to keep your technique sound and do your best. And even if it takes some time on table, or even if it's a cadaveric kidney. So,
no, it is not that. Yes, Samit?
Sir, the audience wanted to see the fossa
Yeah.
at the end.
Yeah.
You can see if the screen is there. On the screen, can you see it?
Yeah, we can see that.
Yeah, so you can see the clips on artery and vein and the upper lymphatics.
Yeah.
And we are ready to close.
Thank you.
Thank you, sir.
Dr. Shamit, do you usually leave a Surgicel there? Most of the cases?
Most of our donor nephrectomies are done by our third-year residents and fellows. So we have made it a habit to put a drain as well as a piece of Surgicel over the hilar area.
So
you
Surgi...
not do it if you're doing it yourself, if you're confident. But this is a usual practice, so it continues like that.
So your fellows, you give them a good girlfriend, huh? Okay, Samit, we are seeing your bench surgery very well and very closely, very keenly. Any more points you have?
Sir, you can see this is the artery.
We would like to see the magnified view. I think there are a lot of PIPs in this.
Yeah. Can you see now?
Yeah, better.
बाकी बंद कर दो, robot donor वाला बंद कर दो.
I think donor can be closed.
Donor बंद कर दो. And this is the vein.
Yeah.
You can see it here. The adrenal clip is still there, which we will remove. This is the main artery. This is the smaller artery, if you can see. See?
Yes.
And these are the lymphatics which we are going to clip now. And this is the ureter. We have cut the gonadal a little away from the ureter here, so that we have this length for reimplantation. You can see a few fat areas which are tied with a suture to handle the kidney once inside.
Yeah.
So we have left it at 3-4 places, mostly on the lateral border.
Samit, there is a very one pertinent question.
Sir.
You know, once you have ligated these, clipped these branches like adrenal and lumbar and all those things, suppose the clip is too close to the main renal artery and you are not able to put a silk suture, would you like to take it off and then repair it ex vivo with a proline or something?
Yes, sir. Especially in robotic, we don't want to take any chance in case the clip, slips while manipulating. But in open, sometimes we leave if the clip is being applied very properly and it is, we feel that it's okay, then we can leave the clip, don't remove it and suture it. But in robotics, we do.
So just a quick comment here, Dr. Samit. So I use ligature. I don't put any clips on adrenal, gonadal vein. I just take everything with ligature. So you guys, I think Dr. Devendra was also saying he does the same. You guys don't use ligature, right, at all?
No, sir, we don't. We are little traditional that way, tying it off with the suture so that you are at peace with yourself, because we have not used it probably. Once we start using it, probably we will do that as well.
Yeah. And the way you are benching this, like we bench all the kidneys like this, whether it is living donor or deceased donor, we tie everything around the hilum so that normally we do not see any bleeding from anywhere after reperfusion. So, after reperfusion, we right away can move to the ureter and finish the case. So this is like very good. So you don't do like this in every case then? You only do this for robotic, this benching?
No, in robotic, we tend to tie off everything most of the time with suture. But in open, see the lateral fat and everything, we just cut it. And if required, if we see a vessel going, then we put a clip.
Okay.
So we are more meticulous when we are doing robotic. But yes, we do the hilar dissection like this in the open as well, tying off, clipping off all the lymphatics. But with the perirepheric fat, we are a little more, you can say, casual.
Right. Question about usage of ligature. It is a difference of practice in India versus US. Once you try to use the same ligature 5th time, it may not coagulate the vessel very well.
So we don't use it more than once.
That's what. That's the difference. That's why we are more relying on the human hands.
Well, you can use all these energy sources. There are reports and all those things. But when you want to be overconfident, it's always better to put a suture so that, you can have a peaceful sleep. Yeah. Well, yes, everything has got its own indications. As we are progressing in technology, every day we find new things coming. We have to get adapted to those things all those years. We never thought when we started that a day will come when we'll do these operations robotically. But now everything is happening. That's what happened to laparoscopy. When people started doing lap chole, they said, no, what is this? I can do small incision and take out the gallbladder. But then now nobody talks about that. So it is the evolution of everything. You never know. Tomorrow there may be something much more finer, much more reliable than what we are seeing it today. All our youngsters who are seeing it today, probably we may not be living and they will see something else.
I heard all the conversation around loops, so I'm going to make one small comment. So I've used loops for the greater part of my surgical career in the last 20 years. But over the last 5 years, I've stopped using loops altogether. That was because of problems with shoulder pain, neck pain, and whatnot. Especially when you're doing surgeries like liver transplants, where your neck is like this for 6 hours, sometimes in complicated cases for 12 hours. So it really messes up your neck and shoulder. A friend of mine gave me a very good advice. He said he's been doing all these vascular surgeries just with readers, simple readers like +2, +2.5, +3 readers. So I tried that, and after that I have not used loops last 5 years. I just use +3 readers, which is my normal vision glasses that I use. It really has. I'm no longer taking pain medications for my shoulder. Earlier I used to get intra-articular injections into my shoulders every 6 months of steroid for shoulder pains. But like my life has dramatically changed, and the outcomes of my surgeries have been pretty much exactly the same.
Well, this is no. It's just quite. It's just getting used to something, and what you adapt doing something. I have not been using. He's absolutely right. I'm using the same thing for my. Yesterday I did 2 arteries. They're smaller arteries, no problem. But yes, I do not defy that if you get used to the loops. My cardiothoracic surgeons, my vascular surgeons, they all use it. There is an advantage. There's no doubt about that. You got to get used to something. And if you're comfortable with something, well, carry on till the time you can carry on. A day will come when I may have to use it, and I should get used to it. Whenever I try to do it, I find little cumbersome, and I find that I don't have any extra advantage. But yes, I fully agree with my colleagues, the younger colleagues. If they start using it well in time, you get used to it. You adopt to your posture also. You adopt to your way of doing the things, and I think you will feel more comfortable and you will do a better job. Okay, let's go back to the operative field now. Yeah, any question, please?
Yeah, I have a small question to Dr. Rajiv. You said you use Ligashore for adrenal, gonadal. Do you use them for lumbars as well?
Yeah.
So, do they occlude these vessels reliably? Have you had any complications?
No.
No bleeding complications at all?
No.
So, how many cases?
So last 10 years.
Last 10 years.
Yeah, no, 0.
So, sir, is there an instance where the ligashore sealant has popped off once you put on the recipient? No. So you don't reinforce with clips or ties?
We tie everything on the bench, as I was saying. So our bench is very expensive. So we tie everything on the bench. It is in the donor because we use staplers. So if you're going to use clips on the adrenal, then it might be in the way of your stapler, and you will not get a good, staple line, and you might have some bleeding from there. So that's why we don't use any clips on those.
So I understand. So I understand that once you take up the kidney, then you do ligate the tributaries. Fine.
Sir, any energy source, which is, even a Surgicel, something which hemostatic agents, they cover up for our technical difficulties. Even why in robotics only monopolar, bipolar was there was no harmonic, nothing to begin with, and still it could overcome all the laparoscopic advantages of harmonic, ligashore, and nothing was there in robotics. In last 1 year, in my personal experience, I have not used ligashore or harmonic in any of the nephrectomies, including donor nephrectomies. We only have a monopolar and a bipolar cutting type. So you can apply pressure when you want coagulation and when you want to cut the tissue. Most of the dissection is done with the bipolar. Even with the last 5-6 radical prostate also lab, I have not even used a clip. All the pedicle is done with the bipolar. It's just getting used to.
Thank you, Aditya. Now all the people can see that he is perfusing and he is trying to check if there is any sort of leak anywhere. Am I right,
Yes,
Samit?
That is what I wanted to show. We
So,
do it in all our patients
yeah.
bench. So there is no leakage, so you can be sure that when you declamp after anastomosis, there won't be any bleeding from the hilum.
Yeah, we appreciate Samit. I think this is one of the very, very important prerequisite before you are pretty sure that there is no, small little leak you are left behind which will bother you later. So what are you planning for this small little friend?
Sir, what is the opinion of the house?
My opinion is just relax and let it lie down coolly.
So I would wait to reperfuse the kidney, and then you can just put a clip on it after reperfusion if the the area is really small?
Rajiv, we are planning to do a robotic transplant, and it's a very small caliber. It's difficult to transplant. So we have to do it on bench only.
If at all you really feel there is going to be of any advantage, you cannot weigh the advantages of the main artery to the disadvantages of a small little artery.
Being perfused by this artery, approximately.
The English is a very nice language.
Hello.
Yes, sir.
Yeah, I'm Anant Kumar. So
Hi.
I wanted to know the opinion. Invariably what we do, we re-implant, but you can see that it is reaching with difficulty and it's very small one. So we have two options. Either we just put a clip here and not to do anything and perfused area is very small, or we can do re-implant. Usually both the option will be good, but I think this is too small and coming with difficulty, so I'm planning to clip it if everybody agrees.
Yeah, absolutely. You can
I think it should
safely
be
clip
clipped.
it. I think.
Yeah.
Okay, just clip it.
It's such a small artery that, you're jeopardizing, increasing your time. If you're going to do at all an end-to side, then even the main renal artery, you can have some complication inside the main renal artery.
That's
for
what
just
I meant.
1.5, exactly, sir. Just for a 1.5 millimeter artery, increasing the operating time, jeopardizing the main anastomosis, it's not worth it. The only indication I think Bhatyal sir would have been if it at all is at the lower. In the lower you have to do every effort to preserve it, but this I think can be easily clipped.
Bhatyal sir, what is your opinion about at this stage for the bench part, keeping kidney submerged in fluid versus just kept on ice like that? Is there any difference? I have seen people just, liquid ice and just keeping kidney submerged, partially submerged.
You see, the main factor is that it is slush. It is ice slush. It is not ice water. It is not ice pieces. It is ice slush. I still remember way back in 90 when I went to CMC, Dr. Gopal Krishna was doing a transplant, and later when they perfused the kidney, the fluid was little more than ice, a little less than ice slush. Somebody asked him, and it is typical that little South Indian, I am also a South Indian graduate, what is that? Yeah, this is water, cold water, it will do. And it functioned very well. So it should be ice slush. It should not be the pieces of ice, really hard ice, which will give rise to problems also. Ice slush.
The field is moving towards normothermic perfusion.
Yeah, things keep changing, when I started this thing, we did partial effectively by using inosine. You must have not heard about that. I had a project of inosine which used to preserve prevent breakdown of all these ATP, DTPA, and this thing, adenosine monophosphate, triphosphate, diphosphate. I still remember that whole thing going on. We used Dr. Andrew Novak came in USI meeting, and he saw me a partial nephrectomy using inosine. That paper got the best paper award. So those were the days. It went out of vogue. Things keep changing, Today we are talking about all these agents to see the vascularity and all these things. Tomorrow you might have something better than that,
Hello, Bhatyal sir?
Yes, sir.
Sir, as you can see, we have spatulated the artery.
Yeah.
And put in a proline stitch for manipulation. We will not touch the artery. We will use this suture for manipulation while suturing inside.
Sure. And somebody tell me one thing. Which side you would like to spatulate the artery?
It's a debatable thing, sir, but we usually do it on the lower side.
Okay.
But we have seen some of our colleagues doing it on the upper side also, towards the upper pole.
Okay.
So until unless it is wide, well spatulated anastomosis, I think the side does not make much of a difference.
Samit, this thing is there, that we observed that whenever we spatulate in open surgery for anastomosis to the external iliac, we always do it towards the foot end.
Yeah, that is what we have done.
So a quick comment here. So in my practice, I have, even for living donors, I've never spatulated the artery at all, ever. What I do is I remove a nice disc of the anterior wall of the external iliac, which is larger than the diameter of the artery. So when you're anastomosing that, it automatically stretches, and it's a very nice diamond-shaped anastomosis that you get, and you don't lose a couple of millimeters by spatulating when the arteries are usually very small in living donors. And I've never had a vascular complication in my career, be it stenosis, be it thrombosis.
No, I think you are very lucky for that matter. But to my younger colleagues, I will always say that the spatulated anastomosis gives the wider, because stretching of an artery doesn't give you really that anastomosis which anatomically and physiologically would matter. So it's always better to spatulate the anastomosis because it is not going to be 1 or 2 millimeters. It's going to be less than 1 millimeter or about a millimeter of spatulation. I was taught way back by the surgical team that vascular surgeon that always spatulate these small arteries. If you are anastomosing 2 arteries, whether end to end, side to end, spatulated anastomosis always pay you in a higher manner as compared to what an unspatulated anastomosis doesn't pay you. So you are, well, if the caliber is good enough, you don't need a spatulation.
But yeah, sir?
Yes, sir.
Can I draw your attention to the camera where we are operating? We are going to make a gauze jacket out of a single gauze.
Great. Yeah.
And you must always use fresh ice rather than this ice which is now a little solidified.
Yes. It should be a little slushy.
Yeah, so a separate ice which is being prepared.
Yes.
And we will use that fluffy ice slush.
And you are making this opening to take out the, you know,
take out the
artery and the vein.
And the ureter will come out from down.
Yes.
So you will see which end is which.
So this is the ice slush which you have made now.
Yeah, this is the fresh ice slush.
Yeah.
You see? Here. This is freshly made. You can see the sound of the slush being made.
Very nice.
You see the ureter coming out
from the lower end.
So that you know which one is lower and which one is the upper end.
Yes.
You also take a suture mark.
Yes. Yeah.
Silk suture.
I just had a couple of questions to Dr. Raj. Can I ask? Yeah. Yeah. So, no, why the robotic transplant has not been widely adapted in US?
No, I think we'll ask a little later. Let's finish off this thing because he's very keen to demonstrate all these things.
Yeah,
and I think this is more important now at the moment. We can have your question a little later.
Thank you, sir.
Yes, because it's my job, you know, as a chairperson, people should see as to what's happening in the OT.
So this is the upper side,
Yeah.
end, that we are putting a stitch, and we'll keep a end of the stitch little longer
Yeah.
to identify its upper pole.
And you will suture it all around.
Yes.
And your ureter is popping out from here?
Yes. You can
Yeah,
see
that's
the
right. And how much should be the opening for the vessels to pop out?
No, I will show you, sir. It's about 1.5 centimeter.
Should not be too big also, no?
Yeah, it should not be too big, but that depends on how wide apart the artery and vein are. If they are wide apart, then you need to either make 2 or make a bigger one.
Okay.
But most of the time, you know, with experience, that most of the time the artery and vein are close by.
Yeah.
So 1.5 centimeter opening is enough. Otherwise, the ice will be popping out or the fat will be popping out.
Yes. That will give difficulty in doing the anastomosis at that time.
So Dr. Samit, don't you have, like we use what is called a SOCK, S-O-C-K, instead of the gauze that you're using. So it's a kind of a pre-made thing that you don't have to suture. So is that not available here?
No, that is not available. What we usually do is we use a green or brown glove, number 7. We put ice and we tie both the ends. So tie one end, put some ice in it, then put the kidney in, then tie the lower end as well, and through the thumb you take out the artery and vein, the cut in the thumb area. So
Okay,
we take our own sock and use it.
Now you can see that it's a lower end, and I have applied an aberdeen, and I am cutting the long end very short. So now it's a loop, but you can identify it's a lower end.
Okay.
And you can see the ureter as well.
Yeah.
And here you see the area of the vessel.
This is the artery.
This type of thing.
And here it is a vein. And you can see that we have already...
No, here because they take little time. In open transplant, I never put any gauze piece also. You just take the kidney there and suture it. But here, because they just want to keep the... Yeah.
Yeah, I think this is to keep it cold to minimize the
damage
during the warm time.
Yeah.
No, you get something to handle also that. The kidney, once you perfuse, you can handle the kidney with a gauze piece. That is more important.
Vein and artery, small prolene suture.
Yeah.
This is
Say, they both artery and vein are on the same side.
Yeah.
Same side? Yes.
This is the vein.
Yeah.
This is the artery. And these are the top end sutures for manipulation.
You can see that we have removed the clips applied on the lumbar tributary as well as the adrenal.
Yes.
And we have tied it. So there is no humeral clip now on the graph.
Yes.
And the ureter is also spatulated here only after seeing the orientation at the end.
Yeah.
So that you don't have to do it on the
intracorporeal.
But Samit, the ureter can be, spatulated even later once you have achieved the.
Sir, we have had a problem once in our initial phase when the ureter was too long and we spatulated it on the different sides.
Okay.
So now what we do is we spatulate it. If you need to extend it more, cut the length of ureter, then you know which side is antemesenteric.
Okay. Okay.
So these are small little modifications that we have made.
Yeah. No, you are nearing, I think, more than 500 transplants now?
Yes, sir, nearing 500, more than 450.
So, obviously, you must have made a lot of modifications, your own observations over this period.
Yes, sir, yes, sir. So,
Which
we
is
are ready to go to the robot.
Yeah. I think this is now very, very important. Before you transport it, my friend can ask question to my friend on the right side. During the transportation, we can have a little chat here.
And second question was, what's your take on robotic donor and robotic
So the first question was, why is robotic kidney transplant not widely adapted in US? I think in US most of the transplant surgeons have a general surgery background, not a urology background. So as a urologist, you are already doing robotics for so many other things. So the learning curve for a urologist is smaller. And then, personally, if you ask me, I take about 2.5 hours to do a kidney. And if, anything exceeds that time, I start questioning whether it is really necessary in my practice or not. But I think what I'm learning is it's easier for the surgeon robotically to do a kidney transplant than open. But again, that is the main reason, because the learning curve for a general surgeon who's not doing robotics, but it's changing now, in my era, but we are the ones who are running the programs. So the younger generation who's now getting trained in robotics and general surgery, they are more comfortable adapting. But those who are running the programs are not.
Okay, we are back onto the recipient now. Samit? Dr. Samit?
Hello.
Yeah, Anand.
We are back to the kidney has come to the recipient side.
Okay.
And that's the pharyngeal incision is given. It is 6 centimeter incision.
Okay.
And rectus sheath is cut, muscle is splitted.
Okay.
And from here they will drop kidney longitudinally inside
Okay.
towards the right iliac fossa, and then they will close it, and then we'll start the procedure. The disadvantage of this incision and not using any device like gel port or any other device is that you take longer time, and because once they'll close, I have counted, it usually takes 9 to 10 minutes before kidney is closed and I start positioning the kidney.
Yes.
If you are using any device, LX device, or you're using the gel port, in that event within 2-3 minutes you are ready to
start
position the kidney and start it. So this 6-7 minutes time is lasted, but you save significant amount of money. If you are not using gel port, you are saving 50,000-60,000 rupees, and that other one is also around 25,000-30,000 rupees. So you save that much of money. In extraperitoneal transplant and obese transplant, we are using that LX device, and in a very obese patient we are using gel port, and because in gel port we can use one of the port through it. And so these are the thoughts, and now once the kidney is put, it is closed and we will start the transplant.
Yes, Dr. Yadav, there was a question from you. Don't think I have forgotten that.
Thank you, sir.
Yeah.
Regarding spatulation versus no spatulation of donor artery, with a 4 mm donor artery, I mean, as Dr. Rajiv rightly pointed out, with a wider recipient vessel, it will take care of everything. With a smaller caliber like 1.5 or 2 mm, spatulation really works, and they also need a intermittent suturing as well. So that's my.
Yeah, you see, there are always plus and minus points for these things. There are always, postulates on one side and dispostulates on the other side. But it's always good, whatever you feel is good in your hands, whatever you have seen over the years, it always matters.
I just agree with the Rajiv, because I have also not speculated. Just with the last with the mosquito, just small, it become a good caliber. Only in the last case, about 2 cases, my aortic punch, that had a problem.
Got stuck.
And that cut was, it was made much bigger than what the size of the artery. In that case, I just speculated and did the anastomosis. Otherwise, normally, if artery is good, I don't require.
Sir, that's what I submitted.
Routinely, I'm not doing.
No. What I submitted was, if the caliber is good and the caliber is big, you have to see it on the table. But it is always good to do a spatulated anastomosis advocated by all the vascular surgeons. Yeah.
Okay, I will just tell you, recently we had a vascular surgeon from Switzerland, like the 4 doctors came for the win. Dr. Thomas Wolf, his name is a very famous vascular surgeon from the Basel University. So he said that they don't do any spatulation nowadays, but while he was watching me, he said, but this spatulation looks good, and he advised me, like Dr. Bhatyal was telling, this spatulated and foot end. He has spatulated, do spatulate at the upper end, and since then we have changed it, and we did not make any difference whether we are doing it foot end or top end. And so most of the vascular surgeons are not doing spatulation, but smaller vessels like in coronary artery bypass, you go and see them, they always spatulate and put it end to side with that in a bigger anastomosis. And the aortic punch, I'll tell you, I think 6 months back, one of my colleagues, while doing the spatulated punch, he took the side wall of the artery also, and we didn't realize. We only realized what happened when we flushed it before closing it. We saw that some fluid is leaking from the other side of the artery also. Then we went there and checked it. Part of the artery was removed from the punch there. So what happened? Fold of the artery came into the punch, and that is also removed with that. So we closed it luckily, and we could see it and stop the massive bleeding from there. So one has to be very clear about using the punch. And if the vessel is atherosclerosis, it's very useful to place it centrally and just make a nice punch. because otherwise if your hand is shaking and punch is going here and there, then it will be irregular cutting it, and that if intima retreats, you have to make sure you are seeing the intima in a atherosclerotic vessel. Otherwise you fix the intima or take the suture in such a way which goes inside out and little bigger suture in external iliac artery so that all intima get fixed. Otherwise dissection may be a problem. So punch is a very good thing, but in robotic surgery we do have a punch, but that punch costs 15,000 rupees, so we don't use it. We'll show you, we have a simpler way of stabbing the external iliac artery and removing the edges of external artery to make it a nice punched hole.
Yeah, Anant, I also had a couple of problems with these punches and I stopped doing using this punch. We make a small stab and make an arteriotomy. Yes, Yadav, anything?
Regarding the punch use, I mean, since we use it multiple times, it's a disposable punch. That's the problem lies here. If you are using it once, every punch is going to work the same way. Another thing about spatulation is, I mean, similar thing happened with me. I mean, my assistant has given me a punch size greater than the donor size. And once I realized it, and now we are routinely doing it. We are having a good disc of external iliac more than the donor artery, and similarly for internal iliac arteries.
In any vessel that has greater than 5 mm diameter, you really don't need spatulation.
Absolutely right.
One thing I'd like to add about the spatulation or no spatulation is that if you use a pot scissor to spatulate, the vessel, that's okay. Like Dr. Rajiv is not spatulating. So you can just cut the artery obliquely. It's as good as, you get the best of both worlds. You're not spatulating, because sometimes when you're spatulating, then you tend to get a little bit of dog ears in the last. So instead of just cutting it straight, just, cut it obliquely, and I think that choose the middle path to salvation. You can do that also.
So the only reason, I don't do that is, so in livers, we were doing that if we had length. In living donor kidney transplant, you have smaller vessels, and you're also dependent upon your retrieving surgeon, how much length you actually get, unless you're doing it yourself. So even a couple of millimeters, in my experience, I don't like to lose any length on the artery or the vein in living donors. I want to have as much as possible, even if it is a couple of millimeters more. In very small vessels, that a few millimeters helps. So I wouldn't do that unless I had to. If it was a very tiny, I've never seen a main renal artery that is less than 5 millimeters. So I've never had to do that. But if it's a very tiny artery, then it makes a lot of sense to spatulate and to cut it obliquely, because that's a better way to have a good arterial anastomosis. But in an adequate lumen, I think you're overdoing it by spatulating. I mean, that's just a personal opinion. Everyone does what they're trained to do, and that's what they should do. Whatever you're comfortable doing, that's what you should do.
Okay, we are back on the robot now, and I think they have docked the robot again, and the scope is in, and we can see.
We are going to put the port.
Yeah.
The instrument through the ports, and then you can see that this kidney is nicely dropped.
Yeah.
And it is quite oriented. We will just check the orientation, and then bring the kidney close to the external iliac vessels.
Yeah, you want to say something?
Yeah,
short and sweet.
Use the 6 instruments.
Yeah.
And so these are the 3 additional instruments we have to use it. One is this black diamond needle holder, which it is under view.
Okay.
We use the pot scissor. That is another instruments we use.
Can we see the pot scissor?
Small needle holder. So most of the time there are 4 instruments, but here these are the instruments are used. So now the first thing we do it, make sure that our orientation is okay. So now the top end, this is the single suture, and the lower end there will be a loop suture. So that we know that that is the upper end, you can see there is a loop suture.
Okay.
That's fine. And here is the vessels, here is the bowel. So my assistant will move the sigmoid colon and bowel with the bowel forceps, and Deepak is very good in doing that. And then we will just bring the kidney here. And so once the kidney is dropped here, We will see where the artery is falling, where is the vein falling, and then I'll bring that my prograph, and the prograph will stabilize the kidney and will help in various procedures. So now what I will do, I will check how is my vein is falling. Always make sure that vein is not twisted. So that's why this is the upper end. And when
You're catching the suture with the
black diamond.
this is the proline suture, tagging suture.
No, you are catching it with the programs.
We are just, this is the suture, this is the bipolar.
Bipolar, yes.
Yeah, so see, I'm just seeing how big it is.
Okay.
And you can see it is not rotated. So here is the vein comes,
Yeah.
and here will be the artery come. So
Okay.
that looks okay.
Yeah.
So now that part is fine. So I'll ask my assistant a clamp over the vein, and here we have to make sure that this clamp is not very distally. You can see that there is some, if that vein is there, then is pe jara wo lagao.
So just making a point on that spatulation.
So what I will do, I will just take it now, and
I think we'll discuss it a little later, if you don't mind, please.
yeah, just we'll put this probe like that,
Okay.
and now proximal will be.
So this
proximal will be distal to the internal iliac vein.
Okay.
So that it won't distend. So now I'll hold it like that, and Deepak will show me with this suction, and this I will lift this vessel, and I will see it here. So if I apply it here, and
Yeah.
you have to make sure that your vein is not distending.
Okay.
If your vein is distending, it means it is not there. And once you put it, make sure there is no branch here.
Yes.
Okay. So that's fine, and vein is not distending. Now what I will do, I will bring the again just little bit here. I'll just use, he has taken my bipolar, doesn't matter. I will move it like that, and then I will bring it like that. Okay. So now what I will do, I have to do venotomy. I will recheck how big should be my venotomy. So that should be fine, and it's very simple. I can just cut it here little bit, and then I go inside and I cut it, and Deepak, can you flush it? So we use this ureteric catheter, and with hep saline we flush it nicely. And that stage I will reconfirm that there is no blood is coming from anywhere, it's filling, and I will recheck whether it is my length is appropriate, or I have to cut little more. So I will just check. So yeah, that looks like that. I will just give 2 to 3 millimeter here. That should be all right. Give me the bipolar. Bipolar. Something always happens when during workshop.
No, this is a minor thing. For you, it is nothing. There must be small little tributary or something.
No, this is the, yeah.
This is from the artery.
Yeah. Okay. Now give my needle holder and suture. Now we have our this technique which we have evolved after a struggle is under preparation. Is already submitted and reviewed. It already that comments were received and replied, so probably it will be coming out soon. And this technique is very simple technique, and this helps us in cutting down the time. of anastomosis and make it a very simple anastomosis. So they take 6 inches 6 centimeter क्या लिए 4 inches sutures which they tie it here. So this work as a tagging suture. So I don't have to tie at this end, and then this is the 60 Gore-Tex sutures with 13 mm needle. So this Gore-Tex suture comes in 13 ml, 19 ml. You can see that like there is a little traction. So what I will do, my fourth arm will bring the kidney. I can bring the kidney like that. Now there won't be any traction. So fourth arm will push the kidney.
So this is what needle are you using now?
It is a 9 mm. Sorry, it is 9 mm.
Okay.
So now we were outside, we'll go inside, and from inside will come outside at this corner, and then this will go outside in the renal vein. So this is, once that part is done, I'll pull it. And now you can see when I'm pulling it, knot is coming there. And this suture stays there. It's not like proline. And it has got a reasonable strength. You will break it if you are putting too much of pressure. But in proline, even little bit of pressure, it breaks it.
Yes.
And it has got the memory. And we try to avoid the catch the vessel. So this sutures, otherwise this black diamond forceps is very good, and as per the manufacturer you can use it for the intimal holding. It is like similar forceps available in our open surgery. And after 2 sutures we just pull it, and when you pull it, you should pull it in the direction of your suture so the hole won't get, if you pull it that side, your hole will become bigger. I think today the beam suture is little longer than what is required, but anyway, doesn't matter. You get gentle tag and hold for few seconds, 4-5 seconds, so that it get fixed. Otherwise it becomes loose, then.
Yeah, it has got that memory and it swells up a bit.
Yeah. You can see I measured it, still the venous length is now looks more. So I will just adjust it, do little bit of cheating and adjust that.
So Dr. Anand, how are the ergonomics with this, like especially with your finger, thumb and neck, with your position, like you're doing this for other urologic indications as well, robotics. So how are the ergonomics with this? Like, do you have pain in your, say, hands or?
See, now you touch the my nerve. I was doing very well, and I thought, oh, I'm so lucky, nothing is happening. But last 1 month, I'm feeling some neck pain, especially when I finish it. Okay. So I talked to the neurologist. He told me to do some exercise, which I started doing it. But still, I get getting pain, especially like suppose like I'm doing it like that, it is okay. But when I finish and get up and straighten it out, then I feel the pain, but that pain disappears after few minutes. And that new system which 5 system which has Surgical Intuitive has bought it, in which it is that console is not like that. Console is straight and it goes and fits as per your face. So as you do in open console, you look straight to the monitor. In the new one, they have done it, and this is probably because many surgeons have developed cervical spondylosis and neck pain. So that question is very relevant. We used to say that a surgeon is very comfortable, but yes, you can get into the problem. And
yeah, cervical is there. Even when we do this thing, after some time, you do have.
Just take a minute to at this stage. Once I pulled it, now I don't want it to be loose, so my fourth arm will come.
Yes.
And my fourth arm will hold it like that, and keep the fourth arm like that. So it is away from my vision, but it is keeping suture tight. And now I will start the anterior anastomosis.
So I think it is very important for the fourth arm to maintain that pressure should not be too much also.
Yeah. So
tear the vessel.
Very soon you will, and I have broken few sutures in the beginning.
Okay.
But now I know how much suture, how much pressure is to be applied.
Yes.
And again here what I will do, I'll just pull it again. So that, and just wait for 4-5 seconds. And then after 2 suture again I pull it, so that this knot is nicely sitting at the corner and probably avoid. But sometimes we have seen that there is some oozing there, but venous oozing little bit, it just stops without much problem. Very rarely we have to put one suture at that angle also. When you see like that, always it means it is getting stuck somewhere. So don't pull it, look up and take care of that. Now you see, I'm just putting it for 4-5 seconds and it will just stay there.
You're making it look very easy.
And you're keeping the whole audience spellbound by. No, you are doing it so well that the whole audience is absolutely spellbound.
Thank you. While you are taking the suture, make sure that don't take opposite wall. So what we do, we keep it like that and then lift this part. So we know that we have not taken the posterior layer.
It's a great advantage is that magnification is and the 3D image is so good. Of course, everything matters by your meticulous handling of all these things. It is not that it is the surgeon behind the machine who matters, but the machine has certainly got a lot of advantages which are given to the surgeon.
Absolutely.
Still many patients says, no, doctor, we don't trust robot, we trust you, you do my open operation. So we have to explain to them, show the photographs and things that, no, I am doing your operation, the robot is not doing your operation.
You can always tell them the robot trusts you as much as the patient trusts you. So it's a mutual understanding. Very nice.
Anand Kumar sir, it's Kishore here. So I wanted to ask the challenges that you had faced while doing a right-sided donor for a robotic recipient.
A right-side donor, I will say there is no challenge, it is easier, it facilitates doing because vein is small, just sitting there. Just can you cut it here? And right side open donor, open stitching of the right renal vein is more difficult than robotically. Robotically it is very easy. It is sitting there. I'll just very lately, I think maybe 3 weeks back, we had a very short vein, and with the 2 arteries. So after repair of the artery, I was little scared. But and I was doing the left side, second transplant. But everything went well so nicely with the short renal vein on left side that now I'm convinced if there is a right side donor nephrectomy, one should do the robotic transplant.
So you mean it is easier to do compared to open?
And this is the one thing is that when you finish it, you pull it before you tie it. Now I'm giving a sustain and then I'm tying it.
Yeah.
So whatever suture has loosened in this time frame, it will just get tightened again. So.
And have you
So
performed
that way
the...
you might have noticed we have done only one time. Otherwise, if you just tie it here, take another suture, tie it here, so you will be tying 4 times or 3 times depending on what technique you are using. Here we have just tied once.
Very good idea.
So we have saved the
time.
And now I just started exactly at 12:02. So it takes 17 minutes to do this anastomosis. Usually we take 15 minutes. Yeah, just take this suture out.
So the stay suture has come under the cortex. Is it? I mean, is that okay?
We often remove it. It doesn't matter. It's a proline suture.
Yeah.
So even if it stays there, it doesn't matter. You can always pull it. I'll just pull it.
Okay.
You can just see. I can do. Okay.
I think it just stays there. There is no harm.
It doesn't matter. But sometimes we just remove it if it comes in my way. Otherwise, it will stay there.
Yeah.
And now, what we do, like if the vein is very short, we won't do this procedure. Then we'll let it be like that. Put to one bulldog here and one and these 2 venous streets. But here, since there is a good length, I can put one here. There is a one advantage. You can test it how your vein is, and then you remove the proximal one first. Don't remove the distal one first, otherwise the vein will get engorged and there will be bleeding. So you put it here, make sure, and then you remove it, and you can see. Okay, give me a suture. It just got loosened for somehow.
Yeah.
Give me a suture. जो बचा हुआ दे दो उसको. Usually it doesn't bleed like that.
You mentioned that during workshop something has to happen. No, I think it is quite understandable.
But this is the.
Isn't it too short a suture?
It will become all right.
He will manage.
In artery, we don't try this single knot because of this reason. The artery always used to bleed at this junction. That's how we change with the arterial part. But in the vein, it is quite okay. Okay. Just cut it. Now it's okay, all these small oozing will stop. Maybe I'll just push it little further down. Yeah, I've seen it. I'll just avoid it. Okay. So now this is my artery. So I'll see where it is falling. It is falling with some tension. So that's how again the fourth arm helps us push the kidney, and now it's coming nicely. So I'll just keep the fourth arm like that for the time being. And now give me pot Caesar. So it is going to come here, and this today's speculation is foot end. Okay. So see, it's very simple. This is the
pot Caesar.
My jaw, my pot Caesar. So I keep the jaw parallel to the artery and stab it. Artery is distended because of the trapped blood, and it goes in this direction, and now I'll just cut it. And then first I'll flush it. So I don't need any blade or anything. And once it is flushed, I will check again how much length is required. So I know I have to cut little bit here, and then I will take the edges of the artery, so it will give you the same effect what you will achieve with the punch without using the punch. You can cut little bit of opposite side also if you want to do that. What I am doing is not necessary, but just to look good I am doing it, because your suture will take care of it. Same thing, you can cut it here. So what Dr. Rajiv was saying, that give you very open lumen, and when you will put when the artery is pulsating, both the edges will remain apart, and that stenosis will not occur. So that's how now this will happen again. Give me suture. And then in robot, that aortic punch is done by the assistant, and he will come. You can only use it if you are using the gel port. If you are using the like phenol incision, then we don't do it. And our phenol incision has another advantage. First thing, it is cosmetically lot better. It is not seen, it is just above the pubic hair. Second thing, for some reason you have to open up, you can extend the same incision. Otherwise, if you put the gel port at the umbilicus, then you have separate, completely separate incision.
Yeah, this is as good as a punch what you've done, so you don't really need a punch for that.
So when I say you save this much money, then everybody says you are anyways throwing the money on robot, then why do you want to save it? So I said whatever I can save, I can save. What I cannot save, I cannot save.
But you know, this type of arteriotomy is really always very good. Punch is also good, but those who have faced problems, they always weigh these things, you know, sometimes.
Yeah, I didn't realize that they were being reused.
Yeah,
the
they are.
punch. Okay.
Anant, there's a question that in chronic diabetic patients, where probably he means that if there's some atheroma and all, would you like to do this type of arteriotomy, prefer to do this type of arteriotomy, or would you like to prefer punch if you have both?
We often get the patient with bad atheromatomic, and in that even we often do the plain CT to see how bad is atheroma and where is my place to put it. And so we do the same thing, and I have a video, we can show it. I think in last meeting we did show it. So what we do, we just fix the atheroma and then move forward. Or take the suture in such a way that atheromatous intima is fixed all the way.
So do you not do a non-contrast CT for all patients as a part of evaluation?
No, when we suspect, we do it. Otherwise, Doppler is done in our patient.
Okay.
Now you can see that this fourth arm will be holding it. Rather an open surgery.
We do plain X-ray for every patient, just to see roughly, you know, you have an idea. Then we go for higher investigation.
We do a non-contrast CT as a part of
I would like to
eval.
say, you might be watching it, might have not appreciated.
Which one?
I'll just show you. I tell everything, whether you do open surgery, you do robotic surgery, especially in robotic and osmosis, you always follow the curve of the needle. In surgery, if you follow the curve of the needle, your holes will not become bigger.
Yes, yes.
Like you can see here, this is following, and like it is gone here. And what I will do, I'll show you. So when you are pulling it, you pull it like that.
Yes.
And especially you are doing prostate, urologist will appreciate in urethrovesical and osmosis if you don't do it and then pull it like that, otherwise your holes will become bigger.
Not only that, urethra will come out.
Urethral hole will become bigger.
You want to ask any question, please?
Yeah. So you don't put a knot routinely at the apex? Knot. So the knot was not placed.
So he says you haven't put a knot at the beginning end.
Yeah, I will show you. That's our technique. We'll show you. Yeah, I'm just going to do that. See, here I'll have to, before tight this one, I'll have to pull these ones. Otherwise, it, like proline, it won't pull everything. Now if I'll pull it, it will be okay. Now, yeah, you notice that I didn't tie it here, there at that end, and I'll pull it for, when I finish it now, what I do, I'll put one hand here, and pull it. So this part is tight. And now what I'll do, I'll leave this one, fourth arm will come here and keep traction here. I'll take another suture, tie it and tie this one, and that suture will come and tie it here. So in spite of tying, instead of tying 3 knots, we'll be tying only 2. So now he will bring another suture, this will go up, fourth arm will come here, and fourth arm will keep traction, and while again I will do it like that, so my traction is maintained. So that is just to avoid one tying knot and saving time. Probably it may matter because you might waste 3-4 minutes in doing various knots in beginning when I was also struggling, and then we were taking more time. But now probably if I don't do it, doesn't matter because we are still doing in acceptable time frame. So what I am going to do, I am going to tie this one.
Sir, here, why don't you take a pre-knotted suture like how we use for vein?
It doesn't work in artery. I don't know why. We tried that. Artery always used to bleed as the vein bled today.
Okay.
So vein never bleeds like that. Or now I don't say never, but because it bled today. But artery always, very often it used to bleed. So we decided that not to try the same thing in artery. I don't know why, but so that's how we changed that technique to this one.
Dr. Anand,
yeah,
you got such a wonderful surgical acumen that everything works like wonders in your hands.
Thank you. Don't say too much, otherwise there is some problem now.
That you will attribute to me.
Sir, you have done on internal iliac arteries anastomosis robotically.
When something is going very good, I always get a sixth sense that something is now going to become going wrong. So be careful.
By that time, I would have left the stage.
Sir, you have performed on internal iliac arteries robotically?
We not yet, but we have seen that there is no problem. We can do that, and with internal iliac, I have thought over how to do it, and there should not be any problem because we do similar uretero anastomosis, some other anastomosis, nothing happens, and the same thing I thought that can be done, but for some reason we haven't done it, but we just in next few weeks we will do it in a young patient where we want to use the internal iliac artery, we will use it.
And what about inferior epigastric for a double vessel and...
Yeah, inferior epigastric I have not used it. You know that I have been advocating to make it one vessel and do the single anastomosis, but there was two occasions where these arteries were so far apart that they can't be reimplanted, they can't be bring together for pantaloon. So we did a separate anastomosis in external iliac. And inferior epigastric I have not used it, Dr. Alawat has used it, but it can be used. But somehow I feel that if I can make everything into one anastomosis, I can cut down the warm ischemia, re-warm ischemia time. And we have been able to, we have been used, we never, never rejected any patient for robotic or open surgery for multiple vessels. So in robotic also we have been able to manage all the 2-3 arteries to do it whatever way it was suitable in that case, and either separate anastomosis, doing all anastomosis into one artery and then doing the single anastomosis. But inferior epigastric is a good option, In fact, I was the one who has published in 1996 in Clinical Transplantation Sequential Anastomosis of Inferior Epigastric Artery for the lower polar accessory vessels. And that the point was people have used the inferior epigastric artery before that, but they did not use it sequential manner. Sequential manner is you do the main artery and then you release the clamp, and then you do the inferior epigastric artery. You might take more time, but doesn't matter, because that your main artery is, major artery is perfused. I think I'll just, probably it's not coming out well, I'll just stop talking for a few minutes. Yeah, now it has come out. And then you do the inferior epigastric, and it works very well because you are not in hurrying it, and kidney is getting perfused. Rest almost 80% kidney, 98% kidney is getting perfused. I'll take one more suture. Now I'll tell you one thing. Like somebody asked, what about this suture? If your suture is coming away, what we do, we just break it like that. Now robot is very strong, it breaks it very nicely. And otherwise, if my assistant was ready to cut it, but before he reached there, I was trying to break it.
And I've used the sequential inferior epigastric that you mentioned more than once, and as you said, it's very nice. Usually it's a very good size match also for the lower polar artery. And you're not in a hurry. Kidney is already reperfused, so you can take your time doing it.
Wait a minute, I'm just checking it. Is it okay, or should I put one more here? I think I'll just put one more here.
Dr. Kishore, do you prefer doing this corner stitch under vision and ending off in the middle?
I rather end it like somewhere in between the corner and the middle. So
yeah.
What I do the posterior stitch first, okay, and then go all the way around, yes. Take 1 or 2 bites to the other side, and then come with the tie one and tie somewhere in the middle and the corner, not exactly in the middle.
Because this corner stitch becomes actually quite blind, and there is no assurance of edema also being taken in the stitch.
You can ask the Kishore. Kishore has done, I think, good number. I don't know, maybe more than 300, 400 robotic transplant. So you can ask question to him also. He is also.
Do you feel that many times at the very last end, when you're completing the anastomosis, then sometimes, as we saw, it seemed that the needle becomes a little blunt. Then taking the sutures becomes sometimes a little cumbersome also. This is what we feel inside Jaipur. So that's why at the very last end of our arterial anastomosis, sometimes we take an interrupted suture with a new needle. And we feel that sometimes, it's better. This is because it's less traumatic, and then we just tie off this suture to our continuous suture. This is something that we feel. I mean, maybe it's very subjective, but we feel that sometimes the needle gets blunted in the end.
Not actually blunt. With robotics, what happens is that it can get bent. Yeah. And sometimes even the tip of the needle can break if you are not careful.
Yeah.
So that is one issue. And second issue, when you transfer the needle to the assistant,
yes.
Sometimes it can break away and get lost in the abdomen. So that is one thing you have to be careful with the robotics. So with the Gore-Tex needle, I mean, it never gets threaded. And the stitches never get threaded or never get broken. It's very hard, difficult to break it. So
we don't use Gore-Tex. We haven't used Gore-Tex till now, but we feel that the proline suture, ultimately, once you're doing it, it starts to get a little blunt. And so that's why in the end we change our suture for the last.
I think Gore-Tex sutures are good for this type of
Sir.
In open we do this thing proline.
Yes.
But it's better. Not always better.
And here we first remove the venous suture, then we remove the external distal suture, and then we just gently open it up and see. Probably this is okay. Just give me some snow. I'll just put some snow here, and by the time I'll remove the jacket, another thing is stuff. अभी लेते हैं, रुक जाओ, अभी लेंगे, उसको रखे रहो. Now after that, most important thing is take these bulldogs out, and there is one more advantage of extraperitoneal procedures, because if these bulldogs are, while you are removing, they are just get lost, then you can easily find out if there is no much space where it will go. And here this is a big problem.
But
twice we have to
Anand, how many
put our hand from the same kidney drop side to remove these bulldogs.
how many extraperitoneal you have done so far?
10.
Okay.
We are now building up, so.
So what are the cases which you would like to take up by extraperitoneal vis-a-vis intraperitoneal?
Extraperitoneal, very obese patient will be difficult, because one obese patient we struggled, and otherwise you can do most patient, and very small children probably transperitoneal will give you more space.
Yeah.
And extraperitoneal will not give you that space. So if you need some space, give me Caesar, then probably you might have to use the intraperitoneal. Currently extraperitoneal looks more difficult, but probably once we might do more, we may be more comfortable.
So sir, you keep the kidney in a similar position in extraperitoneal, or keep it in the right side?
Yesterday we showed the video.
Okay.
We can run it today again.
Sure.
There is a problem, like when you put it, patient position is horizontal in extra, that is advantage.
Okay.
That you don't have to do in extreme Trendelenburg position. But then what happens, the bowels are sitting there, so your kidney remains like that, not sitting there. So what we have to do it, after 2 cases we were struggling, then we, after once the anastomosis is over, we put the patient position little head down, and then kidney nicely goes there, because bowel moves up, and that created a space for kidney to lie down nicely in extraperitoneal space. Or in the beginning you can do little bit of Trendelenburg position, not as much as you need in intraperitoneal procedure. So then kidney sits there. Otherwise there is a problem. Initially first 2 cases we were wondering, and there is a, when we finish remove the pneumoperitoneum, we take our probe and put the kidney up, so that bowel comes down and kidney goes back to the extraperitoneal space. So there's few tricks we have learned. So
Anand sir, Aditya
from
here.
Aditya.
Sir, my question is regarding risk of lymphocyl in extraperitoneal versus transperitoneal, because when I do radical prostate extraperitoneal, I have found the chances of lymphocyl, especially late, after a week or so removing drain and everything, patient have come back with a lymphocyl in radical prostate. How is it in transplant done extraperitoneally?
yeah, so there is a one disadvantage extraperitoneal, that you will get lymphocyl in intraperitoneal, that lymphocyl will be going into the peritoneum and nothing will happen. So so that solution given is that end of the procedure you make a nick into the peritoneum when you finished it, so that will draining. But once we tried to give that nick, there was a
Intestine came.
suddenly that whole thing was, balance of thing was not very well, and yeah, it's here, I think.
So I have a question about this jacket that you made. So your warm time was comparable to what somebody would do in open. You had the little fat on the lateral border to handle the kidney. After you have completed the anastomosis, you spent about 3 to 4 minutes now just removing this. So do you really need this jacket?
Yeah, we have, I think in extraperitoneal you might have noticed we have used the gloves and then putting it in the gloves so that, and take out the gloves. कहाँ चला गया उसका edge?
I think the jacket, jacket is to hold the kidney because you have to give incremental traction when you do the for the fourth arm. So that is the main and then to also the shift flip the kidney to the other side. So you can hold on to something. So especially with the fourth arm.
And just do it, and his results are again very good. So probably you just see that when you finish it, you will see there is all the ice is melted. But it is next 15 minutes, I think once we drop it, probably that is the time it is keeping it cool. So you can see that urine is coming.
Yep. Yep.
So that
You have a question, Dr. Yag?
probably we can get away without the
Fantastic.
ice. And but we are still doing it just to as a safety.
Yeah, your reperfusion was so quick. I mean, you don't really need extra ice if that is the only reason that you're using the jacket for. But as Dr. Kishore said, that it is more for manipulation. So.
Yeah, he must have taken about 25 minutes.
It's very quick.
For the manipulation, couldn't they have used they had kept knobs of fat, which they had kept the sutures on, and they had said that we are keeping these knobs of fat with sutures for help inside manipulation.
Yeah,
so couldn't they
obese
have
patients,
used
so
that?
it can just tear off.
I will
Yeah,
just
the
show you
fat,
why
once you
that
hold it,
fat
it
is
just
required
tears off
by
from there.
the-
So that's fine.
Regarding lymphocyl in extraperitoneal robotic surgeries, I mean, routinely for open recipients, we are doing extraperitoneal only. Even putting a nick in the peritoneum later part, after surgery is going to end, there will be a lot of fibrosis. It's a transplant. It's not a radical prostate or something like this. These holes are probably going to seal with a lot of fibrosis around. So, I mean, this
So
is
I
my
have, because mine is almost always extraperitoneal because the flap I create is extraperitoneal. So my lymphocyl rate would be around like 1 to 2%.
It's similar,
less than
similar
that,
to
yeah.
open. Yeah.
And if you see, even if this technique, if you go inside after 4 or 5 days, the peritoneum would have completely sealed. So you have to assume that either the lymph is coming from the graft or some lymphatics, either way, and it is going to probably, it's a chronic process. It's going to happen like 1 or 2 months later, and mostly it's associated with rejection or some other episodes.
Exactly, that's my point. I mean, putting a neck or leaving some gap, it
No,
is
it
going
may
to
not
seal,
help.
I mean.
It may not help.
Yes, it will not help.
I think only in the initial study they've proven when Prasoon and Dr. Halawat presented that, so they mentioned that as an advantage. But I don't think on long run it is not going to help.
One of the things that they used to say is that when they're incising the peritoneum over the vessel.
So
yes,
that
Harish.
all the bleeding has stopped.
Yeah, Anand, it's a fantastic job.
So we'll just
Do
put
you prefer, when you're doing across the blood group recipients, do you prefer extraperitoneal to interperitoneal? Because across the blood group recipients, they sometimes to have more chance, I mean, we see more lymphocyls in those patients than we normally see in our open surgery patients. When we do across the blood group, then they have a little more of lymphatic drainage. So, Kishore, you just said that you prefer extraperitoneal, but do you ever do interperitoneal? I'm talking on robotic transplants. Yeah.
No, I do interperitoneal, but my flap is different, so I completely extraperitonealize. So the kidney is completely extraperitoneal. It's not seen in the peritoneal cavity. So that is how the technique is. And I mean, it doesn't make a difference. I don't put a drain. Generally, I don't put a drain at all. So I mean, I have not seen any
So after
difference.
robotic transplants, you do not put a drain?
No, put a drain. Yeah.
Anand puts a drain?
Yeah, hello?
Do you put a drain, Anand, in after robotic?
Yeah, we put a drain. And I'll tell you, when in transperitoneal, there is a trick. We put ADK24 drain, and patient is in Trendelenburg position. And when you do finish it, and the patient position is straightened, all the fluid and urine which is going into the upper end near the liver and all that will start coming, and suddenly you will see 400, 500 ml is blood tinge is there and you think, oh, it's bleeding, but most of the time it's nothing is there, it will just finish it up. And extraperitoneal, you won't see that. And drain we usually removed after 48 hours because otherwise it start draining the peritoneal fluid. Now before I put it, whatever is oozing, we just take care of it. So because this side we won't see.
And sir, my case is that just
sure that
apply that because invariably after 4 to 5 days, this also get extraperitonealized. The kidney, what Dr. Anand Kumar keeps, you just suturing it back. If you go inside after 5 days, it's completely extraperitonealized. So, I mean, it may not have much of a bearing on this transperitoneal technique. That is what I feel so. I think it's only the initial studies that have purported this advantage, but I don't think.
Regarding lymphocytes, more lymphocytes AVO incompatible is because of the baseline titers one has got and how many plex one has used. I mean, actually using plex, so many plexes, and suppose the baseline titer is very high, and then the chance of lymphocytes is more compared to the compatible. It's more because of the process before.
I understand that. We do a lot of across the blood group. I understand that. That's why we always leave a drain. You know, because lymphocytes is something we are worried about.
And now the blame is on the audience because you guys decided not to do anything. So now what we do, we see how far this peritoneum is cut. Upper pole is here, so now I can switch it. So at this time, these fats will help you in
manipulations.
lifting the kidney. And here you can take it like that and then just drop it. And before you completely drop it, again I wait it here, and all these bleeding points will be coagulated before I put the peritoneal flap.
I'm just curious about that upper polar artery. How much of the area is?
I've just shown you everything.
Okay.
It is still around 10% of the area is there, but how deep it is in the cortex, I don't know. Sometimes it is the only superficial part it is supplying. But very often what we do, we re-implant such artery into the main renal artery.
Anand sir, during preparing the extraperitoneal space, has it ever happened that there is a puncture which happened in the peritoneum and the gas is anyways leaking into the peritoneum? Suppose in the beginning only if it has happened, so do you convert to transperitoneal or you continue that way? How do you tackle?
Now when you start, all these things will happen. So it did happen, but we didn't convert it. We kept managing it. Somehow or other we could manage it. So
but I think even if one has to convert, it's going to hardly matter. Only thing is you have to change the position a little bit.
Sir, getting ports again transperitoneally, once the space is already created, it creates so much mess. I can tell about the prostate. It's not very easy then to go in a transperitoneal because everything is fallen down. So bladder is already fallen down, so it becomes difficult actually.
I had the same problem actually. So one day I started extraperitoneal and then had to convert to the transplant. So what happened was, you have to replace the port a little bit higher up and then cut the peritoneum and then go down. So yeah, so end up having not 10 but maybe 2 or 3, two more. So
now this is another trick, is make sure this is the ureter. So this flap should be little away, otherwise you put a clip, ureter comes in that and you will come to know later on. Put a clip here. Invariably 1 or 2 clips are required, not more than that, and that keeps the kidney there for a few days till I don't have to put any more clip, or I just put 1 clip here just away from the bowel make sure nothing is there. Now that my kidney is sitting there, and what we do, we just take the fourth arm and hold the fundus of the bladder, and then we ask to fill the bladder. ये वो उसको अभी काटा है कि नहीं काटा है उसको?
Anand sir, in such position, how do you prevent kinking of the renal vessels, because kidney may be falling down onto the vessels?
Okay, so that's very important. You might have not noticed, my assistants are very careful and they keep correcting me. Because of them, most of the time operation goes well. See, they told me your camera is other side, so I realized what was happening. So now you can see that your vessels are straight, camera should be straight, and there is no twisting. You can see this is the vein and here is the artery. Probably I'll just put something here also. बचा हुआ है, दे दे थोड़ा सा.
It's pouring urine, so I guess the vessel should be okay.
Too deep this peritoneal pouch, if too deep, then there will be traction on the vessels. It should be enough that lateral border is sitting nicely there.
There is a little space in the iliac fossa for the kidney to rest. It
So
automatically
now you
goes
can
there.
see that kidney is, there is a good
Also kidney
diuresis.
will be-
And one important aspect is you should make sure that this is straight and urine is coming, so that there is no twist in the ureter. And luckily today the length is just optimal. At least the ureter was kind to us today. We don't have to exercise or do something, but it is still, there is some bleeding, so I am going to take care of it. There is a two-way of, just give me the Caesar.
So don't say anything about the ureter, because it's a workshop, as you say. Something might go wrong with the ureter.
At the moment, it is very innocent.
Yes.
See, there is a, we have to find out this bleeding is, and we do the point coagulation as we do in open surgery. I know people object to it, but we have been doing it and it works very well, because we do point coagulation, we don't. So now this is the vessel which is causing us problems. So I will hold it here and I will put the current to 2. Now the current to 2, and then I'll just touch it intermittently and this will get coagulated.
But why not use bipolar?
Probably not so precise. I have tried that. This I found it more precise. It takes more tissue. I don't want to do that. So if you see it here, it is just doing what? Just the point coagulation.
So do you have any tips when there is a bleeding from the anterior aspect of the artery? Once you flip the kidney, if you have a bleeding at the anterior.
If it is bleeding, then you will see that some blood is collected. So I have premonition that maybe anterior side bleeding. So when I turn it there, then I will take care of it immediately.
Do you switch the camera port or just through this? Because I find it little bit, the exposure is quite less from here when you flip the kidney to tackle the anterior surface of the artery bleeding.
No, but I have put the extra sutures in this position, and what do the fourth arms, I just support it so that kidney goes this direction and there is no traction on the vessel, and then just you put it. Now you see that most of the ureteric bleeding is done, taken care of, and now what I will do, I'll just give a, even in open surgery I do that, so that this cut end won't bleed. Otherwise your residents will be cursing you, because there will be hematuria and he has to come and do the flushing or something, or change of catheter. And our ureteric anastomosis is also very simple. We do take the 4-0 suture. Now again I will make sure that my ureter is not twisted, its urine is coming, and going in. The thick, okay. I'll take.
I think somebody from the organizing committee can come and change the chairpersons. I think that they forgot. And it's lunchtime also, and we've been over here for the last 2.5 hours, so. Arre, nahi sir.
No, the kidney is diuresing, now we can go.
And now see that if you have to put the suture, keep your open end of the forceps inside to make sure that you have not taken the opposite wall.
Sir, you have had any instances where you had to reperfuse the kidney in robotic?
Not yet.
Not.
I mean, till now we did go back one patient for bleeding, one patient for subcapsular hematoma. Otherwise, we don't have to convert into open, and we don't have to do any other procedure. One patient had subcapsular hematoma, so we opened laparoscopically. One patient, radiologist said post-op urine was not coming, that there is no perfusion of the kidney. So we immediately put the laparoscope, and we saw the kidney is nice and pink.
Okay.
And while we are checking it, kidneys, and repeating the Doppler ultrasound, urine started coming. So I think we just panicked it too fast, and radiologist was the resident who gave the wrong diagnosis. And one time there was a bleeding, and we just went inside, we just washed the clot and other things, but then we couldn't find any bleeder and just closed it. And but we did the same phalansteal incision, we extended upward little bit, and with that we tried to check if there is any bleeding or not, and we could nicely see the vessels, and there was no bleeding from the vessels, and then we came out. So, but in surgery anything can happen, and can happen at any time, so keep our finger crossed.
And do you use a Doppler, intraoperative Doppler at any point?
No, we don't. No. Like you look, we have intraoperative Doppler, we can use it, but see, what we do, this is my eye Doppler. If the kidney looks like that, I know it is nice. So we use eye Doppler, not the radiology Doppler. But if you have any Doppler, we have the BK ultrasound, and we can drop the robotic probe and we can check the Doppler flow at any time if we think it. But till now I don't remember any time we have to do it.
Do you feel now we have large experience with robotic also, so do you feel that output is slightly less to start with in robotic compared to open?
When we started it, then that was there, but now it's not. Everything is same urine output, same thing is happening. Initially, we have our nephrology colleagues were never keen for the robotic, and every time they were criticizing something or other, and because of their very criticizing eyes, we were very careful, and we keep changing things and keep improving. So that is also very good if you have a colleague which is teaching you and telling you this is wrong, so that you keep on improving. So we are thankful to the nephrologist for many improvement we brought in.
Yeah, I think it depends upon the warm time, right? So if you take really long, like 75-80 minutes to put it in, then you'll have a low urine output to begin with. But if you have warm time like this, what Dr. Anand did today, I really don't think it should make any difference versus open.
Recently we were in Basel for proctoring and I'll tell you, while proctoring they take 70 minutes, 75 minutes, but the urine started coming there. Maybe the European kidneys are very special and they don't bother for some of the time not getting the blood flow. But they immediately started producing urine, and I was wondering, today we have taken so long, probably urine will come after some time. And like there we were surprised when we went to the, after the operation, see the donor. So probably 3 hours later, donor was eating banana. I was surprised. And they removed the catheter also. So post-operative, as soon as patient is awake, they remove catheter. And he was eating banana. I said, yes, great. And he was very comfortable.
When do you normally remove the Foley?
And when do you permit your patient to have bananas?
So, it looks like while talking I have taken this little deep suture, so I will just take it out and then put it another.
Did you have the occasion to reperfuse your kidney sometimes?
Twice, in fact, yeah. So I had twice. One was my first case, so that was a nightmare. So and then, like maybe after like maybe 150, around 150, I had. But that was quite uneventful. Probably he had some thrombogenic issues. But the first case, definitely it was a technical issue because.
So how did you reperfuse then?
No, I opened the opened. Yeah. So I had actually 6 conversions. So 2 was this, the re-exploration, and 3 all were negative actually, you know, vascular spasm mostly. Then we tried to fix it, by reducing the pneumo, position changes and all. And then one re-exploration the night for a bleeding from the surface. Actually that made me to switch to harmonic while preparing the kidney.
For on bench?
On the bench.
You're using harmonic.
Yeah.
So in your reperfusion, did you like even dismantle your vein also? Did you do a venotomy? And
no, I did a venotomy.
You did a venotomy and then reperfused.
Okay.
Because your vein was okay.
Yeah, vein was okay.
Problem was that.
Yeah. Initially what happens is the threshold is very low, you get tense, so the moment you don't know output you tend to especially the earlier years. So now we know this is vascular spasm, I mean this output will come, you have a Doppler which is aiding us. So
I think yesterday I was talking to Professor P.B. Singh sir, and we were saying that sometimes CT angios can be very, very misleading inside the post-operative period. You might have a good vascular tree, but there can be a thrombus. So that I was talking to Professor P.V. Singh yesterday, and
sure.
we were discussing this only.
When you started your robotic transplant program, did you put double J stents in the ureters?
Yeah, I always put double J stents. Even now I put for the open also, the robotic also. I mean, I don't know whether there is any compelling reason for that. Mostly I would say at least I will get to see the patient once more while stent removal. So that is the only reason. But
we try to avoid stenting, but I mean, fair enough. Because when you start a robotic program, we do only live at the moment in Just Look. I mean, live mean we do only open. We do robotic donors, but we have not started robotic recipients yet. But would you prefer to do all extraperitoneal or would you prefer to do transperitoneal? Because we normally want to do it only for very fat people, which I think is the advantage of that.
That is one fallacy you commit when you start a robotic program. So I also did the same mistake. See, what happens is that always there's a nephrologist on your side. You're taking a relatively fat, like your male, and you're having a lady donor. The creatinine is bound to come in a slower pace. And whatever you say, obese patients are difficult to do robotically also. Compared to if you have a choice between a thin patient and a obese patient, it's much more difficult with the obese patient. So obese patient is not the first patient you should take. You should try a lot of normal BMI, thin patients, and then once you're done with like 20, 30 cases, then you try on obese patients. But we have a perspective that is only beneficial for obese patients. But
that's nice to know.
Yeah,
that's nice to know.
That is what you should approach, because I did the same mistake. First 10 patients, all high BMI patients, creatinine coming slow down, there will be criticism all around. Then I started, like engaging more normal BMI patients. Then things started picking up. So that is, I mean, applicable for all surgeries. If you're doing a robotic radical prostate, first case you will not take a 32 BMI patient. You will do a thin patient. You will preserve a thin patient. Similarly, I would say. And
at Lutyens Hall. So if anyone's interested, they can start having their lunch. And in the meantime, I'd just like to thank Dr. Rajiv, Dr. H.S. Bhatyal, Dr. T.A. Kishore, and Dr. Nachiket to chair this session. Thank you.
Thank you very much.
You've done a wonderful job.
See that the lunch is now open in Luton Hall, where we had dinner yesterday evening. So those who are interested, they can go there. And now I'm putting the stent, and then we do the anterior layer, and then we bury the ureter except and diffusal tunnel. As far as stent is concerned, actually, we were the one who started putting stent in 1989 and 90, and our publication was the third publication in the world in Journal of Urology, prospective randomized trial, stent versus non-stent. And then we published in 2001 our large series of urological complication before and after the stent, and that camera after. And then we have seen that stent does make a difference, and urological complication is very, very rare in our series. Stent will take care of minor leak, obstruction in the post-operative period, subtunnel hematoma and all that, but it won't take care of major leak. And so you put a stent and we remove the stent, patient is discharged on 7th day, comes back on 10th day with the urine culture report, and that day, 10th or 12th day, suture and stent both are removed. So the stent stays for 10-12 days, not more than that, and not much rate of UTI. Some people do have very severe stent-related symptoms. In that case, we have removed the stent as soon as when the catheter is removed. Sometimes people can't tolerate the catheter, so we remove the catheter and stent early also. Otherwise, they all get anticholinergic when they complain. If they settle down, then stent comes out as usual. If they are not settling, then it will come out. ऐसे करो, मेरा छोड़ दे, छोड़ दे. Cut. ले जाओ. Thank you. Okay. काटो. Chalo, drain layer. So that part is over. We'll put a drain. And before we move, we just check the color of the kidney again. ये ले जाओ. So now what we do, we go back here, check if anything is oozing and coming out of here, that looks dry, and we again check the color of the kidney, like eye Doppler, you can see the kidney color is good. So we'll just put the drain and just come out. ये लेते जाओ यार. हाँ आर्म फ्री है. ये ले जाओ, फोर्थ आर्म ले जाओ. ये निकाल दो, ये इसी में लगा दे. हाँ ले जाओ. चलो ड्रेन दो.
And good afternoon, everyone. Just another small reminder that lunch is being served at the Lutyens Hall, and we will resume our session in another 10-15 minutes with Dr. Oswal's presentation. Thank you.
सक्सेस हो उसकी।
अभी दिल्ली मेडिकल काउंसिल का भी एक सेशन था ना? अच्छा, पर उनका तो कंपलसरी रहता ना CME पॉइंट्स के लिए? तो पॉइंट्स तो नहीं कैंसिल करेंगे?
नहीं
CME पॉइंट्स
नहीं, वो तो लेकर जब सारा ठीक हो
फिर ठीक। पूछ लो जब चालू करेंगे या फिर थोड़ा डिले सहन करना पड़ेगा, ऑडियंस तो ही नहीं। महाराष्ट्र में हमारा जो नागपुर और मुंबई वाला सो नेक्स्ट वीक
आयुष आयुष आयुष
हाँ, कल सर बोल रहे थे हम केस में दिए नहीं कर महाराष्ट्र में हम सिलेक्टेड पेशेंट्स का कराते हैं तो हम 30,000 रुपये देते हैं लाल वगैरह को, तो हमको तो मालूम है कि मैक्स में 16 में होता है, मैक्स में सैंपल भेजते हैं, तो लेकिन मैक्स कैन डू
So suppose in between two impacts, 25,000
DNA forensics
हाँ वो कर रहे हैं, तो हमने फिर अपना शुरू किया लास्ट
हम सैंपल भेज सकते हैं महाराष्ट्र से। वो सब करेंगे, हमको मैनिपुलेशन तो करना ही नहीं है। यहाँ की ट्रांसप्लांट टीम सेट हो गई कि मुंबई की और नागपुर की? He is Professor Jamal Rizvi from RC Ahmedabad. He is the chairman of Transplant Organization Committee at Max Hospital. Every month. DNA fingerprinting is the norm.
सबका first is the DNA fingerprint. Even in the all comers, everyone, even from foreign, someone is coming, husband and wife, children is not there. So we know ये husband and wife. We have to prove only from what they cannot change the children. Right? We can transport. We are transporting sample from even abroad out. हाँ, yeah, you have to see the child. एक कैसे भी हो, but जहाँ पे क्या है individual who shares the gene. So you must have heard in Myanmar and Bangladesh. वहाँ पे हम देखेंगे कि फैमिली क्या करेगी, ऐसा डायग्राम बना के लाएगी, ये मार देगा, वो मार देगा, you cannot match. उस केस में हम mitochondrial और
at least some clue.
Some clue will be there for opposite maternal sides if they are coming. At least X we are on the safer side that we know that
Satish.
they are from
Satish. One extended family or some connection at least.
So if it's not met with that, we have a face screen and a thumb evaluation. So any of the patient who comes from from doctor,
उससे क्या होता है?
वो जैसे हमारी कमिटी में चली गई, कमिटी ने क्लियर कर दिया, now they have to come for the admission. So there is a single admission counter where they will text that this person who has been registered with this ID is the same or someone else. So at the admission counter they will make the scanning. If it's matched,
अच्छा, थंब का स्कैन है आपके एडमिशन काउंटर पे.
So if it's matched with their face and thumb, they will go ahead and admit the patient. Then move to the ward. From ward, we have inside the pre-operation. We have again same face scan for the
So we have
you can't substitute that person.
Yeah, we have a little cooler system in our operation theater. वो परमिशन का ओरिजिनल कॉपी ओटी के इंचार्ज सिस्टर देखती है, उसके ऊपर फोटोग्राफ वो फोटोग्राफ के ऊपर सिग्नेचर और स्टैम्प है ना भाई, इनका ऑथराइजेशन नहीं, पर वो तो बांग्लादेश का ही पेशेंट और बांग्लादेश का ही डोनर, वो आधार कार्ड नहीं, वो तो पासपोर्ट की भेजते हैं. Your choice. चलो चलो.
We can discuss each other like
Yeah.
it's complete.
No, this technology you're using is excellent. It's a system that you purchased.
Welcome back, everyone. So we'll be starting our post-lunch session now, where Dr. Ajay Oswal will be having a presentation on legalities in renal transplant. And for chairing this session, I'd just like to welcome Dr. Shailesh Raina, Dr. Manas Ranjan Pradhan, and Dr. Pranav Shankar to the stage, please.
asking that we do have a pretty high volume. I'm at IKD Ahmedabad. We do about 40 transplants, kidneys a month, and about 2/3 of them are living. So
Okay.
it would be good to have a.
Good afternoon, dear sirs, dear friends. It may be difficult for me to keep you awake in a post-lunch session, but I'll try my best to do that. So let us straight away move to our first case. Advocate Bhardwaj was supposed to be here. Okay, no problem. So this is the first case, 32 years male, proposed father to son kidney transplant. Documents confirm the relationship. भाई ये चल नहीं रहा है. HLA surprisingly showed 0/6 match. Therefore, DNA fingerprinting was done, which showed paternity ruled out. That was the report we received. So, competent authority in our hospital denied the approval. So, Dr. Shailesh Raina, should we disclose the findings to the family that the claimed father is not the father of the donor? Should we disclose this fact to the family?
You know what? By disclosing this fact to the family, you're going to create a lot of turmoil on a family. Anyway, this boy needs a transplant. You will have to just tell him that I would do that you will require another donor. We are not policemen or judgments here. As far as this case is concerned, no, we cannot accept this, because as per the law, unless you do some DNA fingerprinting, sometimes they even take hair. And if these two tests come that he is not the father, then I would just tell the family that, you know, we cannot take this kidney, but not necessarily tell them that because the paternity is suspect.
So that's, you have to be circumspect and respect the privacy of the family.
Absolutely.
Yes,
Doctor,
Jamal.
just a practical issue. What are the mechanics of getting the DNA fingerprinting done? Do they not get a copy of that report automatically in the hand, or does it come directly to you from the lab?
See, actually, when we send the sample for DNA fingerprinting, the DNA forensic labs takes a special consent that you may come to know certain facts which may be unpalatable.
No, that's all part of the routine consenting. But the question was, will you reveal it to them? Once the sample is given and the report is processed, they're going to anyway find out, right?
They are going to find out.
So there's no question of revealing or not revealing.
They are going to get the report.
Results are going to be there, and they're going to know about it.
Yes.
Let them find out. But we should not be creating a turmoil in their lives.
Okay, Dr. Manas, what next? Stop further proceedings, ask for another donor, or go to appellate authority? Excuse me.
So I'll probably find some other place, some medical thing or something like that, and tell them to find an alternate donor.
But the other donors in the family, wife is ABO incompatible, mother is diabetic, and kids are less than 18 years of age. So practically, and the sister's husband is not willing to allow her to donate. So practically, there is no other donor. So that's besides the point. They may or may not have the donor, but you agree that this donor cannot be selected, right?
No, it's more for social reasons rather than medical.
Okay.
But ABO incompatible donor can be taken.
Yes.
So you can give them a choice.
Given the choice, so they asked us, is there any legal recourse to this? So we suggested you can go to appellate authority, and the appellate authority, after considering points in law and the documentary evidence of being parents, issued a written approval to go ahead with transplant. Sir,
Yes.
what is your take on this? So DNA fingerprinting
See,
decides
if
that
the
he is
if
not
the,
the father.
if the authorities say go ahead and there's a judgment and they give it in writing, please go and do this transplant.
Okay. Yes, sir.
So my only question is because on one hand you are allowing near negative, but he has got a certificate, he has brought up the child, father of the child, every document he has got. So what law says, because on one hand near relative is allowed, on other hand the father who has nurtured this boy, you are refusing on the basis of DNA printing.
So the argument given by the appellate authority was exactly saying that the documents confirm that he is the father.
HLA is not required.
HLA, actually DNA fingerprinting is not required by law.
Yes.
So based on that section of the law, rule 18(1)(4), that DNA profiling is essential only if documents do not confirm the relationship. Therefore, he issued the permission, and therefore our hospital administration told us to go ahead and do the transplant. My next question to you, Dr. Raina, should DNA fingerprinting be done routinely as it is done in some hospitals in Delhi? Just now, the chairman of the authorization committee at Max told me that they do DNA fingerprinting in every transplant which is genetically related.
You know, if you get a HLA typing like this, yes. But if you don't get, if you got no match, but if you even get some match, I don't think we need to do DNA in every patient.
As per law, it is not essential. Yes, sir. Sir, you were saying that you do DNA fingerprinting in every case.
What we felt, right, in last 2 to 3 years, there were certain cases which has pop up in Delhi NCR regions, right? So authorization committee is comprising of health secretary, nominee, CDMO and lawyer along with the social person, right? And 3 or 4 clinicians from the hospital. So seeing the past experience, what they felt once the authorization committee was being called to the crime branch or NOTO, it was very difficult for them to justify because, you know, on Form 21, the NOC which they received from the embassy was being questioned. The decision of authorization committee was also being questioned by the crime branch or the NOTO or the investigating officer. So, you know, what we have discussed with the health secretary that by default you all should go with the DNA rather than, you know, proving through the documentation. So as the first case what we were discussing, obviously we have seen such cases where the DNA has mismatched. But again, from competent authority, the case was being forwarded to the authorization committee and we have taken a call based on the documentations as the parents have nurtured their kids. And I remember there are 3-4 cases where we have given the clearance after DNA mismatch also. But if they have provided so much of evidence that it shows the relations, how they have grown from 0 to 24 years or whatever their age or association with the family or family get together or educations, right? So if they are providing the enough documents, obviously we are as an authorization committee surpassing the DNA report also. It's not mandatory that in 100% cases it has to match only.
Yes, sir.
So, Dr. Ajay, at many times we see that parents have adopted the child from one of their close relatives. So, if they can be called separately and if they have a document of having legally adopted the child way back, which they have not disclosed to the child also, so that can also be explored.
So, if there is a documentary evidence that this child is the adopted child of this set of parents who are one of the donors, then this can be considered as other than near related category donor, and authorization committee has to permit it. Yeah, adopted children or adopted parents are treated or considered as other than near related donor,
because they've lived a lifetime.
You need to have a documentary evidence of adoption. We have done
from way back.
Yes.
You know, can I
yes,
come in here? Now, we've been at this game for the last 35 years. And I've gone through the phase where the abroad committees, people came from abroad and they tried to investigate and a whole lot of... At the end of the day, we as transplant surgeons cannot absolve ourselves of the responsibility. That's number one. We have to take the responsibility. But if we
responsibility in good faith, and also if there's a doubt, you can go to the court, and if the court gives a verdict, you do it, then do it. Otherwise, we are getting yourself into trouble, unfortunately today. But DNA for every patient, I think that is not accepted.
Okay. Sir, we routinely, I come to the next question in a related transplant. The form number 5 says that the relationship is either established or not established. Established by the results of the tests for DNA profiling. The word used in form number 5 is DNA profiling. Whereas we are not doing DNA profiling in each and every case as Max is doing. In our center or in many centers, DNA profile, as Dr. Raina said, is not the routine. So then we are getting this form 5 from the lab. So there seems to be a dichotomy in this legal provision.
I couldn't agree more. The dichotomy is not only in this, the dichotomy is also amongst ourselves. There are a lot of centers doing non-related transplants who say we do not do non-related transplants. But the affidavits and all are perfect in order.
Pardon?
The affidavits are perfectly in order in many centers in this country. I'm not going to name anybody. But the surgeon knows that he is doing a non-related transplant.
Under the garb of related transplant,
Under the
or unrelated, labeled as unrelated?
Under the garb of related transplants.
Okay, so that is
the surgeon knows,
indefensible.
the nephrologist knows, we know, but we are all quiet. So, see, I'll be honest with you, as far as transplants are concerned, all this, what has happened so far is because, and I'm saying these words with full sense in my head, I take responsibility, that we have absolved ourselves of the responsibility of a transplant between two people, and we've given it to the courts and the administrators to take care of. Once we come back to take our responsibilities, believe you me, you won't require such forms. You won't require such forms. Now we are also signing up perfectly justified. Now look at it. Has been established dash not established by the results of this. So you are signing on this means it has been established and also not established. So you're legally right. So it's not that you're signing on both. So you can that time say, but has not been established.
Sir, the report from HLA lab is not established को वो cut करते हैं. They are giving form, what I am trying to ask you is,
but it is for, when you
are giving form number 5, establish the relationship based on HLA, not DNA profile.
So you can tick one and sign, no? But none of us see that.
So we don't sign this. This is signed by the lab people.
But sir, आप lab को बोल दो ना कि बाबा देखो ये
So
this is not established.
if lab says it is not established, then we end up sending DNA profile for every case. Is that acceptable to you?
No.
Jamal, you have to say something on this form 5.
Again, it's the practice at our hospital to get DNA testing done for all patients across the board, and it's a question of the safety of the teams that are working. I mean, it's that way. If the law is going to take a hard stand on unrelated transplants, we have to take an equally hard stand for our own protection. These other problems are going to come up, and it's unfortunate the patients may have to suffer in the odd time, but I think it is what it is. We all know that we have colleagues in prison, and that is that is not a situation that anyone wants to be in inadvertently.
Yes, Dr. Vyas.
Sir, we all know what happened 6 months back in Jaipur. One of our colleagues, 2 of our colleagues rather, 6 months they have not. So why cannot we get this for each and every patient? I mean, it's either their word against ours, and if it means that one of our colleagues is inside jail for the last 6 months without the possibility of getting any bail and the possibility of getting a harsh sentence, I think that this should be made mandatory for all patients.
Sir, please excuse me for uttering a harsher sentence. The newspaper articles said that those colleagues of ours knew that the donor was in reality an unrelated donor brought from Bangladesh, labeled as related, and then transplant was done. This is, I may be wrong, but this is what I have read in newspapers.
But sir, ultimately when the permission was also granted by the embassy, And if they are bringing papers that seem to be genuine as far as high up as the embassy and also competent authority, then just for our safeguard, why can't we just add another test for our safety?
Agreed.
Sir, please, sir, hear me out. Sir, please let me say this. That unfortunate surgeon or urologist of ours, he took on face value the papers that were given by the Bangladeshi authorities. And then they had an NOC in hand. Then in that case also, what is he to do? Maybe this would have saved him all the present time.
If you know that that donor is in reality an unrelated donor,
please don't
no
even try.
Piece of paper, even from the head of United Nations, will be acceptable to me as a related donor. If he is unrelated irrespective of what document.
Period. And this is what I keep saying.
Sir, I have a point to make. Whosoever does an unrelated transplant, so label it as unrelated and do it as unrelated.
Yes.
Perfect. Perfect. You go by the court order, send for state ethical committee and do. If you do an unrelated transplant in disguise of related, then you are in deep trouble.
That is the biggest crime.
And
that
this
is the biggest
where
crime.
I
Yes.
come to again and again. Let us be responsible transplant surgeons. One case not doing a transplant or two cases not doing a transplant is not going to make you very rich or very poor, and it's going to give you sleepless nights. That one wrong that you do and knowing that you did it is going to finish your career, give you sleepless nights. And I've seen this happening from the last 30 years. And believe you me, don't do an irresponsible transplant. I beg of you guys.
So,
even just
Manas,
to update, you know, after that incident, even Bangladesh embassy has started asking the DNA profiling before giving the NOC. So after Jaipur incidents, they have made it mandatory that without DNA, they will not issue form, no objections.
Sir, in yesterday's discussion, I had said, raise your antennae when you see a patient from unusual source or unusual place, or if things seem to be too good to be true, then probably it is not true. So if you get such a case, say I am practicing in Aurangabad and I get a patient from Assam or Kerala or Jammu and Kashmir, I should not jump out of my chair and drool over the prospect of getting a new line of practice. I should suspect, ये patient मेरे पास क्यों आया? Right. Yes.
Sir, I wanted to just add that I totally agree with all my seniors and all of you. But now with medical tourism rising every year, and we get a lot of people coming from African subcontinent, Middle East also, and they're coming from Southeast Asia. I think that this thing will become more pertinent.
Yes.
Because maybe we can, deal with, as you rightly said, with patients in our Indian subcontinent.
Our coordinators know how to read our Aadhaar cards and voter cards, but we do not know how to read those documents from, say, Africa or Russia, because we can make out whose father and whose mother in our papers, but in their documents it is very difficult, at least for me or my coordinator, to make out ye father ka naam kaun hai.
You are right, sir, because polygamy is allowed there, and I'm not joking. We have two brothers from the same father and different mothers.
They are called uterine siblings.
Whatever it is, so unless you don't know of this situation, so the embassy gives, then that's the time when you see the HLA typing properly.
We move on to next case. Dr. Manas, the current provisions in transplant law, its amendments and rules mention that swap is permissible between near relative pairs only. So that means on each side of swap there has to be a near relative of the recipient, then only you can do a swap. Suppose a patient comes to your team wherein on one side there is mother and son, and on other side there is father-in-law donating to son-in-law, which is legally, as per the letter and spirit of the law, is a other than near related donor. So is that swap possible under current scenario?
Sir, in current scenarios, if you go by the HOTA Act, it's not possible, but recently we have come across one or two judgments where they have allowed this.
So
yes.
This is that judgment?
Yes.
Sir, Superintendent sir, Can this, actually I wanted this question to be answered by Professor Harsha Johri or Advocate Bhardwaj, but you are also an authority. This is a judgment from Kerala High Court. Can I take reference of this judgment and implement similar practice in Maharashtra or Delhi?
No, sir, because this was an individual judgment for that case. We cannot, overrule the THOTA regulations. This was for the individual
sir,
case.
Can it not become a case law to return with? Court can always say that here onwards, this becomes a case law.
No, because, in recent past also we have seen swap from two hospitals, different hospitals where they have done the swap surgeries, right? One donor from other states who were supposed to do their near relative been transported to other state, and the similar kind of swap, and in two hospitals the surgery were performed in two different states. So that was an individual case where that court has permitted.
Sir, inter-hospital swap and inter-city swap in our center and our region we also have done. On each side of swap, the pair was near relative. So one transplant was done in Solapur and simultaneously one transplant was done in Aurangabad. So we have done that. But the pair were amongst themselves near relative. The question here is swap involving other than
Sir,
near relative.
if it is done, both are from different states, then you have to go to the court of law for them to say yes. If it is from the same state, then also I'm afraid you can quote this, but it will have to go from the courts, and they take 1 day to give the judgment.
You have mentioned a very pertinent point. I was going to ask the question. Suppose a patient comes to Delhi from Madhya Pradesh, related swap. So for a swap, do you need a NOC / verification of residential status from the state of domicile? Yes or no?
Yes. As per
Anyone
law,
who
yes.
agrees or disagrees with this?
No, you don't. You don't
agree
as
with
per the
Jamal,
law,
you
and
don't.
we routinely do it without an NOC.
Yes.
Yes. No.
So the law clearly mentions that swap needs permission from authorization committee. And it is boldly, loudly, clearly written in form number 11 that swaps do not need NOC from their state of domicile. That is the written word of law. For extra protection, you may go to any length. Yes, Ranjan.
So I've discussed this because we also had a similar patient. So I discussed it with one of the judges of the High Court. So he said in India, law has 3 stages. One is given to us by the Constitution, the Criminal Penal Code. The second is passed by the Parliament. The third is a High Court or a court order. So if there is a court order, it is supposed to be one of the laws. So if the patient appeals to the authorization committee, it rejects, he can file a writ to the High Court. And on the basis of this law, it can get cleared. So we are doing the same.
This judgment from Kerala High Court is applicable
throughout India, because
throughout the
judicial,
country?
yeah.
This is what you mean to say?
Because any High Court will take the judgment from this court. And they have clearly written in this order, if this payer can donate to themselves, why not in swap?
Okay. Agreed. So, Jamal, your assertion that for swap you don't need
Ajay, I'll take your leave.
Yes.
Thank you.
Thank you very
It's
much.
such late, but my request to all of you are, be careful with the law, take responsibility for your transplants.
Jamal,
Thank you.
Please.
It's fine. See, I think, Ajay, here the issue is the letter and the spirit of the law. This is basically when this rule was drafted, it was in a clumsy language, which omitted to take. I mean, they said only near related donors may be in swap. It should have said all legal donors may. So just because the people who drafted that rule drafted it perhaps without a proper application of mind, for decades, we've been running through hoops to try and get around this. But I think the spirit of the law is absolutely, if you can do a transplant directly, there's no reason for you not to swap. And if you did this, apart from High Court judgments aside, if you do it in the spirit of the law, it's very unlikely that, you are going to get into trouble.
Jamal, can I request you to come on the...
Yes, sir.
Okay.
So we move on to the next case. So, one of our friends was caught on a wrong foot by law enforcement authorities, and all sorts of multiple rules and laws, including Bharatiya Nyaya Sanhita, Indian Penal Code, etc., was slapped upon them. So I request Superintendent Sir to tell us, if you are caught on the wrong side of the law, should only transplantation law be applied with all the provisions concerning forgery, falsification of documents, etc., or the authorities are allowed to slap 420, forgery and what not, assault, battery, causing grievous hurt under Indian Penal Code upon our surgeon colleagues? Are they allowed? Should they be allowed?
See, it's a legal opinion basically, but if you ask me my personal opinion, then I feel that, first of all, the patient or the patient party who has presented the wrong documents to the transplant coordinator or the surgeon and tried to prove their relationship. Obviously, a surgeon or a treating doctor cannot identify or verify the relationship. Whatever is being presented to the surgeon or the doctors, they consider those relations, right? It's the transplant coordinator or the authorization committee have to verify all those documents. And
sir, we are going in a slightly our question.
My question is that obviously doctor should not be involved because doctor is the
no. Doctor is involved. The police ACP says slap IPC ki ye dhara is pe laga do.
Sir, actually that's why I am saying, doctor is looking from the treatment point of view, right? Seeing the documentation or establishing a relation. There, if I, being a doctor, you can say the doctor is just being, see the patient and decide that this.
So that's a very interesting point. So tomorrow, can I stand up in a court of law and say that my liability should be restricted to
the treatment only,
surgical negligence or medical negligence,
exactly,
or my responsibility ends with a good operation done? I am not responsible whether they are mother or father or not. Can I say that?
Yes.
Is it legally accepted?
Yes.
I don't think
No,
any court of
No,
law or
sir.
government will accept this argument. Up till now, no one has. Yes, sir. Anand Kumar, sir, you have to say something. सर ऐसा हो गया तो हर सर्जन हाथ ऊपर करेगा, बोलेगा मेरा काम सिर्फ.
Actually, that all the form and everything surgeon also signs.
Yes.
So one way he is also responsible. He was supposed to check and see because he signed the documents. And whenever something happens, finally the doctor get he is not implicated finally, but there is before that there is a police trial and media trial and all that. So that is very troublesome. And the police will finally immediately jump on the doctors. And then the media also jump on the doctors. So the media assassination and media trial is the worst thing to happen. And but doctors is this one way is responsible because he is signing all the paper.
Yes, sir. There is a general rule or general principle espoused by Supreme Court of India which says generalia specialibus non derogant, that is a general law yields to special law should they operate in the same field on same subject. So our transplant law has provisions to punish for forgery, punish for falsification of documents, punish for falsification of relationships. Then why should authorities be allowed to slap IPC on us? Why I am saying this? Because there are most of the offences in transplant law are non-cognizable and bailable, whereas in IPC all those offences are cognizable and non-bailable. So if we get only transplant law, we have certain protections that it is a non-cognizable offence or a bailable offence. That's why I am asking this, and Supreme Court has espoused this principle. Special law overrules the general law. Yes, sir.
Yeah, actually that as per the transplant rule, the doctor should not be arrested, should not be, unless that the committee which is constituted by that the NOTO or the transplant authorities, they find him guilty of doing the wrong things. But the police, police will immediately arrest and they put them in the jail.
Because police quotes IPC or BNS. That is the problem. Yes. Yes.
Actually, sir, again, because the last fiasco happened in Jaipur and this was discussed at the medical college level to length, I do not think that inside the authorization committee there should be any doctor at all. We have to bring in professionals. Authorization committee, what happened in Jaipur was that you are bringing the principal who is already busy working from 8 to 8, you are bringing the superintendent, the dean of faculty, and all these people, they are already overloaded with work. The government wants you to be a surgeon also, they want you to be administrator also, they want you to be on the authorization committee, so that they just cut down on the expenses. A big segment of people who were involved in transplant, they brought it up with the secretary and said that why are you making us and doing everything? So I think that as far as the authorization committee, there should be independent people who should be professionals. They can come from a legal background, and it should be a 24/7 job. What is happening is that in majority of places where the authorization committee is again, to the point of repetition, people are already busy, being made more busy. Then there's some laxity inside checking of the documents, and people are getting NOCs wrong. This is what happened. I personally feel that the surgeon and the nephrologist or anybody who is attached with the medical college should not be on the authorization committee. It should be a people of high standing, but they can be retired. They should be there 27 for the job. It should be a professional job.
Okay, I cannot agree more on any other count. Thank you, Dr. Vyas. Yes, Ranjan.
So just a word about non-cognizable versus non-bailable. Non-bailable doesn't mean that the offense is not bailable at all. Bailable and non-bailable just means bailable means कि थाने में जाके bail हो जाएगी. Non-bailable means आपको lawyer करना पड़ेगा तब bail होगी.
Sir,
that is
exactly. So
only.
bail non-bailable में bail बहुत difficult है और bailable में bail थोड़ा सा.
Bailable is just कि पुलिस थाने में इंस्पेक्टर SHO कर सकता है bail.
In transplant law, most of the offences pertaining to us are non-cognizable. That means पुलिस वाला खुद चल के without complaint या without authorization appropriate authority के instruction के आपके ऑफिस में नहीं आ सकता.
Exactly.
In a cognizable offence, he has all the right whether there is a complaint or no complaint. He can take a suo motu cognizance and knock on your doors. So that is the difference.
And can a surgeon take anticipatory bail in view of if suppose some police case is being churned up? So is there a provision of anticipatory bail for this?
There is a provision of anticipatory bail in most of the law. The problem is, say in Jaipur, our friend was denied anticipatory bail.
Still, he tried to get anticipatory bail from Albert Court. They refused because there is such a big media trial going on.
Yeah.
That even the High Court is scared of giving them any kind of a bail. They have asked that in 6 months, in 6 months he has been interrogated so extensively. Even after 6 months he is inside jail. This is because on account of this media trial they are not willing to give him bail. That is the sad part of it.
So my next question to all the panelists and all the audience is, can there be a separate written provision in transplant law saying that once the offence is registered under Transplant Act, IPC shall be applied only if the said offences are not described in transplant law. So, should we not have such a provision in transplant law? If the offence is related to transplant, it should be tried and booked only under transplant law. IPC should not be applied. Why not should we have this provision? Anyone?
Sir, if this is the rule, that if this that if there is a special rule, I mean special law,
that's the Supreme Court judgment.
Then I think
multiple cases, not a single case.
Then that is good enough. I mean, there should not be any special. No, it's just like repeating.
The problem is the authorities who come knocking on your door do not listen to these arguments, and they usually come on Saturday or Friday midnight, and that makes things worse for us. Anyone wants to say anything on this point? Okay, so we move on to the next case. Doctor, sir, is it essential to have a full-time urologist for recognition as a kidney transplant center? As per the transplant law, what does the transplant law say on this?
See, in Delhi, one surgeon is registered with many centers, but they have to be, the team have to be available 24/7 to take care of the patient.
Yeah, patient cannot be neglected.
Right?
That
but
goes beyond.
one surgeon can be registered at various places, and they can have the transplant registrations more than one center.
So the problem is, I have received calls from many of our younger colleagues saying that the inspecting team for approval of the center had come and they had insisted that you don't have a full-time urologist at your center, so your center cannot be recognized as a kidney transplant center. Jamal, you must have gone to many places for inspection.
Yeah, so the law is quite silent on whether a transplant surgeon may work in the Human Organ Transplant Act. We have in Gujarat, we have G.dot guidelines, Department of Transplant, and that explicitly states that one surgeon can only work at one center for transplant. So that is how things are with us. But again, I think this is being a state subject. Every state is going to have to formulate its own rules and apply them accordingly.
Transplant law has no words mentioned like full-time, part-time, honorary, visiting. No, nothing. It has to be only.
So it's completely
surgeon.
vary on the the inspection team who visit the hospital. Sometimes they ask 16A forms or the return,
16A.
right?
Yes.
So what kind of association you have with the hospital? So it's depend on the investigators who comes for inspections.
So different authorities probably interpret this law differently, and Gujarat has a specific provision in G.dot that one surgeon can be associated only with one hospital. Is that correct, Jamal?
That's correct.
So one surgeon, if he cannot operate at more than one center, how will he generate volumes unless he is some center like Max?
That's what the rule, I think the G.dot does not concern itself. They do concern themselves with the fact that there was a trend of, people attached to 5 and 6 centers and probably patients getting neglected, even operating in different cities. So I think that was the concern, that was the spirit in which these rules were drafted. And how volumes are going to be generated, does not really concern the people whoever drafted the drafters.
Ajay sir, as Jamal would know about, we go in Jaipur, in Rajasthan, and in Rajasthan, a center should have 2 urologists, and as sir rightly pointed out, they have to give 2 years 16A form that they have been, working inside the hospital, and the salary is being drawn over there. There is one permanent nephrologist has to be there, and one person who technically has a diploma, a nursing staff who has a diploma. These 4 people, they have to be associated with the hospital to get registration for minimum period of 2 years.
So I humbly submit that this is over-interpretation by the authorities. The transplant law doesn't mention that. The only thing which goes without saying is that patient cannot be neglected. That's all. Yes, sir.
Yes. So I will take it on a different level, that it says 24/7. That means the surgeon also has to be a full-time surgeon associated with that hospital. Many years ago, I was the designated surgeon, and a nephrologist wanted to call another surgeon from another city. So I wrote to the NOTO over here that what is the interpretation, whether you can have a fly-by-night operator. So they said, you have a SOTO, you please write to SOTO. I wrote to SOTO, and the SOTO returned my application that your letter does not start with respected sir and you are addressing government official. I wrote to them in all humility, with all respected and kindly added over there. But then they said your SOTO does not have the requisite staff, and after 1 month again I wrote to them, and then they said we are referring it to the concerned department, and they referred it to the biomedical waste department in Delhi in Sarai Khan, this ISBT, 3rd floor. So what I'm trying to say is that when these kind of scenarios arise from these conferences, we should put the government in dock and always have a written question to them, so that when they arise, that we have already asked these questions to you and you are the one who has not answered.
So
this is the purpose of having these.
I myself had put government in dock once. I will discuss with. Yes.
Appointment letter of 1 urologist and 1 nephrologist to first time grant transplant license. After that, you just have to inform that someone.
So after some years, yes sir. So please take a mic.
Inspection committee is urologists only, well, us only. The transplant law says ki you have to be registered in that state, then you can have the license.
Yes.
1 and 2 are made by us only, ki 2 urologists have to be there.
Yes. So after few years of my practice, another center started calling me for doing transplants. That hospital gave me an appointment letter. I started doing transplant, and they had written a mail to the appropriate authority that this surgeon is joining us as a visiting urologist. doing transplants. So the appropriate authority came down and they de-recognized that hospital, saying that he is a urologist attached to another hospital, he cannot operate in multiple hospitals. So, and a case was slapped on me saying that you are doing transplant without authority or without approval, without consent. So I had to go to the High Court, and the High Court said if surgeon is recognized as a team member of one transplant center, he can perform transplant at other hospitals if they are registered under the Act. The registered hospital has to ascertain whether he is a member of the team of the other hospital or not. Once this is ascertained, the hospital can call upon any such surgeon who is not a member of their own team to perform transplant. Appropriate authority cannot raise objection to this practice. So this is a High Court judgment, and I had fought this case. As you said, we should put the government in dock.
Yep.
So we move on to the next case. Superintendent sir, in very early part of my practice, I was facing a case, mother to son transplant, and that mother was not signing on the consent forms. And I told them, अगर आप साइन नहीं करना चाहते तो आप अपने शहर वापस चले जाओ और वहाँ डायलिसिस करते रहो. So the daughter-in-law told me, this mother is not signing on the dotted line, and she is insisting that a certain amount be deposited as a FDR in her name in bank, then only she will sign. So now I am aware of a potential transaction in a mother to son transplant. What is your take on this?
See, as a committee, obviously we have to see the financial transactions, and I have seen one case where the authorization committee has rejected because of father who has 75 lakhs in his account, and before coming to India he divided to 3 daughters, and daughter has upfrontly told in front of the camera saying that yes, my father has deposited 25 lakhs in my account, because he doesn't know that he will come back in what situations, right? And transplant authorization committee, what I told that, consisting of health secretary and legal, they have taken cognizance of this statements and rejected this case.
Jamal, would you do this transplant?
Yeah, I think I would. I mean, there's no evidence here. There is a quid pro quo. I'm giving kidney, so you're getting money. Money passes between parents and children. I don't think you have to, try to read too much into it.
The law is silent on financial transaction between past relatives.
Yes, exactly. Yes. So there is a Karnataka High Court judgment which says that if relationship is established, you don't need to poke your nose into the potential suspected or even documented transactions between
Sometimes,
the donor and the recipient.
It's very difficult.
Yeah. Yeah.
Yeah,
so
most of the time we had.
I come to a very explosive question. You have done a transplant, Manas, and 6 months down the line the donor says that I am not the related donor as written in those papers, and I have been promised certain amount of money which I have not received. So now I will take you to either police or court. Now what should be done? You have been taken for a ride.
Sir, this was a first degree relative. I mean, not a spousal.
You have done a transplant as a spousal transplant approved by the competent authority of your hospital.
Yes.
And now 1 year or 2 years down the line, you realize that, or the donor has realized that her check has bounced.
I've come across such, real cases. But in this case, the donor, whoever the donor is, he or she is equally responsible for this. Because at that time also, in front of this thing. Yes.
Can authorities let you escape the news if you say that मैंने तो permission लेके transplant किया है, अब वो पत्नी नहीं है, वो उसकी जिम्मेदारी है कि मेरी जिम्मेदारी है?
No, you cannot
Will
escape
authorities accept, or should they not accept this argument?
They should.
Yes.
So just to add, before giving the clearance, obviously we all must have scrutinized the documents,
yes,
such as marriage certificate,
yes,
right? the consent what has been given by the
Yes,
family,
yes.
the donor.
After due diligence, approval had
Obviously.
been granted.
So whatever they can quote, right, we also have certain proofs that the donor has agreed and given a consent, not at one step, on various steps, while consulting to doctors, while consulting to transplant.
And not only given consent, but committed forgery.
Yeah.
Yes.
So, in our law, the problem in our situation or in our country is, up till now, no such donor or recipient had been put behind bars. One donor or one recipient goes behind bar for forgery. This practice may probably stop and protect surgeons in future.
No, donors and recipients have gone behind bars. And in the Hiranandani case, I mean, both the donor and the recipient were arrested, in addition to the doctors, unfortunately.
So, doctors were put behind bars
but the
for a
donors and the
longer
recipients,
duration.
yeah.
So that's the reason why we have started, most of us are doing video, taking video recording of the consent and everything.
So, I have been directed to sum up this. I will sum up this presentation or discussion in just 3 or 4 words. Dear friends, cover your own ass first, because that's the most important structure in your life. Thanks.
Thank you, Dr. Ajay Oswal, for this thought-provoking session. Thanks, Dr. Pranav, Dr. Jamal, and Dr. Manas Ranjan. So we'll be heading over to the second operative workshop. So I'd just like to brief you about the second case that we're operating on. So in this case, we have a 49-year-old mother who's donating one of her kidneys to her 27-year-old son. It's an ABA compatible transplant, both having A positive blood group. The donor is a 49-year-old female with a BMI of 34.69. There was no abnormalities in her investigations, and she doesn't have any prior history of surgery. Her examination findings were normal. On evaluation, her left kidney had a DTPA of 53.3 and the right kidney had a DTPA of 54.1. The CT angio shows 2 arteries on the left side, both having ostial diameter of around 2 mm and supplying the accessory artery supplying the lower pole. The recipient is a 27-year-old male with a BMI of 25.51 with the blood group of A positive, and he was initiated on dialysis 2 months ago, going thrice weekly with a native urine output of around a liter per 24 hours. Their cross-match, flow cytometry and CDC cross-match were both negative, and they had an HLA match of 6/12. The recipient received injection basiliximab 20 mg as an induction dose in the OT today, and he was started on immunosuppressions of tacrolimus, mycophenolate and prednisolone 48 hours prior to surgery. So the decision was made for the donor to undergo a left laparoscopic transperitoneal donor nephrectomy with vascular reconstruction, and the recipient is undergoing open live renal allograft recipient surgery. So for this session, I'd just like to welcome Dr. Muruganandam, Dr. Rahul Yadav, Dr. Priyadarshi Ranjan, and Dr. P.V. Singh to please chair the session, please. Thank you.
Can we have the CT image of the arteries, please? CT scan image of both the arteries. So who are the operating surgeons on the recipient side and the donor side? Can we know the names of the...
So for this case, we are having Dr. Ruchir operating on the donor, sir, and Dr. Pragnesh is currently on the recipient side.
All right. So Dr. Pragnesh, are you with us? Are we connected to the OT? Ruchir, Dr. Ruchir.
Hello.
Hi, Ruchir. Ranjan.
Hi,
Ranjan. Can you just explain us what structure did you cut and what are you doing right now?
Currently, I am the superior pole. I am separating adrenal from the upper pole.
And you have already cut the adrenal vein.
Yeah, just a minute. Let me show you. So this is the adrenal one vein we have cut. Zoom out, please. Zoom out, zoom out. Yeah. So this is the kidney. We have mobilized the colon, lifted gonadal vein ureter complex here.
Lumbar vein also you are through?
Lumbar vein we are through. This is lumbar vein.
Okay.
Okay. So I was trying to find out artery from here, but it looked a bit difficult, more embedded within the fat. So I decided to go to the superior pole first, separate it from here. The kidney is more mobilized and it may be easier for me.
You're able to see the pulsation where you are.
Yeah. So the superior artery pulsation is clearly here. So I used a hook here for more finer dissection instead of harmonic. So here the lip of the adrenal is there. And once I dissect a little bit, I get a plane, then I'll use a harmonic here.
So what is your usual practice to dissect the adrenal of the superior pole of the kidney? You come lateral to medial or medial to lateral? Which
Mostly
way?
I go from medial to lateral.
And division of the adrenal vein is the first step?
It's first step.
Can we have the CT images here as asked?
So I am a bit slow here because what happens, the left adrenal it curves around and wraps the hilum. So I try to dissect it very gently. It may take some time, but at least I want to be sure that all the structures are safe.
So on the recipient side, Dr. Pragnesh is preparing the inferior epigastric, it seems. Can we have the audio from the OT number 3, the recipient OT?
Hello.
Hello.
Can you hear me? Am I audible?
Yes, yes, yes.
Yes. So we are preparing a transplant bed.
Okay.
So we have looped the external iliac artery. We gave the hockey stick incision parallel to the rectus muscle. We have not divided any muscle We have just separated the facial attachment after incising the external oblique aponeurosis.
So what is the plan of vascular reconstruction in this patient?
Sir, looking at the CT, probably a pajama will be made, pantaloon will be made. Rest we will decide on the bench. We have preserved the inferior epigastric artery also. We have not prepared yet. Or else we can do one in the external and one in the internal.
Can you ask somebody from the OT to show us the CT angiofilms?
Donor OT में बताओ.
Are we connected to the donor OT? Are we connected to Dr. Ruchir?
You can again ask to Shaunak, our anchor, who can see on the PPT slide also.
So are there any precautions you take to prevent lymphocele while dissecting the recipient bed?
Yes.
What is your choice?
Clips wherever I found the lymphatics.
Dr. Ruchir, are you connected? Hello? OT number 8. Can someone connect to OT number 8? Donor side.
Hello?
Hello?
Hello, can you hear me?
Yes, Dr. Ruchir. Can you explain a little bit about the CT angio of this patient?
So, this patient has got two renal arteries around 8 mm apart. The ostial diameter is almost equal in both.
Okay. And this is a 34.2 BMI donor. Any special piece of advice for such kind of patients while operating?
Just be gentle, follow the plane. A little fatty patient, usually the planes are good. The fat strip off easily. But in some cases, the toxic fat, then it becomes difficult. So mostly what I have observed in females, the fat is usually more softer, easier to peel off. In males,
Usually you always choose left side irrespective of the vascular anatomy, or this particular case is not right side?
Multiple factors.
Yes, what are the factors you normally consider? Your protocol?
The vascular anatomy as well as the GFR.
Yeah,
If
this
there
is
more
equal
than
in this
10%
case.
difference or 10 ml difference in the GFR on both sides, we'll choose the lower one.
Okay. So that's the bottom line.
Yeah.
Then?
And vascular anatomy, definitely. Left is usual preference, but if required, we don't hesitate to take the right side.
Yeah. Suppose the right side has got a good vein and the artery, single artery. Still you go for left side 2 arteries?
If the GFR is different, yes, otherwise yes. Mostly we go for the right, left. Left is our preference.
Okay.
So you want to mobilize the entire upper pole, Ruchir, and then look for the arteries?
Yes, since I am doing things this way, so I thought to complete it as well, right now. So I can see the muscle now. vessel is going to adrenal, I am cutting it here.
Yeah, 2 arteries. Actually, Ruchir, I could see both the renal artery pulsation just above the vein. If you zoom out a little bit, I could see. So your artery is not far superior; it's near the vein itself.
Yeah, near the tip of the suction.
It looks like a lymph node to me, but anyway, I'll maintain a distance. So I positioned harmonic in such a way that active blade remains upward.
Yeah, that's a very valid point. Yeah.
So little bit finger movement at the joint where you can rotate the blade. That's the trick.
Dr. Ruchir, any thoughts about flipping this kidney and seeing the arteries?
On left side, we usually don't flip it first.
Actually, artery.
In
Ruchir,
this
at least
donor,
one image.
why right kidney is not being retrieved? Left has 2 arteries. Right has good enough vein and single artery, and acceptable GFR on both sides. So why not take right kidney?
Yeah,
Ruchir.
this we discussed.
Yeah,
Dr. Ruchir.
We are more biased maybe because of the vein characteristic. Vascular reconstruction we are doing routinely, so we are not very averse to doing a vascular reconstruction rather than tackling a thin, flimsy vein.
I think I would also buy that point. In my preference also, I would like to go on the left side only, because somehow I feel right side laparoscopic donor nephrectomy is technically more challenging, especially when you are a single surgeon doing both donor and recipient. So my preference is also to go ahead with either there are 2 arteries or 3 arteries, we can manage laparoscopically, because right mostly, at least in my practice, I do open. I don't do laparoscopic right donor nephrectomy.
So do you mean to say that just because you want to always do lap donors,
Yeah.
you are switching sides?
Just to extend until unless there is some medical contraindication or an indication to go for a specific site. Otherwise, just for vascular anatomy, I would always like to prefer the left side, because I'm more comfortable doing a laparoscopic donor nephrectomy on that side.
So I can see one artery here.
Yeah.
Yes. So CT wise, it looks a perfect case for a pantaloon.
Yes.
I mean, that's a question for the audience. I mean, how many prefer open donor for the right side? I mean, okay.
Yeah, good number.
We routinely do a lap for even right or left. We usually don't do open donors, but obviously if there is any difficulty, we want to take an extra cuff, we can do that.
Actually, we have an open mind. We used to choose right side. If the right side vein is good enough length, and during the surgery, if it is not appearing too thin on visual inspection, we harvest as on the left side. If not so, then we'll subcostal incision, changing towards the supine position. That makes the incision smaller. So we do good number of right side. But I know many centers, they, irrespective of what is the anatomy, they always choose left side. Many centers I know there is a protocol.
And that's the benefit in retroperitoneoscopy. I mean, on the right side, one can go up to the aortic border easily. But with a transperitoneal way, I mean, a little bit of more expertise and more labor is required.
Yeah, because in right side, at least I would always like to take the cuff of the IVC. And once you are taking the cuff of the IVC, you need somebody who is by your side to repair that IVC. And many a time clamps slip.
Many a times.
Yeah.
Initially we started like this, but later on we applied lap Satinsky, then we dropped it also, and now that's just a venous reconstruction with a gonadal vein helps us. So we routinely apply a hemolog clip despite of the length of a renal vein on the right side.
So I would prefer to use that time to reconstruct the two arteries on the left side rather than reconstructing the vein, because vein, so many problems I've seen over the years that for the past so many years we have dropped the idea of right until and unless we are cornered to do the right.
So your right is not right for you, only left.
Dr. Ranjan, in your experience, do you find venous complications are that frequent?
See,
that one should worry
it's not that frequent. It is just that one case out of 100 which will take your night away. And see, right side vein, nobody can predict the anatomy, the texture, the thickness, the walls of the right renal vein. And right veins are directly draining into the IVC. The length is small, and in my center I usually do on both the sides. So I have a very low threshold to, so I can't leave that IVC in somebody else's hand. So I have to repair the IVC also and then go back to reconstruct the artery. So I don't want to take that risk.
Actually, on the right side, we were doing routinely right side donor. We used to use the lap Satinsky, retrieve with the cuff, then suturing. Then one case I had a very bitter experience. By the time actually the hemolog clip of the artery got caught in between the clips, which you could not observe from this view. And luckily, by the time we removed, closed the peritoneum again, when we went and saw the edge, it was not there. So we could quickly open and came out of that. So from that, we thought it's not that safe to do at all. So now only two methods we use. One, if the length is good, during the dissection, we'll come to know the vein is too thin or slightly thicker. Like this left side is doing Ruchir. We were able to judge the thickness of this by this flow and the transmission of the light across. So if that is good enough, we'll put a 2 hemolog clip and retrieve. If not, then we'll change the position to supine. By the time we'll prepare the bed on the other side, and we'll do a subcostal incision, do a proper open Satinsky and remove that. And I think from Bangalore, one surgeon has told they can put one small pediatric Satinsky through the hand-assisted port and put. But I think for donor, better not to try all this.
See, putting a subcostal incision instead of a fan and steel, I still am a very great fan of fan and steel incision because it is so painless, always hidden, there's no muscle cut. Converting it into a subcostal incision, which is cutting the muscles, painful, dense scar. So
there is something called L galley clamp. So this is like actually made by one surgeon called Risk L Galley from University of Alabama. So where you can put the hand through a hand port, and you can clip it. It is not a pediatric Satinsky, it's a long one, and it's got a peculiar angle.
The handle will be outside the body or in total clamps are
the hand will be inside the body, and there is a Satinsky kind of thing. It's just kind of peculiarly angled.
No, the handle of the Satinsky is outside the body?
No, inside, completely inside.
Oh, then it's like a pediatric.
Yeah. What clamp is called? L Galley.
I think my concern about having when we do, even when we apply Satinskys in open surgery, we always apply 2 Satinskys.
Yeah.
In all these tips and tricks for doing a laparoscopic right-sided donor in which you have a single clamp on the vein, on the right-sided vein, that would make me very, very uncomfortable.
Absolutely.
Because loss of control of that vein could be a catastrophic thing. The two things I'd be scared of, one, bleeding would be my lesser concern. The greater concern would be massive gas embolism. You have a pneumoperitoneum, you have an open, an IVC, you could have, massive gas influx. So I think, personally, I don't think that these are very safe techniques of doing
absolutely
it.
Correct. Yeah. I have done quite a number of cases, and one case made, as Ranjan is telling, is that the one
many a times there are small veins draining from the liver into the IVC, which get entangled into the Satinsky and cause torrential bleeding.
The Satinsky applied through the port, it always keeps moving. Whenever you're doing
tackling a left lumbar vein is comparatively easier rather than tackling a right lumbar vein, because it is just posterior and just goes inside the IVC. So many a times while putting the clamp also there is torrential bleed from the right lumbar.
Yeah, yes, Aditya.
Yeah. I have done 3 cases so far. What I found, there are multiple variable factors which one cannot predict while planning a lab Satinsky. The issue is Satinsky is fixed at 2 points. One is where you apply it IVC, that fixes it. The other point is at the skin, that fixes it.
That keeps moving.
And that keeps moving, and then there is respiration, there are so
Pneumo.
many things. Pneumo, sometimes it is less, if abdomen gets decompressed. There is very high likely chance that how secure it may be, something hits it from outside, then you are in a soup. Other thing is, while in the enthusiasm of cutting, once it has happened that I realize that I have cut it too close to the clamp.
You can't
there
switch
is not much vein left above the clamp. Then the other way was to go below the clamp, pass box stitches and close it, and then obviously it becomes cumbersome. But the one which you referred, Dr. Dhanpal, he has demonstrated from Bangalore. He used a very small Satinsky. It's so lightweight, it just stays there. It's quite secure.
The entire thing goes inside. That's
entire
what.
Thing goes inside. You put your hand inside, just put it there, clamp it, come back, take out the kidney, and go back and repair it. And even you can put your hand to help yourself in suturing the stump. That's still quite secure compared to the lab settings.
Absolutely, correct.
That's called a PDA clamp.
No, in fact, what Jamal bhai brought the point that in open donor right nephrectomy, we put 2 Satinsky clamps. First, we put a clamp, we cut the IVC cuff, take out the kidney, and then place a second clamp behind and take out the first clamp so that you can easily see the margins while suturing, which makes it pretty secure feeling to me at least. So that comfort is not there with single Satinsky, especially on the IVC.
Experience I would like to share this. It was another case of auto transplantation for a Takayasu arthritis. So one kidney was knocked out. Patient was only with one kidney, which was the right one. Already it was stented twice, and the second time twice it got blocked also. They have done balloon angioplasty for the renal artery. Again, almost getting blocked, creatinine 3.5 around a young lady. So we decided that we will take help of cardiac surgeon, and we go and we'll see whether we can get it out. We take the clamp, and with the cuff, how do we do it? What happened finally, to cut the story short, where I went with the idea of lab that I mobilize entire kidney, take the cuff, and we see whether we can put a clamp over the stent which was there. The stent and with the arteritis and all this, everything is so fibrous. We are not sure whether we will get
it will stay.
The clip will actually occlude the artery. So finally what happened, we thought we open it, take the cuff, and we take out the usual like we do right donor. But in the enthusiasm of doing it open, despite being midline incision, because we had to do a transplant also, we thought with the same one we extend and we do the transplant. The moment we flipped the right kidney, it got avulsed from the aorta where the stent and the normal artery was there. Once avulsion happened, in the panic, nothing came to mind how to take off this and that. Just cut wherever it is, apply Satinsky, came out with the vein. Anyways, the artery is short, vein is short, hardly 5 mm. Then luckily the internal iliac was good. It was not affected by the arthritis, it wasn't stenosis. See, we took a reverse flap of that, reconstructed it, and she being a lady, and we could preserve the gonadal vein, and we reconstructed the renal vein with that. So case came out good in the end, but opening and having the idea that everything will go fine, sometimes may not go that well. Suddenly, being a lab surgeon, I fail to see things. Suddenly, when things open, I realize that I can't see anything.
Yeah. So you expect the best and prepare for the worst.
So Richurji, this is the dense lymphatic duct you are trying to cut, Dr. Ruchir?
Yeah.
So this is the lymphatic?
Yeah. So it was a transported pulsation at that time, which was looking like an artery. So artery, if you can appreciate, one is this artery, and other is this one. These are two arteries. One
So
is the superior pole of the superior aspect of renal vein, has a little bit more cranial. So the lymphatic vein, I'll be clipping it.
Yeah, Naveen, you want to ask?
Yeah, basically the right donors. So I have this question to whom, like to all those who have experience with the robotic thing. So because, I mean, the main thing about donors is that we don't want a bigger incision and we want to do minimally invasive. So like what is the opinion about right robotic donor? Because when we have difficulty in lab, but in robot we'll have a better control of the IVC and we can have a better dissection of the vein, right?
How do you think the robot has got better control over the vessels?
Because we have a like we can take the control of the IVC in a better way, and we'll be able to take the sutures in a more easier way. We don't need a Satinsky.
No, how the suturing is okay, but how will you take the control? Which
so
instrument will you use?
So we can mobilize the IVC superior and inferior to the renal vein and loop it. Yes, sir.
These are all possible by lab.
Yes, sir. So after that, suturing would be.
Suturing also
is possible by lab.
We were doing that.
Yeah.
But how to control that vessel till you remove that and suture? Between removal and suturing, how to hold that?
So it is the same like how we do for the IVC thrombectomy, where we have the control of the.
I was just coming to that point. Probably you are extrapolating from right RCC with an IVC thrombus.
Yes, sir.
In a transplant, the focus is the recipient and the kidney, and then the donor. So your energy is distributed at all three places. You can't afford to have anything going wrong at any place. In a destructive nephrectomy, which is usually a tumor nephrectomy, you are not concerned about the kidney or the thrombus. You can repair the IVC anyway, put a clamp across anywhere. Okay. In a donor nephrectomy, the donor's other kidney is equally important. The kidney which you have taken out is also very important. You have to perfuse it in reasonable amount of time. And you have to see that you have got an adequate length of the renal vein, adequate caliber, as well as the cuff. So all these things are important. So you want your attention to be least to something which is unexpected. So the idea is to go very sorted.
And the
so
thing,
that you can sail
IVC thrombus patient can afford to have multiple transfusion, ICU care. All these things he can afford that, but not the donor who is altruistic, not having any disease, to go. This always that risk is there.
And IVC filled with thrombus doesn't bleed like the normal IVC.
One more point to make here is a lot of things in a robotic surgery is dependent on assistant.
Yeah.
Your assistant to be of the same caliber like you are while putting clips, while doing so many things. I mean, for that you can't risk a donor. And anything which is possible with laparoscopy, robotically can be possible laparoscopically also.
And of course now the robot has got good clip applicator.
Yes.
Now it's nice curved and surgeon can control that.
And whenever the mishap happens, de-docking a robot takes 2 to 3 minutes. It's very difficult in an emergency when the IVC is ruptured and you are trying to de-dock the robot and remove everything and then put the open trolley, because you have to do it within minutes.
Yeah.
So that is a real challenge.
Probably somebody will do. No, you've given the idea, somebody will do.
Thank you.
We can just assume the benefits of a robotic surgery, but what are the problems come with the robotic surgery one has to keep in mind? De-docking, good assistance is needed. All these things to be kept in mind as well.
Yeah, got it. Thank you. Yeah, or we can have a better clamp so that same like laparoscopic clamp, we can have a separate port through which we can place the lap Satinsky.
Yes. Okay.
Bottom side is that once you take out the pneumo is gone.
Can we connect to OT number 8?
Then what happens is that all the bowel and everything will come inside.
OT number 8.
Then it tend to displace. That is the whole problem. So
Dr. Ruchir. both the arteries were seeing very nicely from above the renal vein. So why do you want to dissect from going behind the renal vein?
Yeah, I also think so.
Because both the arteries were very clearly seen above the renal vein. So what made you think to go from behind? Because
I feel I'm more comfortable putting a clip from this side rather than going across this. Okay. If I put a clip across this thing, I have to retract it. It will be something.
No, not like. No, probably the upper pole, if you mobilize little more, from the upper pole, if you stretch, this will come straight to you.
Yeah, rather than going from behind, because you might be at risk of rupturing the renal vein.
You can just flip the kidney as of now.
Yeah.
And can be taken.
See a little bit, and I'm going to flip the kidney.
And can somebody adjust the camera settings here? I mean, things are looking little brighter, all red. I mean, anything more, sir?
Resolution part. Yes.
Sir, about the right donor, I'm Dr. Himanshu Sharma. When I was there at Max, we were using a TA30 stapler to take the right renal vein along with a small cuff. Just wanted to know if anyone else can share their experience about use of staplers in the right side.
Dr. Jamal can answer. Yes.
Yeah, so I mean, I think the standard of care should be a TA30 stapler to manage the right renal vein, where you get the full length of the vein, you get a certain amount of cuff by tenting up the vein, and you get absolutely secure closure. Your stapler is not going to fail once properly fired, and we published in the past, and it's probably the standard now. The practical problem is that for unknown reasons that even the company people can't answer, laparoscopic TA staplers are not available in India at all. And this has been a chronic problem over the last 5 or 6 years. There was a shortage of staplers, then I think Covidian introduced a stapler, it was there for a few years and again it's disappeared. So every unit that does laparoscopic donor nephrectomies, particularly the right side, has this dilemma, and there are many ways in which they're all tackling it in their own ways. So this all ranges.
You told once the TAA stapler, you remove the.
Yeah. So again, see, this was at that time Johnson was selling a 6-row stapler without a knife, and we were able to modify it by manually removing 3 rows of staplers to create. So to remove 3 rows, keep 3 rows, and effectively convert a GI stapler into a TA stapler. But that was specific to that device, and even that device is no longer applicable. So we've used our last stapler. So I think I foresee us using more gonadal vein extensions, because that's a useful adjunct. If you, especially in a multiparous female donor, they have good, large caliber gonadal veins. You can retrieve the gonadal vein at the time of surgery, slit it open, make it into a cylinder, and extend your right renal vein with it. Other options are to do a terminal opening, as has already been discussed, and apply Satinsky clamps. Just go with wet clips and accept a short renal vein, and in most cases, in a donor in a recipient who's not very obese, you can get away with it. Or prefer, as discussed in this case, prefer to go on the left side and accept a complex arterial anatomy instead of a short renal vein. Again, it all depends on the surgeons, whether they're more confident in tackling multiple arteries or a short vein. So there's multiple factors here. There's no answer for each particular case.
I think right lap donor become easier if either the hemolog clip or the stapler, they make like a broad U. If that shape comes, then it will solve all the problem.
Yeah, I mean,
they said they are into that making, but we've never got
when that comes, that will be a game changer for laparoscopic right donors.
There is a stapler. I had discussion with company also. It's a almost C or U-shaped stapler. It's a purple one which comes, and it is used in colorectal surgery. But again, it's a 6-row stapler, and we spoke how we can make it 3-row and all. The end users are so less; they are not able to assess who will end up using it. They make it, they modify it, and will it really be usable? The other thing, as a urologist, we are not well versed with the usage of saphenous vein. It's a very good vein. I think a couple of cases, call a cardiac surgeon and maybe you learn afterwards.
No, one is gonadal, but for female patients, Jamal has told, we also use, you can harvest the right side gonadal along with that.
It almost always works, but for the scenario where you find another option.
After closing the donor, then that problem comes, saphenous vein is better. Suppose you finish the donor, then after declamping on the recipient you have the trouble, then the saphenous may help. But if you are suspecting a short vein during the retrieval, probably the gonadal vein will be there useful.
One more option is there. I mean, Welfare Medical has got a reticulating hemolog clipper pliers. So you can get an extra margin by just reticulating it and getting 1 or 2 mm extra margin. They are very good pliers. I mean,
the robotic clip applicators are quite good. You can, in any angle you can apply. It's surgeon control. Now they have got a beautiful energy device also nowadays.
Those applicators and energy devices, they charge per use. So they are,
that is there, sir.
That's terribly costly.
That's true.
And on vein, I mean, it's a convention to use to double secure everything, to put double knot, double clip. Sometimes I've seen like somebody stuck and there's no space to put another clip. We get away putting a metal clip, or sometimes only one clip is there over the vein. But on IVC, one can never be sure. I mean, if you put one, so that's that.
Yeah. And suppose something happens the right side, one point which I learned from the liver surgeons is that suppose if there is a massive bleed, this clamp slips, it happened to us once. So taking the first stitch at the middle, that controls 80% of the bleed. This is by the anatomy. The liver surgeon showed me, Professor Rella, that actually it helped for us. Yeah. So normally when they have a IVC, we have taken a cuff, we removed the clamp, slipped out. So you will bleed, you will be packed. Then you will, when you go in again, the tendency is to start from one side on the top and you will coming down either below or up. But put the finger and 3 finger, one and the middle finger above and the thumb below. The index finger can control. The first thing will take the middle, the alleys, try to catch both ends and lift it up. One stitch if you take 80% control of the bleed. I have seen myself. Then again put another 2, one above, one below. Almost 95% is gone. Then you can put a full line. I think the urologists, many of us may not know this. The liver surgeons, they use this.
Dr. Rajiv, we'd be interested to hear your perspectives on, how you go about it in your practice and in America. How are you?
Yeah, he is liver surgeon.
Especially status of donor nephrectomies on the right side, the issue of the right side vein.
I do lap and assisted for right and left. That's what 90% of the transplant surgeons are used to for donor nephrectomies. So you already have your hand in there in case of any dramatic disaster. We have to cover it. We use Echelon Flex powered stapler for artery and vein on right and left. It has 4 rows of staples. Right side, as I said yesterday, if you run into length issues, you can use Dacron graphs, which is different. It's readily available in our wards. You don't have to worry about harvesting another vessel. It's simple. You can get size matched graft, so it's much easier. We use staplers. So Lloyd Ratner, who started lap nephrectomies, he actually uses a V-shaped, like he fires 2 rows of staples is what he was telling me to get a cuff of the cava. I've never really had a problem with length. I would just put the kidney on the, I don't like to use grafts unless I have to, so I just put the kidney on the vessels. You just need a little bit to be able to sew it. So I prefer not to use grafts.
No, so currently you'll use a 4-row stapler. Yes. So you leave 2 rows on the graft side, and then you have to excise that much vein, so you shorten it even further. So
you'll be losing
it's a
that.
Short vein, and it's a thin vein.
Yeah.
So you have to be careful with your technique.
No, but again, every millimeter is precious, and to lose that.
So actually,
but listen, are TA staplers not available to you, which fire a single row?
So they are
a single row, three rows on one side.
3 rows on one side, yeah. So actually, when I trained, that is what we used to use.
So
But,
that seems to be the better choice, because the vein is the final thing that you cut, and so you don't need any control on the kidney side.
Right. So I haven't, as I said, like I'm very comfortable transplanting short veins, short arteries. If you have, again, if you run into a problem, if you're not comfortable with the length, use an extension graft. But if you're able, the preference should be to not use a graft, and
Right.
the
So,
kidney would be lying on the
yes.
vessel. Like
So,
one of
and
the
again,
poles
you
would
know,
be on the external
the
iliac.
longer your vein, the less frequently you'll have to use a graft. So it just seems to make sense to maximize the length that you get.
Yeah, true.
And that will.
It's a matter of comfort. Like, when the day I run into a problem, I'll probably switch techniques.
No,
But,
yeah.
No, I think
until
liver
then, I'll
surgeon.
continue doing what I'm doing.
We work very closely with the liver surgeon. They use extensively in the liver. All the in the veins they use grafts extensively. So probably they are more comfortable with that.
One can dissect the whole external iliac, can clip the internal iliac vein to make it more superficial. And though a little bit of a hypothetical situation, but yes, internal iliac vein graft can also be retrieved to lengthen the vein of the right side.
But that will be very tough.
Yes.
I have seen sometime.
Dr. Rajiv, can you throw some light on hand-assisted laparoscopy, because it's not widely practiced in India. It's almost standard of care in donor in US. So can you highlight some?
Sure. So people do it. So there is a high Fenton steel, there is a lower midline, and then the Cleveland guys use a midline slightly above and below the umbilicus. I prefer a lower midline. A lot of my colleagues do a high Fenton steel. So you first make your incision, put your hand port. Then under the guidance of the hand, we put two 12 mm ports. So one is, 2/3 of the way from umbilicus to the SIS, and the other, a couple of fingers below the ipsilateral costal margin in the same line. That is the camera port. The working port is the right lower quadrant or the left lower quadrant port. And we use a single instrument like a ligature for the entire procedure. I prefer to do as little of arterial dissection anteriorly. So I would identify the vein, then I would immediately flip the kidney, get the artery, just the origin above the aorta, enough for the stapler to be applied. To just minimize the handling of the vessel. Dr. Anant Kumar's team, they don't go into the Girota. I actually go into the Girota as the first step, right in the middle of the kidney. I'll go all the way up, and then I'll go towards the diaphragm. I'll identify the vein. I'll take the adrenal. Then, I'll separate the adrenal gland. That way you get the entire upper pole. I haven't dissected any of the artery, like I don't even try to see the artery from the front. And then I flip the kidney. And then, you can just palpate with your finger where the artery is. Everything lateral to that is very safe. It's essentially bloodless. So you can keep taking that in layers.
Hello?
So it's much faster.
I'm audible
and
in
the only mortality, deaths that have occurred in US in donors have been at the time of port placement, where they were doing a total lap and the resident placed a port directly into the aorta, and the attending was not in the room. He was waiting for the resident to get situated, and then he would come. And this happened in New York City. It was one of the Northwestern alumnus, like 4 years ahead of me from Northwestern, who was the attending surgeon. But by the time he came, opened, the patient was already dead. So, it's safer to have your hand in there. The incision is pretty small. It's like, about 3.5 inch incision, just enough for your hand to be able to go in. Sorry? So we don't have that experience. Most of our patients have, the donors have BMI between, I would say 28 to 35. 35 is an absolute contraindication for us because above that you start having metabolic syndrome. So we are very conservative when it comes to donors because if something happens to the donor, the program shuts down. Even small complications lead to big problems. So we are very risk averse when it comes to donors, liver and kidneys. So yeah. Mostly they're like average BMI for a donor would be around 30, 30 plus.
So with robotic liver donors, I mean, what is the take?
Very few programs in US are doing that. When I was doing livers, I haven't done livers since 2019, but when I was doing livers, we used to do lab assisted donor hepatectomies, which is interesting because it was essentially an entirely open procedure, but we took the right triangular ligament through a subcostal port that prevented the requirement of a subcostal incision. So the entire hepatectomy is carried out through an upper midline incision. So after we take down the right triangular ligament, we'll put a Thompson retractor and use that upper midline, take the hand port out. So we place a hand port for that because you need to mobilize the right lobe of the liver to take the right triangular ligament. So that was kind of semi-open, but it's called lap hand assisted. That's what we were doing. I don't know how much. So one of my friends, I'm also a visiting professor in University of Colorado. So Trevor Needham, who's now the chief of transplant surgery at University of Colorado, which is where transplant started. Starzl was there first before he came to Pittsburgh. That's where he tried doing some of the livers. So Trevor actually, he's just learned the robotic hepatectomies and he's just starting to do robotic hepatectomies at UC now. I don't know of other centers where there. Dr. Humar in Pittsburgh, I did a fellowship at Pittsburgh as well, so Dr. Humar was my mentor. He does the maximum number of living donor liver transplants in US. They do about 100, which is like a huge for US. Nothing compared to what you guys do here, what Dr. Subhash Gupta, etc. Do here. But even he does not do robotic donor hepatectomies. He does open, standard open.
Yes. Recipient, they have done couple of robotic donors.
Yeah, recipient, it's almost impossible. Like it's.
No, I think Professor Rela is doing recipient. I heard.
Recipients.
Currently, is not there. They have two robots, one for donor, one for. I was told, but I have not seen. But in our center, they.
I heard that there is a German surgeon in Saudi who does that.
So actually Trevor went to Saudi to learn. That's where he learned and came back.
I think in Cochin, Amrita, they do routinely, I heard, robotic donors, liver.
Donors they do, but
yeah.
not recipients.
Dr. Rajiv, can I ask you a question? Yes. So when you do a hand-assisted lab donor, it's surgeon's hand or assistant's hand?
Surgeon. So it's a one person, so there's a assistant who will hold the camera. Surgeon, your left hand is through the hand port, and the right hand, when you're doing the left, so left hand is through the hand port and the right has the ligature. When you're doing the right, it's the opposite. Some people like to still they don't mind crossing their hands. I prefer which is more ergonomic so that my hands are not cramping. So
but I think the position will be in some twisted yoga position throughout the surgery. No,
no you need to be ambidextrous. If you're ambidextrous, then it's not a problem. So when on the right side, it's opposite. My left hand has the ligature and the right hand is in the hand port.
But on the left side, your whole hand will be inside. So the shoulder will be close to that port. On the right side, you have a long 30 centimeter instrument. Right. So you'll be always in the oblique position.
So that is actually because of the low phalansteal. I started doing that, but the problem was it was very uncomfortable for me. I was more comfortable with a higher lower midline incision. Like I go 1 finger breadth below the umbilicus, and then I make about 3.5 inch below that. That is kind of easier on your arm.
That makes sense. And the retrieval also through the same incision.
Retrieval,
So there is
yeah,
no.
so you just hold the kidney out and bring it. So
I think, yeah, yes, Aditya. I think Ruchir wanted to tell something in between.
So one case happened to be like this. We had already given incision pen and steel. My teammate was about to retrieve the kidney. They gave already artery was cut. When the vein he was cutting, so that it nicked the base of the stump. So obviously he started oozing, bleeding, so we could apply a small clip there, metal clip. There was not enough space to apply anything else, and quickly took out the kidney. But by the time I took out the kidney, that metal clip came off. In that moment, there was not much option whether to open, to convert, do what. So the one hand was already inside, so I could just press it there. Took a breath. What we did, the camera port we moved. We moved the camera to the lower port, which we from where we were applying the clip.
Yeah.
So the camera comes in the center, and you operate with the camera port actually. So with the help of the hand being there, it was just snugly fitting to allow space for the hand only, and we could control the leak and all. We could repair it. Small repair could be done, but yes, it is tricky. It is better to put a higher incision. Sometimes I've done it without, we don't use ports and all, but you can simply make enough space for your hand, but it has to be on higher position.
Yeah.
It can't be in the pen and steel one.
So it was a forced hand assisted case.
Forced hand.
Quick comment about the vessels, etc. So most of the transplant surgeons in US, we have a very strong vascular background, so we don't really worry about any vascular problems at all. We are able to deal with anything and everything. That's how we've been trained. So we don't really worry about the vessel lengths and this, but although, we try to get as much length as possible. We go right up to the cava on the right side. When we staple, we go, right on the aorta for the arteries. But it's, we're very comfortable dealing with any sort of vascular issues as a part of the training. So I think that is one reason why we don't worry about using staplers.
What I realized after, I saw the hand assisted in US, so when I was in US, so I tried to replicate that, but here the patients are so small that your hand almost fills up the abdominal cavity, so hardly there is any space to. Yeah, it's all interference, lack of pneumo. I used to struggle. Then after 3-4 cases, I had to switch back to regular. But hand assisted is quite attractive. That is what I felt, especially in big patients. I think it's quite fast, as you said. Yeah. And regarding the renal artery comment you made, you don't see any main renal artery less than 5. Here it is very common. We get renal artery 4 millimeter, 3.5 in elderly female donors. It's quite common here. Yeah. So even the main single renal artery.
Can we see the recipient on the screen?
They're not able to connect that for some problem.
I mean, with the 2 millimeter vessels, two vessels, I mean, too much of a traction on a vessel from the interior side will do spasm, and obviously, so once you see the arteries, just flip the kidney and just dissect posteriorly, avoid traction on the arteries.
Dr. Rajiv, you said you'll cut open the Gerotas fascia and flip. So while you flip the kidney, doesn't artery go into, say, kink and spasm or affecting the circulation?
Yeah, so you have to be careful about how you flip the kidney. So the direction has to be medial and upwards towards the liver. That straightens out the artery. So we are very careful about what position the kidney is when you flip it.
When you open the Gerotas fascia while doing the laparoscopic donor nephrectomy, does not the kidney fall towards medial aspect?
No, because the lateral attachments are still there. So you first go right onto the middle of the surface of the kidney, open the Gerotas to go up to the upper pole. Then you go up to the diaphragm. that is the first step. Then you identify your vein, you identify your ureterogonadal complex, you take the adrenal, you remove the adrenal, separate the adrenal from the upper pole, then you take down the lateral attachments, and then you flip the kidney, and then you dissect the artery.
And when you use, say, synthetic grafts for short renal vein, do these patients not need anticoagulation?
No, so you don't need any sort of anticoagulation for this.
Which sort of grafts do you use?
Dacron generally. So some people use it, Lloyd Ratner actually, he uses it on almost every single right renal vein, Dacron graft. I asked him, like, why don't you publish it? He said, yeah, I don't want other people to know what I do. But it's very strange, but you know, he uses it on almost every right renal vein.
So would most transplant centers in the US have a vessel bank? Do they practice, banking vessels? And
so if you have a liver program, then you get the iliacs along with the liver, carotid sometimes along with the liver, that you can keep for 14 days. But if you don't, like my program is a kidney only program now, so we don't have that luxury, so that's why we use the grafts.
Regarding anticoagulation use, I mean, everything has been tried and nothing worked finally. I mean, we all have burnt our fingers in AV fistulas and all, tried everything to somehow salvage the fistula when always there is a difficult situation. I mean, a good meticulous technique without holding the intima will work.
Yeah, Dacron we prefer because Dacron, the needle holes will not bleed, unlike PTFE. PTFE, there will be a lot of oozing, so that's a mess. But Dacron is just like your regular vessel.
Are there any units doing retroperitoneoscopic donor nephrectomy in the US? Because if you have a lot of obese patients, I think retroperitoneoscopy is a huge advantage there. Because all your abdominal fat falls in front. The flank is relatively fat-free.
Yeah, and that is one disadvantage of general surgeons doing kidney transplants. I think you guys are more comfortable. I don't know of anyone who's doing retroperitoneoscopic nephrectomies. If it'll start in Cleveland Clinic and UCLA. Because they're the urologists run the program. Yes, we are more comfortable with the abdominal intraperitoneal stuff.
I mean, perhaps you should think about, because you keep talking about how much obesity you face, and I think that is one additional advantage over transperitoneal, because transplant you're actually going through that big panus of abdominal fat, and the flank actually in a patient who's in lateral position, the fat does actually fall away. I mean, even in a very obese patient, the flank looks relatively lean and fat-free.
Yeah, but for donors, 35 is our absolute upper limit.
Yeah, it's the same with us. We don't
nobody will
35,
take it. So up to 35, I really don't think, I haven't felt the need yet, but maybe I'll see today. I think they're going to demonstrate, right? Either today or tomorrow. We'll see how that looks. It's very comfortable, yeah. The problem is implantation. So in certain races, like especially African American, they'll have a huge BMI 45, 46, and their pelvis will be really narrow. So you're working in a rat hole. So I get CT as a part of pre-op eval for every patient. That's a non-contrast CT. So that helps you with the surgical planning, and also it tells you how difficult your night is going to be, because I look at the distance from the skin to the external iliac where I'm going to do the anastomosis, and in a lot of these patients that is like more than 24 inches. The longest gastro that I use gastros for all my vascular anastomosis, the longest gastro I have in my OR is 18 inches. So it's really like you're barely reaching the vessel, and then you're working in a rat hole, and then you have to flip kidney to the other side to do the other side of the anastomosis, and the visibility is not great because the space is so limited and the kidneys are huge. Some of the kidneys are like 13, 14 centimeters in size, and so it's not easy to transplant these really big patients with really narrow pelvis.
So how pervasive is robotic recipient surgery, kidney surgery in America now?
I would say there are about 15 to 20 centers that have started doing it on a regular basis. But even in those centers, so when I was in Detroit, I was also doing some normothermic perfusion for Henry Ford. Henry Ford was one of the first centers that started robotic kidney transplant in US. That's where the Verticity Foundation is. But they're also, the nephrologists are not happy with the, outcomes. Like it takes much longer. The outcomes are not like the open where, everything is quick. There is a huge learning curve.
But for these extremely high BMI recipients, perhaps it would actually be easier than cutting through 24 inches of fat and,
Absolutely.
so those are the patients for whom it's actually, whom there is a well-documented benefit. So
Probably you're using the robotic instrument directly through the wound with the air docking.
Yeah, I don't do robotic kidney transplants, so yeah, but
I think they connected to the OT again. So, Dr. Ruchir?
That is why Henry Ford, actually, Dr. Mahind Bhandari, he's from Jaipur. He's a Jaipur alumnus.
I know in 2014, when before they started, they came to Medanta here and our center, and that's where they did 7 robotics at each places. So that's how we started, and that's how they started. So it all went together, and after that, they had this Korean surgeon, what's his name, who was part of their team, and he did the first few cases.
Buju John. In robotic transplant, the greatest challenge is the anesthesiological aspects also, the position of the patient, the fluid balance. So many a times you are doing a good job surgically, but because of certain other limitations, so there's a huge learning curve from all aspects. Otherwise, once that bridge is crossed, then the results are absolutely acceptable, but initial 10, 15, 20 cases are a disaster.
And the regulation is so much in US that there are at least 11 to 12 programs that try to start robotic kidney transplant, but after 5 or 6, they had to stop just because the results were not so good and they did not have support from the hospital for going on. It was not like the Starzl days when Starzl did the first 10 liver transplants, all died, but he was still able to continue doing them and result in the first.
Raju, the donor surgeon wants to say something. He'll come back to this discussion again. Dr. Ruchir, we are connected to you.
We are ready for removing. Dr. Anant has scrubbed for retrieval. Ureter has been removed, and we have observed good diuresis. So as you can observe, we have not gone into the Gerota's fascia. We have gone around it. We preserved all the hilar fat and just a little bit of dissection at the base root of aorta to identify the vessels. We can safely cut it.
So this is a case also you have to flip the kidney medially,
the kidney, we dissected from behind.
Okay.
So now we have got a nicely dissected hilum.
So you are going to clip the vessels below the vein or above the vein?
So from above, anteriorly. So can you appreciate the two arteries?
Yeah, both the arteries dissected. There's a complete free all around.
Yeah. So the first clip goes here. Usually we clip the smaller artery first, but in this both arteries are almost equal diameter. So clipping the lower one first. So you can appreciate there is a gap between the two clips, so that you are very secure.
Yeah.
The key points here are to ensure that the first hemolog is not applied directly on the aorta, a little bit above, and there should be a gap between the two clips. And as we will cut, we will keep a little bit of cup above the second clip.
So the metal clip you nicely applied now, but if you would have done that first, We're always doing that after putting the hemolock.
Yeah, after putting the hemolock, we just gently squeeze it, don't crush it.
Yeah, I know.
The idea is to just avoid the pulsations from being transmitted upwards. The literature says that hemolock clips the burst strength is more than 809. Yeah, this is our cutting, you can see.
Yeah.
Little bit of cuff is there.
Yeah, that's perfect.
Yeah, so you keep a little bit of cuff above, so to ensure the safety. And above RT, we clip all the lymphatics. So the incidence of chyle ascites or chyle drain is very, very rare in our center.
Dr. Ruchir.
Yeah.
So I just saw that you applied the clip on the first artery, then you applied the clip on the second artery, and then finally you cut both the arteries. So why couldn't you have applied the clip, cut the first artery, and then went to the second artery? And
Yeah,
then
it would have been done.
any specific reason? Because the instruments might struggle, and we might land up with some inadvertent injury.
Yeah.
Or the sister provided the clip, second one, so we applied it.
See, one advantage of what you said is we will have a good stretch on other side. Once you cut one, the other one we can focus.
Yeah.
But the
And
problem is the field will become little messy with the back bleed.
Okay, so I think the kidney is almost affected here. We'll just lift it up and see if there is any one of strand remaining.
Oh, you are able to feel.
Yes.
So the kidney is free.
I have not seen this.
Probably Anand sir is doing it actually.
Yeah, Dr. Anand has, he has retrieved it.
Yes.
So we were showing the sign, it is not Richard. Richard also together with
The pressure लगा रखा?
Actually, when I joined,
हाँ तुम्हारा.
3 months
अरे
I was
वो
there.
grey वाला कहाँ है बेटा?
Before I finished, again 3 months he came. So we are not observing fully. So with the hand you form like this.
Ruchir, can you get the camera focused on the perfusion bench?
Please focus the camera here.
The light is too bright, so
Yeah, they'll adjust it.
I think it needs adjustment of the one is focus, other one is illumination is too much.
So while dissecting the artery, we cut a little of preputial tissue from the adventitial tissue so that the lumen is clear before we insert the cannula inside.
so one artery is perfused. This is the second artery.
ग्रे वाला कैन्यूला मंगाया था ना, वो कहाँ गया प्लीज? ग्रे वाला मंगाया था, ग्रे ग्रे वाला सब बुद्धि कैसे बोल रहे हैं? So can you see the bench?
Yes, yes.
So
Ruchir, what is the pressure in the pressure bag for perfusing the artery? Are you applying some pressure or is it just by gravity?
no, it's under pressure. We keep it below 120 mm. It's below 80 mm.
The pressure is 80. The cuff is applied and pressure is 80 milligram of mercury.
We never go above.
So are there any specific guidelines or recommendations about the pressure in the cuff while perfusing?
Yeah, it says that it should not be above the systolic pressure. It should be mid-systolic pressure. So, because we should perfuse to the physiological pressure, we should not overinflate and other things because otherwise minor vessels inside may rupture.
Sir, so audio is not very clear. Ruchir, can you help us?
So the pressure is kept below the physiological pressure, mid systolic diastolic, so that the smaller inner vessels are not ruptured. There is no injury inside. So I am just repeating what Dr. Anant is saying so that you can hear it better.
Yeah, yeah.
The dilatation of the artery is a routinely, sir, or only for the spatulation or and reconstruction? For all cases, this dilatation is done, the dilator?
Hello?
Yes, sir.
Yeah. What was the question?
Nothing, sir. This, you routinely dilate every time, sir?
Yeah, these are the two vessels. We do gentle, we use these vessel dilators which are very flexible.
Yes, sir.
And these are the dilators meant for the arterial dilatation.
Okay.
We do the dilatation, we don't do over dilatation.
Okay.
Because if you try to do over dilatation, the intima may rupture. So once it is nicely going, it we dilate, and if think it is difficulty going in, then we just stop it. And since I am going to do the pajama, I will dilate them gently.
Okay.
And then यहाँ बनाए फिर हम वहाँ बने वही दिक्कत है।
So there's a question from the audience, sir. Is the dilatation necessary for the artery, or it can dilate by passive?
By gentle dilatation, you achieve two things. If there is a little bit of spasm of the vessel, that is taken care of. Second thing is your lumen is just become little, maybe 20% more than what it is, so your suturing and everything becomes easier.
So there seems to be a small branch also arising from this artery which you are perfusing. There's a small branch coming up.
There is something when we'll dissect it, I will wear my loop and I will dissect, and then anyway these two are to be joined, so that one has to go.
It's small, yeah?
Sir, which solution you routinely use for perfusion?
It's custodial.
We have custodial, and now the one Indian company has come out. What's the name?
Graft Sol.
Graft Sol.
and that is actually they have copied the urocolin and they make it there, and that solution is composition is same as urocolin, and one advantage is it's coming in 3500, it cost is 3500 ml for the 500 ml bottle, and others these are 15,000 or 10,000 one. So and you don't need more than 500 for live related. In cadaveric, yes, you need more solution and bigger packs. So Grapsol is available by the Indian company. I think MCure is making it.
Sir, your thoughts on perfusing with the RL?
Yeah. So actually we just doing that. It was just getting kink, so I'm just gently perfusing little more and then finish. And I'm going to take the kidney to other side and then we'll do the pajama. And there is, I think there is little bit branch probably that will get sacrificed. This is smaller one which you could see.
Yeah.
That can be going to the capsule
We
also.
routinely use
It
ringal
may be going to
racquet
the
only.
fat, it may not be going to the kidney. Okay, so I'm just going to take this whole thing to the other side.
Sir, your thoughts on perfusing with ringer lactate rather than using any solution?
See, actually in Sanjay Gandhi, we just used to perfuse with the ringer lactate, and we used to put soda bicarb and some heparin. Initially piperine, later on we saw that piperine is precipitating, so we stopped it. We used to put soda bicarb and heparin only. But what we have seen that kidneys end of the procedure is edematous, and sometimes we have seen we gave the name of third day oliguria syndrome. First 2 days kidney produces a lot of urine, and third day sometimes the urine output will go down, and then 4th, 5th day it will pick up again, and probably we thought that we are using hypoosmolar solution, and that's what kidney is edematous. There is a tubular edema, that's why it is happening, not in all patients, but yes, good number of patients. So once we change it to the isoosmolar solution like urocolin, Grapsol and HTK, you don't see that syndrome. So probably it is isoosmolar, there is no tubular edema, and there is no kidney edema, probably they are smooth post-op course. That's what I think, and since then we are using these solutions.
So, as we are closing this, I would like to introduce the team members here. So, I was assisted by Dr. Brajmohan, and cameraman was Mr. Shashi Ranjan, anesthetist Mr. Angad, he is just leaving. And Vaishali sister. I think that's all from the OT8. Now the action will be on OT3.
इसको यार थोड़ा इधर हटाओ, कहाँ है बंदे ये?
So I'd like to thank Dr. Priyadarshi Ranjan, Dr. Muruganandan A, and Dr. Rahul Yadav for chairing this session. For the next session, I'd like to call upon Dr. Pankaj Gaur, Dr. Abhijit Patil, and Dr. Shivam Priyadarshi on the stage, please.
अपोजिट वॉल लिया है कि इसमें सामने से बढ़िया अपोजिट वॉल लिया है सामने से अगर इसको अपोजिट वॉल एंगल के आसपास एक टाका टॉलरेट कर सकता है ह्यूमन मिडल ऑफ द इन डीप शीट मेरे पास डिजाइन पर विजन Designs for vision.
Hello, good afternoon, sir. I am Dr. Pankaj from Hall. Can you hear me?
Dr. Anant. Dr. Anant, are we audible? Ruchir?
Connection cut gaya. Sir, loop lagane gaye sir.
Yeah. So here, this Dr. Anant Kumar is trying to do this pajama. Anybody in the hall would be doing differently from this? Dr. Rajiv sir. So what would you do in this case? There are two arteries. So would you do the same thing, pajama, or you would anastomose separately?
Hello?
Yes, please.
Can you hear me?
Yeah, now we can
Yes,
hear.
Dr. Pragnesh, please go ahead.
Good evening, Dr. Pankaj and Dr. Priyadarshi.
Good evening.
Dr. Anand Kumar is getting scrubbed, so I am dissecting the kidney right now.
Right.
So, I think you guys call it pajama or pantaloon. We
Right.
call it B plus T.
Okay.
That's pretty much the same thing.
Right. Yeah.
I will do a separate.
So you would do a separate, even if the two arteries are almost same size?
Especially with both robot and open, I will do a separate anastomosis.
Separate
That's
to
just
the
for
external
place.
iliac, yeah.
Some specific advantage or some specific reason which you can mention for that?
No, I think it's one is the comfort, personal comfort level. That is one, and second is that when you do the pantaloon, there is a T comes at the end, so that tends to leak actually. It tends to leak in that corners in the pantaloon.
So there are two school of thought. So the many people that I've met. So some say that when we do two separate anastomosis, if they fall in one vessel, the other will not be affected. While on the other hand, what people say, if you do a pantaloons, it gives a wider anastomosis, less chance of stenosis. So there are two schools of thought.
Actually, one view is also that if you are doing two in the external, then you are having more chances of limb edema or transection or something like that. I mean the vascular complications leading to the external iliac jeopardization are actually doubling, because we are doing two arteriotomies and.
The counter argument for that, no, we are putting both arteries together.
No, of course,
if thrombus, yeah, so that's
so it's a trade away.
I think it's a personal choice, I would say. Many people who the method you are trained. So even in robotic, I would prefer to do as double anastomosis, provided the external iliac artery is okay. I mean,
of course.
recipient.
Yeah. You should have the pliable two
If
spaces.
it is too
where
bad, then probably one anastomosis.
Sir, could choti forceps de do?
Yeah, the only situation that you would actually have to do a single one is if it's a heavily sclerosed external iliac. But otherwise, I don't think it makes a difference. You do two or you do one.
But sir, in robot, I think if you do a pantaloons, it's slightly better because it gives a proper, bigger, wider anastomosis. As except when you do an open, you have smaller punches. Small size punches which are available.
Robot I have a 2.8 punch. So
Achha,
they make
if you have punch, then
yeah,
it is
2.8 punch is there. So, but again, to get a good arteriotomy for a smaller artery, it's slightly more challenging in robot, I would say. But still, you can get a fair amount of punch.
You don't always need a punch. I mean, you you have your scissors and like.
Yeah, not necessarily. We don't do with punch. We just But robotically, yes, punch is probably.
I think so. Dr. Anand Kumar does the pot scissors. I regularly use punch only.
Yeah, I was just listening to the comment that if you do the pantaloon.
Punch you use or the assistant?
The assistant uses
Hello,
punch.
can you hear me?
Yes, Dr. Anand Kumar. Please go ahead.
So I was saying that the angle, I will just show you the technique. With that problem will not happen. And it's very simple technique, very reproducible, because we are just going to show you. And you can see that this is little different. Give me click. The kidney has come out with all the fat, and lymphatics were clipped at the end, and all the dissection is done here when the kidney is comfortably sitting into the cold saline. So now probably this is coming out of there, but it is going to just put it. This is going to the fat, so we just sacrifice it. Just दिखा दो. Just give me the clip. I will later on just let छोटे बड़ा. एक और दो.
Sir, up to what ratio of diameter we should or we?
So now what we do, we start like that. We hold this is the ureter, this is the gonadal. Everything is. We just go lateral to this, and we start cutting here. In robotic, we just tie everything here. We just take a bigger clip and keep applying it for the vessels. Even if it bleeds after that reperfusion, we can just take care of it. There is not so much of tension as in the robot, because you are limited with your access and your clip. So that's what I call it, dressing up the kidney.
बेटा ये वाला कैमरा क्या कर रहा है?
Those people who do the dissection inside the aorta, this step is not required, but then you spend time there and I spend time here. Here there is no chance of bleeding and everything is before me, and we can safely keep clipping everything. Now when we reach to the lower pole, and this is the hilum, then we'll move like that. Clip. And in robotic we tie everything. We can tie it here also, but it will take more time. So कैसे दे रहे हो? क्लिप यार निकल जा रहा है सब.
दब रहा है सर हाथ आपका.
This is the hilum. I was just going a little closer to it. I'll just move away from here.
Dr. Rajiv, just had a question. Does anybody use microscope for any of the vascular anastomosis like liver or kidney? No? Not even for liver.
For liver, I do use, I did use loops. I also did pediatric transplants, both kidneys and livers. So for peds, I used 4.5x loops. But for everything else, I used 3.5. But now, my vision is +3. So I just use my regular readers +3 because I'm only doing kidneys. I haven't required loops, since I transitioned to only kidneys. But that has really improved my health. My spine, my shoulders, they're all great now. A lot of the surgeons in US, after 15, 20 years, they require cervical spine fusion and whatnot.
Abhijit, how often you use an end-to-side anastomosis in your institution?
Not much, sir. Not much.
End to side?
End to side. No, main renal artery to the accessory to the side of the main renal artery.
Implantation, you mean?
Accessory renal artery to the side of the renal artery, main renal artery.
Okay. No, usually not. Usually not. Yes.
It's best avoided. It's
Yeah,
not an ideal way of reconstruction because, if that clots your entire kidney is going to
Exactly,
clot.
sir. So same principle. A smaller artery will then trouble your bigger main vessel.
But I have seen Dr. Anant Kumar doing it.
Yes.
Dr. Anant Kumar does. So again, the question comes: if there is a kind of a one side is a small artery, the other side is a normal artery. What will you do? So one of the option is that what Dr. Anant Kumar does it, and then otherwise either to inferior epigastric or to the external iliac. So what would you prefer?
Especially for lower polar, we discussed this earlier today. So I use inferior epigastric, and I would do that after I've already reperfused. I'm not worried about the warm time, etc. I have all the luxury of time, and that is usually for polar vessel. It's a very good size match. So I never ever take inferior epigastric when I open. I always preserve it because you might need it for something or the other. But then that's a very easy anastomosis. It's an end-to-end anastomosis that you do. All you require is like 4 or 5 sutures. It's very quick anastomosis. Interrupted. I do it interrupted.
Interrupted. That the second question is that.
For me, the end to side has worked very well. I've done probably more than 100 cases end to side to the renal artery. Never encountered any complications. That's why I asked. So
we also are doing regularly at Max Vaishali with Anand sir's this thing only.
Yeah,
and
Dr.
if
Anand
it is less than 30-70 ratio, I mean up to 50-50 or 60-40 is okay for pantaloon. And if it is lesser than that, then we usually implant it.
Actually, we have published it, recommendation is 50-50, 40-50, 40-60, but we have published the paper is up to 30-70, pantaloon works very well. And the idea is that you make a pantaloon, it is easier, you do a simple anastomosis, and your anastomosis is also wider. And since it is well spatulated and done it, unlikely that one artery problem will be going to the other one, which is the people's apprehension. Now, I will try to show you that simple technique of making pantaloon. What we do first thing is, we just, just a minute, please. Yeah. So, pakdo. Clip. These are the lymphatics which I say that if you clip all of them, your lymphoria will be less. So like all these lymphatics, they all will be clipped. Okay. So what we do, we just first thing is, most important thing is we should make sure that orientation is not disturbed. So थोड़ा सख्त करिए पानी, निकाल दे पानी उससे, उस भर के निकाल दो. So it is oriented like that, and we will pass a dilator so that if there is any twist or anything, that will be taken care of. There is a vessel here, so I am sacrificing it here. Okay, just give me the dilator. So what we do, put a dilator.
So the purpose of this dilator is just to keep that vessel in the place, or are you actually dilating the vessel, sir?
Oriented. We are actually dilating, but not over dilating. That's what I am showing you. That this is the last dilator will go in this, and this one probably may accept this dilator nicely. So that's the dilator is. Now is two things. Is that we just oriented it nicely. करेंगे छोटा सा clip देना. There is a small vessel going out of that. We'll have to put two small clips on that. One more. ये छोटे वाले इंस्ट्रूमेंट रखें नहीं रखें? आगे थे ऑटोक्लेव ओके. Okay. Now just give me two dilators. थोड़ा पीछे छोटे वाले पीछे रख ले, जगह बन जाएगी. तो पानी और सकते कहीं से भी कर. Give me two dilators. Now the dilator we are going to keep it here. They are not the big one, they are smaller one. ये वाला लीजिए, ये छोटे वाले में डाल दीजिए. The idea is just to keep the lumen open. And सभी कर रहे हैं. Just I'm trying to show them. Okay, so now they are properly oriented. They are lying side to side. Give me the pot Caesar. Straight pot. नहीं ये वाले दो, ये ठीक है. Irish. This is rather Irish suture they have given me. That's fine. So this side we will cut, and we cut a reasonable length. The similar length we'll cut it here. And now we'll see whether this length is equal or I have to cut little more. So keep side by side. This will need little more. Okay. Now, what we do, we pass first suture here, but we don't tie it, so that my angle is very well seen when the angle is so I go outside in. Rubber shot.
Must be. You are using 60.
70. It is 70 proline, and only one suture will be used. You will see. Just put a rubber shot here. Yeah, cut. Yeah. Then another suture to this angle. 70 or more. So only 170 is required. Rubber shot.
0 नोटो टाइप करना है, NOTTO आ जाएगा नीचे कॉन्टेक्ट में सेंटर में.
So this is another suture is taken. नहीं दिख रहा मेरे को.
NOTTO.
Yeah, put a rubber shard here and you cut it here.
Sir, can we keep 2 5 French infant feeding tubes in each vessel so that it stabilizes the vessel?
We'll just show you. Just wait. What? Let me just do it
He
and
will
then
put
I'll.
dilators. He will put the dilators. Yeah. See, you usually put feeding tubes, huh? Okay.
They are pliable. You can place them.
Yeah.
Okay, so now just hold it here. Now we'll put the 2 dilators to stabilize it and keep the lumen open. And we'll take the posterior layer now. And angle we just don't tie it, we'll tie it later so that last sutures are very well seen. Hold it here like that. Just put it here. Now see, my one assistant is holding like that, and these 2 dilators are inside. And you will see that now my both edges will be very well seen.
Dr. Anand, I have a question about the use of dilators. Like I've seen you use the dilator like 9-10 times now in the artery. It makes me very uncomfortable. Have you had any problems related to using these dilators in all your these pantaloons, like any dissections or anything?
No, we never seen any dissection, any thrombosis, anything. And these are the now we are putting the smaller one just to keep it keep the oriented and in. The biggest advantage you can see there, I don't know whether it is being transmitted, both the edges are so nicely seen, and what I am holding is I am holding the adventitia.
So, Dr. Rajiv, what do you keep usually? Do you keep anything or without?
We do it a little bit exactly opposite of what Dr. Anant Kumar is demonstrating. So I would tie the corner stitch first. I would not tie the upper. So, this is the V, right? So I take the corner first, and then with one edge I'll go up to this. So here, both the vessels I'll take a stay. I'll not tie the stay. Like he tied the stay, he kept the angle open.
Right.
But he's going from top to bottom. I go from bottom to top, and the same thing on the other side. So just do it in a different way than what Dr. Anant is doing. But I normally don't put anything. I'm very scared of instrumenting artery. So I believe in like minimal to no instrumentation of arteries unless you see a stenosis and you have to dilate a stenosis. If it's a perfectly healthy artery, I don't try to instrument that artery at all.
Right.
Sir, is it possible to use an infant feeding tube for that?
Yes.
You don't really need it.
So just to keep it aligned, maybe sometimes this may be helpful.
So if you have the angle taken and the the stays nicely held. They're very well aligned. You don't need anything inside the artery. And so again, it's my personal choice. I don't like to put anything in the artery unless I absolutely have to. There's no other way around it. But you don't have to. If you have it nicely set up, take the angle first, don't tie the top, put two stays, keep that under traction, or the assistant hold it. It's a very simple, easy thing to do. It's just opposite direction. He's going from top to bottom, I go from bottom to top. But you don't really need to instrument the vessels to keep them aligned.
So you keep the corners away with the stay sutures to prevent the corner stenosis. And you start from the...
So no, it is easier. Now you can see the intima on both sides very clearly. Like here you're not seeing the intima, right? There from the opposite side, when you're doing it, you see the intima from inside, you see every stitch. Here you're not able to see that just because of the way this is being done. So I like to see every stitch. Even when I'm doing the artery, I want to make sure that every stitch
You can see the intima, you can see the intima here. Both are there. I could see they are close together. I don't know whether it is being transmitted that way or not, but
so you require 4 stay sutures.
Very nicely here.
4 stay sutures, no?
No, two on that.
Because
two on each side.
Dilators is keeping them apart.
So after I finish one side, then I put the stays on the other side. Otherwise, it's so small, you will have one proline that you are tying, you are doing your anastomosis with.
Interfere.
Then there are 2 other prolines, so it's too much blue on the field. It gets confusing. They get entangled. So just to keep the field clean, it's best to put the stay on the other side when you're doing the other side.
Then you flip the kidney to the other side.
Yeah, I mean, this is just, you flip the vessel. To the other
Flip
side.
the vessel, that's it, yeah.
Actually, it seems like the dilator may come out through the artery at any moment.
Pardon?
What's the question?
Okay.
One
of the...
will come out of that.
Yeah.
We are going to turn it, we'll just see. Just give me 2 minutes, let me tie these.
May cause some injury,
These two sutures will go that side, and now this anastomosis will begin from angle to the top, because that's how the only one suture is required to do all this procedure. That's what I'm going to show you, just a minute. Okay. Now, so just show them. Just leave it here. Give me this suture. Now you see the situation is like that, just now opposite, and just keep the dilators, and we go from angle to the top. There are 2 things like these. Rubber shots are keeping it up, and both the edges are very nice seen. I'll just show you. I don't know whether you guys can see or not, but I'll just show you. Both edges are very nicely seen. When I will lift this adventitia, you will see that both edges will be seen.
Abhijit, putting in these hard instruments inside the lumen of the artery, does it not screw up the intima?
We were discussing so much.
You
can just... We had a lot of discussion on this, so please. देखो देखो.
No, see, these are the soft, these are the just kept to...
Actually, it is not as scary. It looks very scary. But I have been assisting and doing this technique since last 8 years, and it's absolutely safe. I mean, we never had some intimal tear or any complication because of this step. So it is perfectly safe. It looks scary, though initially I was so scared also, but now we are comfortable with this.
And this is what I'm trying to...
Because infant feeding tubes are not that oriented. I mean, the purpose is to keep them oriented to each opposite to each other. But the infant feeding tube itself is soft
Flexible,
and
soft,
flexible. So sometimes when you are taking suture, it will go here and there and won't be like straight like that. So that's why.
And the trick is not to over-dilate the vessel. When you over-dilate, then there is intimal tear. You just do gentle dilatation, that is spas will be open up and the lumen will be open up. It will be number of times while you are trying to flush it, especially in multiple arteries.
Then, yes.
That cannula is not going in, but you just gently dilate it with the smallest dilator. And
Yeah, cardiac surgeons, they use shunt. I don't know whether you have an experience with
So
shunt.
otherwise it's a good
Cardiac surgeons, they use
but only
shunt.
thing is that assistants
we
should
don't
be
have
very
any experience with
familiar
that.
with this procedure.
No, you can put a kind of implant in the feeding tube. Small stick you can put always.
Actually, the shunt looks very similar to that. It's like an
Yes.
implant into a infant feeding tube. So.
No, and infant feeding tubes, they are usually larger than the size. I mean, these are very small because of this magnification we are seeing it, but these dilators are the smallest one.
Feeding tube, 4
Now this osmosis is done.
छोटी आर्टरी में दिक्कत सही बात.
We just required one suture. Sorry.
उसमें फिर वेंफ्लॉन वगैरह कुछ
And
डालना
we
है तो
just cut it, and then what we do, we take the same particular solution, cold solution,
हाँ नहीं होता तो इतने
and
सालों
we
से
just
कर रहे
take it
हैं.
now.
Dr. Anand, I have a question about the number of knots that you take at the top on each side. Normally with Proline I take 7 knots, but in these I tie from the angle to the top. So at the top I take 11 knots on each side.
Okay. So we usually take 1 or 2 more knots than the number of the suture. If it is a 7-0 suture, we will take 8 or 9. If it is 6-0, we will take 7 or 8. If it is 5-0, we will take 6 or 7 throws, knots.
Dr. Rajiv, why 11? Is it a cricket team, football team, what?
So usually I tie in every one Proline, I use 7 to 8 knots, whatever suture it is. I didn't know this formula of with the 0 you do one more. That
In that,
very
we may
sound-
tear out the suture.
Very sound formula, but I never knew. Now you can, while I'm doing this, there is a, hold it there. There is a small hole here in the vein. Yeah, just give me same suture, 670.
It's not looking at you.
There was some leak, is it?
There was
some leak, yeah.
Small.
Now this kidney is ready to be implanted, and what we take a small wet gauze piece, wrap it around it.
What artery is being prepared for this, internal or external?
This 27-year-old
So internal must be.
27-year-old boy, so we are just going to do the internal iliac artery. So we just keep it there, that keeps it oriented, lower part of the ureter is popping out, so we know this is the upper end because I think now 3-4 times in my 5,000 transplant career I put the kidney upside down, not intendedly, like by mistake.
It's doing open,
Just
right?
like
Yeah.
that.
That's open.
So we do the vein first, and renal, this artery is prepared, but now I am going to cut it, internal iliac artery, give me the right angle. So what we do, I just put a right angle, cut it, and then transfix with 2-0 Vicryl.
So do you use self-retaining or it just a diver?
This is the Omnitrack detector.
Omnitrack, okay.
We have 2 Omnitrack detectors. Sometimes we have a lot of operations are going on, and sometimes we don't
Bulldog.
get it. Bulldog. And we have a nice bulldog here. This bulldog can be applied in this way or this way, that way. Just and most important thing is, should not apply bulldog like that. You should apply bulldog at the junction of internal and external iliac artery. The reason is all the blood flow is now diverted. If you just put it here, some blood is there, and after some time some blood may get clotted there. So like inferior epigastric artery, we also put the clamp at the origin of the artery, and so that otherwise if you put it here, then probably this part, the blood will be accumulated, and then maybe इसको hold करो, सीजर दो, इसको खा ले रहे हो.
So I think both the vessels have been prepared, as I can see.
आज तो नहीं काटते, सीजर मांग रहे हैं भाई.
External is also
दो बार
where.
पॉट दे दिया. Excellent. Now we dilate this internal iliac artery also, little bit, not the over one. And the many ways I dilate, I'll just show you. Just give me the Vicryl, 2-0 Vicryl. You can use. फिर ऐसे दे दिया यार, I never take suture like that. I told you a number of times.
He's transfixing it. You usually transfix it? or
I
just
always
what?
transfix it because
So
that
neat
is the
only.
most secure suture.
Okay.
Dr. Anant, why are you doing the internal iliac in this case?
It's a 27-year-old young boy.
Really?
Yeah. So we are using internal iliac, but if suppose he requires second transplant, then it will be gone into the external iliac. In internal iliac is that easier, and your blood flow to the limb is not interrupted. And but we don't use it above the age of 35 because around 40 years of age they stop developing atherosclerosis in this artery. So now there are many ways of dilatation. Oh, this is right angle there. If just posing, I'll just put one more suture.
So what is the artery of choice at your place, sir, Raju sir?
For young patient, we use pediatric, we always use the common iliac or external iliac depending on the age and the size of the artery. And from 16 years to probably 30-35 years, if the internal iliac artery is good, we use the internal iliac artery. After that, we use external iliac artery. And in diabetic patient, like if the patient is the diabetes, then even in younger stage also we will not use the internal, we will use the straightway external. Now there is a many way of dilatation. I'll just show you the how do I do it. Just give me the right angle. take the right angle, gently dip with the hep saline, and we just dilate it little bit, no over dilatation, that's all. You can see little bit of size has increased, there is no intimal tear or anything. And then we flush it, Satansky clamp. This is the good Satansky clamp, the Sculap makes it. The advantage is when you apply it here, it is sitting nicely. Otherwise, just show me other Satansky clamp. No, this is not Satansky clamp. Okay, other Satansky clamp, they are getting out like that, and then it interferes. So I have seen the vein, I know this vein is little bigger, so I will give little big incision here. Okay, 60 sutures or 50 sutures. For right vein we take 60 sutures, for left side we take. I told you number of times, never give me like
So
that.
how many of us are using internal iliac?
One-third का junction.
Here.
नहीं बात बोला 2/3 and 1/3 पे लगा.
And external? Yes, so almost 50-50, yeah.
Okay, let me ask those who do not want to use internal, what is their objection in young patient not to use internal?
Erectile dysfunction.
Yes, Rajiv, yes. So, matter of training, yeah. So only thing is sometimes sometimes if there might be a kink if you are doing to the internal iliac, and that kink may cause problem later. So we had come across 2-3 patients like this.
So that,
yes.
That kink happens because you have not matched the length of the artery and excised the extra one.
Now, even if you match when you put the kidney later into the bed, there may be some kind of
just stay at till the end of the operation. We will show you if you place the kidney like that above the you will not see the kink, and we always make sure when we place the kidney finally we put the bowel inside, like not the peritoneal cover, and then kidney goes and rests over there. So there is a two advantage. The bowels are behind it, the kidney, so your biopsy is not a problem, and that lift the kidney. I'll show you. If you are not doing it, then you will not appreciate unless I show you.
Sir, in fact,
that is the big advantage, and that time you will show you that how your artery is nicely coursed and there is no kink. It's very important. Always make sure there is no kink, especially if you are doing the right side. Right side vein is short and artery is long. We often excise the artery if it is long to make sure that there is no kink. Right side kinking is more common in comparison to the left side.
Right.
Left side, if you just any extra, like you can see that I will excise internal iliac here because I cannot excise the renal artery because there is a pantaloon there, but where it is lying nicely, the rest will be excised.
Kidney lock.
Kidney. So these are the 4 corner stitch. I don't know. I have been using it for long. It helps in many ways. It just keeps everything open, and osmosis is done very quickly. And a very, very rare chance that opposite side will come in the way. There are many ways of doing it. In difficult situations, I have done it different ways, like taking the vein from inside out, from posterior suture from inside, anterior suture from outside. But these are the very different situations. But otherwise, in normal situation, you just do it.
So can we improve the angle of the camera?
Yeah. They will do that. Still. So if you are doing internal iliac, do you actually dissect the external iliac like this, what you have done?
But we have just put the loop to detect it. I don't.
Okay.
I don't even touch it. And I'll show you if it come in my way by doing the vein, I'll just put a adventitial stitch away from the artery and tie with the muscle and then just hold it like that. And then my artery will not be in the way of stitching the posterior layer of the vein.
So anybody in the audience is doing artery first and vein later?
Okay.
Artery first and
personally believe that artery is more precious. If you see both the anastomosis is precious, but artery has technical error. If there is anything, then it will have more critical thing. So I do artery first, so you will have more focus on the doing the arterial anastomosis, and then I do like the posterior layer from one side, then I will put the kidney, flip the kidney and do the anterior layer from one side, and then kidney will be in that fossa, and then we will see where the exactly vein is coming, and then vein anastomosis both posterior and anterior layer from the same side, means posterior layer from the anterior side and then the anterior side. So this way your kidney will be handled with the assistant only once while you are doing the arterial anastomosis, and at that time no anastomosis is fixed, so avulsion of anastomosis chances will be not there, and the arterial anastomosis is very very precise, and then venous anastomosis you can do means quickly. So I have now done more than 1300 transplant with this technique, and I feel so comfortable that I don't want to change this thing for me.
so you take care of the length of the artery and vein accordingly before starting the arterial anastomosis.
At the bench, the one mandatory thing which we do a leak test and then see the length of vein and artery. The vein length must be more than the arterial length. If it is equal, then we will sacrifice the artery. But we will keep the arterial length lower than the venous length unless until there is some early branch. In that scenario, we will try to put the vein anastomosis little lower side by stretching the artery so that the curve of artery king should not be there. So while putting
So
in
how,
the fossa.
how you adjust the length when you're using internal then?
So are you using
this is
internal
for
or
your external that the
Yeah, internal iliac artery, usually we do vein anastomosis first. We do the venous anastomosis, put the kidney and put the bulldog
And
in
then
the
it
vein,
is same.
and
That's the same
see
thing, yeah.
that how is
And-
the curvature of length and all those things.
and for the right side donor, you use artery first.
All technique. Unless
No, but
until-
right side vein is a little bit friable, and I mean I would be more cautious
but
for
it
vein
is-
rather
but
than.
it is very easy. Once you have done the arterial anastomosis, you just keep the kidney in the fossa, and you will do very easily. Means I have done things and I have no issue.
Good.
So for sir, if you are using external iliac artery, you will have to clamp that artery for that much long time. You cannot declamp the external iliac artery before you do the
You
vein.
are right, but maximum anastomotic time will be in the range of 25 to 40 minutes. So clamping the 40 minutes artery is not going to hamper by any means to the patient. So I don't see ki there is any problem.
But definitely it's a longer time than usually, yes.
10
If you
minutes
do vein
more.
side.
I mean, as compared to the
15,
vein
20.
first technique, then
Yeah.
have you ever had any vascular complication regarding, I mean, in the lower limb?
Not really, but yes, in one case there was intimal fracture, but that was
That-
not
that-
related
that
to
is
the
not
technique.
related to the-
That was something other, but never any issue.
And atherosclerotic arteries and all, I mean, you will do artery first and
Yes, artery first, and at that time maybe you need an intimal fixation and all those things. But I have always done. But in cases where there is a serious calcification,
We want the
and
cameraman to
intercalated
focus on the anastomotic side, not able to see the
Hello,
anastomosis.
Can somebody focus it? The focus is not good. कहीं से करो ना, इधर लगा दो।
सर के पीछे से वो वाला कैमरा ले लो ना अपना,
अलग से लगा दो।
वो कैमरा सर के पीछे से ले लो।
कैमरे का एंगल ठीक करो.
Anand Kumar sir, have you ever tried artery first technique, sir, or never, sir?
Like suppose there is a multiple vessel complex situation, I have to do 2-3 arteries differently, separately, then I will do the artery first.
Okay, sir.
But in a straightforward case, no.
So he has flipped the kidney on the other side and then doing. So do we usually, you do in the same manner?
Same way.
So you also do the same manner? Okay, you definitely. So we don't, we keep the kidney on one side only and start from inside and then do the other side. Yes. Without flipping the kidney, yeah.
Yeah, we flip the kidney.
Yeah.
Cameraman, please try to focus on the suturing line. We can't see.
Okay.
Okay. So, Dr. Anand, Dr. P.B. Singh is asking what is the length of the needle holder? Is it
and forceps?
And forceps. And are you using a longer kind of a needle holder and forceps?
I don't know what is the length. I don't know. But
it is 35.
With different lengths we have, whatever suits.
We use
Yeah. So you must be using the longer one.
35 centimeters. We usually use 35 centimeters.
On right side we don't keep the kidneys.
Okay.
Right side we just keep it.
Sometimes there is a chance of getting the other wall also if you do this.
That is prevented by diamond-shaped stay sutures, which he had demonstrated.
पर कई बार क्या आता है stay यदि loose हो गया, it may come. So there is a chance of taking the other side also, but
by this technique, it's very, very, very unlikely.
Okay.
We have seen it happens while we are teaching the new resident or fellow to do that, and he has taken deeper bite. And whenever we suspected, we stopped him and then checked it and then corrected it. Otherwise, it usually doesn't happen. Now we flick the kidney again this side, and we also turn the table. Table हमारी तरफ कर दो. Just hold it here.
So the table is also tilted that side.
So
Now the table
turn the table also. Then camera को fix करो ठीक से.
इधर से दिखाओ. Will come that way.
भैया. So उसमें you don't have to change anything. You just keep going.
इसको नहीं रखो.
You do one valve from the inside.
Inside, yeah.
And you come outside.
Now, when we start,
best way is if you can use a laparoscope.
Just check it.
Laparoscope, telescope, and then show the in the depth. You can show whole picture very clearly because from there, hand is coming, this is coming. So if you can use the laparoscopic camera and put the camera there, laparoscope there, the telescope.
Yeah.
And whole anastomosis can be seen very clearly.
Clearly, yeah.
There is very good camera from Designs for Vision. Though the camera costs 10 lakh rupees, if somebody uses a full SD, 4K will cost something around 15 lakh rupees. I mean, everything can be recorded and obviously the display can go to anywhere.
So we usually in all our OTs, 6 OTs, we have that camera with the light. So I think camera, the light overhead probably gives a better vision. So here the camera is not with the light, isn't it? There's a separate camera they are showing it.
But I think the laparoscope is the most economical way of doing it, and also the stable.
But somebody has to keep
hold the camera.
holding on. That's because you cannot remain stable. That is important. I think the overhead on the light camera is the
light camera is the best one
yeah,
for the transmission.
Yeah.
We have the light camera. If you can focus on the light camera, they can see it. उसको वहाँ दिखा दो. Yeah.
Because then we will get the surgeon's view in our camera.
Yeah.
If the light camera is used.
Can you see it now better?
No, it is the same. It is the same.
It's the
They have
same.
not changed
Actually,
it.
your finger
Now
is
it's
coming in.
focusing the camera.
Yeah.
Yeah, now it is better.
Yeah, now it's better. Now you can see the wall. Yeah.
Now this camera is in the light.
So the assistant can keep his fingers a little away from the kidney, a little away, so not near the hilum, so that we can see easily. Yes.
Use the artery on the gauze piece to hold the kidney rather than keeping the finger. Yes, now it is better. Thank you, Dr. Pragnesh.
And there's one more thing I keep teaching everybody, like you should, like once you finish it, you bring that here and do not try to catch the needle with the finger and thumb. Otherwise, you never know, once you'll get some communicable disease and nobody will believe where you have got it.
What suture do you use, Dr. Rajiv? What suture you are using for the vein and artery in your program?
For the most part of my career, I use 6 hours, but for both. But since I stopped using loops, I also started using 5 hours, and I've not had a problem with 5. I use 5-0 proline for artery vein, 5-0 PDS for the ureter.
In the cadaver as well as live donor, both you're same.
So we use usually 5 for vein and 6 for artery. Yeah, that's it.
Now, what we do, we take the 2 vesicular forceps. Show me this vesicle. Give me another forceps. Okay, now, just hold it like that. I think we should have defattened this also. And I will see how it is coming. Now you see, this is coming extra. So I will excise it here, and now I will cut this obliquely so that both.
Like scissor.
So Dr. Anand, don't you put a bulldog on the vein side and just see whether there is a leak or not? No.
Do it in robot, not in this.
Okay.
You can do that. That's not a
Yeah,
bad thing.
we always do it. Yeah.
Now we'll do it. Okay, just show me the suture. Now remember, these 2 knots are at the side. These 2 knots were at the side. Isko udhar ka khiche.
So will you spatulate intra-iliac artery or not, sir?
Yes, I should.
See what I have done. I have
Obliquely cut.
Obliquely. So you can, I think if you appreciate it, it is not cut like that. It's cut because I cannot spatulate this part.
Yeah.
So I will just try to match it.
Okay.
How it is going.
But had this been a single artery then, sir?
Yes, our all anastomosis is spatulated.
Okay. Okay,
I
sir.
have been.
Yeah.
इसको यहाँ पकड़ो ना.
So this is 6-0, right, sir?
Yeah. थ्रेड को इसको एक ऐसे कर लेना
Yeah. So at this time, how do you know that what should be the exact length of the internal? Because he is keeping the kidney out and doing the anastomosis. Okay.
Now I just wanted to show you when we place the suture, इसको थोड़ा कुछ पकड़ ले, ऐसे ऐसे पकड़ ले ना, और इसका फैट को ऊपर कर ले. कितनी बार बोला इस फैट को तो मैं काट ही देता हूँ.
Finally, the position would be different.
क्लिप पकड़ ले.
Like this. So there will be a kink, right? So a little kink.
सीजर दे, इसको बाद में देख लेंगे. सीजर दे. कैसे दिखा? हेड पकड़ो ना उधर. This is coming in our way. I'm just seeing that if I can cut it. I will clip it later.
So can we hold that fat with some mini Babcock or something?
No, I can do that, but at least I just wanted to show you.
Yeah.
See now, I have put this corner suture before tying. I am just seeing now. You can see.
Yes, sir.
They are coming equally. Can you see it?
Yes, it is a perfect match.
Perfect.
So that's how I cut it obliquely, because I cannot cut this one.
Yes, yes.
So, and with experience, I know how much I have to cut, and that suits there. So now, what I will do, there are many ways of doing this also. You can tie only one side and then come to this side. But what I do, I'll tie both the side and then just twist it. Becomes very quick operation. Either or I flip the kidney this side and opposite side I do it from there. Put it there. I'll show you there are many ways of doing it. I've used different techniques in different situations. Suppose there is a early branching in renal artery which is still there. And I will not take anything.
Your voice is not clear.
Looking at. I'm saying, hello, can you hear me now?
Yes, sir.
Yeah, now it is clear.
Unstable
I'm saying
internet.
that there are many ways of doing this arterial anastomosis also, and I use different technique in different ways. Like this is the simplest way. Now you just have to keep it like that. This is very important, so that and I just take the angle.
Sir, what are the precautions you are taking because this is a pantaloon, so that there should not be any leak after and the edges are perfectly secured?
So we have already, when we make a pantaloon, we try to do the anastomosis and angles are secured, but it's no guarantee that it will not bleed. It may still bleed, but most often it will not. And we just have to make sure that one thing is your suture should not go with the other suture, 70 proline, otherwise it will cut through. Needle should not, so we make sure that it should go away from the suture.
So before doing the anastomosis, would you like to just unclamp the artery and let the blood flow and then reclamp it. Usually what we do is, we usually do in that way.
You can do it if you want
Yeah.
to have more
Yeah.
fill and adrenaline flowing. Otherwise,
because
we do it in external iliac artery when the artery is atherosclerosis, that before
Right.
finishing the anastomosis,
Yeah.
we just open the distal end of the external iliac artery,
Yeah.
so that if there is any atheroma or any blood clot or anything is gone there, it
Yeah.
should come out, then flush it again with the
Heparin, yeah, that's right.
heparin, and then reapply the clamp.
Yeah, we usually change the site of the clamp also, a little away, so that it doesn't go on the same site.
So that we do it in, but not in this
Yeah,
situation.
yeah.
See, once I'll remove the clamp, if it is bleeds, it's not that sometimes it bleeds, then there is some gap is left, and we put another stitch while it is bleeding. When you are putting a stitch while it is bleeding, there is advantage. The lumen is distended, and unlikely you will take the opposite end. If you put the clamp and blood flow is not there, then, but if the bleeding is too much, then you may have to put the clamp, because then you can't see, you can't do it. But otherwise, smaller bleeding, we just, while it is bleeding, we just put a extra suture and it becomes all right.
So how many of us are doing in this way, the anastomosis of the artery? So some people do by parachuting also. So
I do it parachuting in a difficult situation when there is another branch very close to the renal artery.
Mhm.
Then I do use parachuting because I'm trying to see the edges before, because here I am pretty sure and that everything is. Now there is a two-way of doing it. One is the opposite, I just do it there, put this suture this side, but then probably you might not see better. Or there is another way is this, I can just bring this one forcibly here, and this will goes up, and you can just see both the edges are again before me. पकड़ो इसको, रबर शॉट लगाओ. Now both the edges are very nicely seen. So I just turned it upside down and just finished this enough. I can flip the kidney that side and then do the posterior side. So, दिख रहा होगा? हाँ, ठीक है. If you want your angle should not bleed, your suture should be going obliquely at the angle. I'll just show you by taking out one by one. Otherwise I could have done in one go. So the suture at the angle has come this way. And now when I'll go back again, it will go this way up.
Yeah.
So what happens, it nicely seals the angle. Placing the suture obliquely, so the angle is nicely sealed.
Huh?
Proline, sir.
Proline. None. Gore-Tex he uses in the robotic.
They are white in color, sir.
White in color, yeah.
This is Prolin 60.
Yeah.
Vortex is very good suture even for open surgery, but it's a cost because some places I have gone
Quite
for
costly.
demonstration after they have given me Vortex to do the anastomosis, and I was quite happy because I was not paying, somebody else was paying. But otherwise it's expensive
Okay.
suture. One Vortex suture costs $30 and this one Prolin suture costs 300 rupees. So 5 cents or something. So there is so much of difference in the cost. But in the robot, loose karo, thoda loose karo.
So this is 13 mm needle, na?
13 mm 60.
So arteries we use 9 mm and for vein we will use 13 mm. Perfuse करें, flush करें.
हाँ, अभी दे रहा है. Flush, loose कर दो. So before you, what we do it, we flush it with the heptaline. That is, it does two things. If there is a leak, you will see, and while last suture will become, you apply while it is nicely distended. Good. We usually remove the arterial clamp first, followed by the venous clamp. Because if you remove the venous clamp first, suddenly venous blood goes into the kidney and then takes some time before that.
So you don't.
So today there is some bleeding from the approximate this pantaloon. We'll see.
Ah, thank you. Thank you. Thank you.
70 suture.
So you don't use warm water at this time?
Hmm?
Warm water over the kidney?
No, we don't put warm water. Actually, this time in AUA conference, there was a very nice paper from Cleveland Clinic. And what they were showing that the cooling the kidney with the cold solution is not a good idea because the kidney is cooled and suddenly you warm blood goes into that. Rather you stop doing that, then by the time you will reperfuse, the kidney temperature will be room temperature, or you start once your venous anastomosis is over or half of the anastomosis is over, you start pouring room temperature water over the kidney.
Exactly.
And that
Yes.
will be more, and they were showing that the kidney function in post-op is better in those kidney, but the difference was very small.
So we also usually do that. We don't use cold water after the venous anastomosis. So it's a room temperature water, and then after the unclamping, we usually put warm water over the kidney.
And what, like, if I am training somebody, the guy is going to take time, and you don't have to say him to hurry up, otherwise he will take more time more. So we at that time we keep cooling the kidney and tell our fellow resident, you also remain cool and just keep doing the operation and we'll see. So that's the ureter. Yeah. So there is some bleeding. We'll just
some
give
bleeding,
some,
yeah.
Yes, we'll give some time for the nature to take care of it. After that, we will go there. So most of the bleeding stops, except main bleeding will stay there. Meanwhile, I will do the hemostasis of this hilar tissue. Just hold it here. Clip. So in robotic surgery, we take all effort to avoid this to happen. But in open surgery, even if it happens, that's not a big deal. You can always take care of it. Even in robotic, then we use the bipolar to go there and do it. Because वो screw पर लग गया. और डालो यहाँ पे कुछ भी नहीं.
गज भी दो साथ में.
70 ले लो. You might have to put one stitch. मेरा क्लिप एप्लीकेटर खराब हो रहा है.
So how many of us use warm water here? No, none of over you. Yeah.
Warm means, I mean, room temperature or?
No, warm.
So how?
Warm is
lukewarm.
Lukewarm. But it's not room temperature. It's a slightly warm water.
Around 37, you mean?
Yeah, maybe.
37.
But it is not hot. It's warm. That's it. So if it is hot, we usually add cold water so that to make it warm. So did we see the urine coming out? Yes.
Show you.
Okay, let's see the ureter. Yeah. Because usually within 1-2 minutes it should come out.
In my previous robotic case, it came out immediately.
Yeah, usually it should.
So,
yeah.
If I would have been doing this robotic, everybody would have said this is because of the robot, urine is not coming. But even in open surgery, it takes some time to come the urine. So, and it's quite variable. It's not that always you get.
Yeah, that's true. That's true.
We had urine output after 2-3 hours also.
So in this case, are we seeing the urine coming out?
Not yet.
Not yet. Okay.
The CVP kitna hai? What is the CVP BP? The first thing you should ask the anesthetist to fill up the patient.
Sir, CVP बढ़ाओ.
And blood pressure. If the patient blood pressure.
So
yes.
So usually, what blood pressure you keep?
Now the urine started coming.
Okay.
Mean arterial pressure of 100. And CVP around 14, 15.
Something.
Raju sir, do you actually use CVPs in your transplant patient nowadays?
Yes.
No.
The CVP catheter is routine in our program, but I'll tell you, if the patient blood pressure is okay and patient is making good urine, you don't even bother CVP, because at that time sometimes CVP is very low, but doesn't matter. The urine output is good, BP is good, so you keep replacing the fluid. And what we do, like if the urine output is less than 500, we replace it whatever is coming. Between 5 and 1000 we give 80%, and over, if it is coming over 1000 then we just go to 70%. So because we should not keep replacing, otherwise there will be
Overload,
lot of-
yeah.
A lot of
now I am
operators-
going to check where it was bleeding, put it here and give me the epsilon and the suture. You can see there is a one bleeding here.
Yes,
Just
but
hold it here.
Yes, sir.
So our patient population is very different. So they have poor cardiopulmonary reserve, a lot of them, and we use thymo for induction. We use 4.5 milligrams per kilogram in 3 divided doses. The first dose is given in the OR with induction. A lot of them will have hypotension, etc. We give about 2 liters at least by the time the arterial anastomosis is complete. So it's about 1.5 hours from induction to when the arterial anastomosis is complete. So we tell the anesthesiologist in the first 90 minutes give 2 liters of fluids. And after, just before unclamping, I use 80 of Lasix, just to help. But not all our, we primarily do deceased donor kidneys. So our kidneys don't look like this initially after reperfusion. They may look, more bluish. So then we do other maneuvers. We say like, I might clamp the external iliac below the renal for 3 to 4 minutes to increase flow. I'll probably ask the anesthesiologist to give some more fluid. We rarely need Dopplers because if you see good capsular bleeding, that's a sign that the perfusion is there. So, and if your arterial, I really go by the if you have a really nice thrill at your anastomosis, then I just don't bother. Whatever the kidney is looking like, I know that a kidney is getting blood flow. It's just the cold time, because our cold times are long. We transplant kidneys with cold times up to 40 plus hours. So, we have different patient population. Most of the kidneys will not, so our DGF rate is very high. It's in excess of 50%. So most of the kidneys will not make urine in the first week.
Because you have mostly DCDs.
You are talking about deceased donors.
Deceased donors.
Deceased donor, yeah.
But 60% of those deceased donors are DCDs.
So what about the living donors?
Living donors, they usually work right away. We don't have any problems with them.
So why this thought? Because we have 2 nephro units. So one nephrology unit will not use CVPs. They'll use CV only if there is ATGs to be given. If there is no induction, they will not use a CVP. And there is a lot of literature from West Side which says that CVP actually does not have any important role in transplant.
Yeah, it doesn't. I mean, we just look at the maps.
Yeah.
We don't have the luxury of maps above 100 in most patients. If it is above 60, I'm happy.
Okay.
No, but our
yes,
our population is
so
actually
most of
they
the
are
kidneys,
accustomed to higher
I would say 75% of the kidneys
So 60
are
maybe
placed
they
on the
won't
hypothermic
diuretic.
machine perfusion pump. All DCDs, 100% of DCDs. If the in the rare instance that the donor was at our hospital and we got the kidney, and the cold time is going to be small, then I don't bother placing the kidney on pump.
And do you use Lasix intraoperative or I mean
As I
after?
said, so just before reperfusion, I give 80 of Lasix.
So is it, sir, evidence proven giving Lasix, or is it just an...
It's not evidence proven, but it works. So I actually, for DGF kidneys,
mannitol
we
is
do a
given,
lot
yes.
of things which may sound counterintuitive, like we give fluids, we give diuretics. DGF kidneys are managed in a very different way. We don't dialyze them, as per schedule. We'll wait to see what the function is like. most of them will require dialysis for up to 30 days, but not on a regular basis. So once in 4 days, once in 3 days. So we monitor them very, very closely. And usually, if we are seeing some response with Lasix, we will continue, otherwise we'll stop. Then we just wait for the ATN to resolve. And it does, ATN always resolves. So if your judgment has been good, you've taken a kidney that has decent biopsy and good flow, good resistance on the pump, ATN in 100% of the patients usually resolves. Sometimes it may take longer. So my longest one has been about 2.5 months of ATN, and after that the patient started making urine, and then did very well after that.
When your kidneys are looking bluish and not diureting, and so do you use intraoperative Doppler?
So I don't always use intraoperative Doppler, only if I'm worried about my anastomosis. So if there is flow to the DGF kidney, you will still see capsular bleed. So capsular bleed is a good indication that there is flow. And thrill at the anastomosis. If you have a pulse at the anastomosis, then I'm a little bit worried because there is some the renal vascular resistance is high. That's why you have that pulse. If you have a good thrill, you don't have to worry. If you only have a pulse and the kidney is like totally blue, it doesn't even get a little better when you clamp the external iliac distally to improve the flow. In those cases, I will use Doppler. And if I have good Doppler signal throughout the parenchyma, even if it is looking blue, I will still close and come out. I won't worry about it because it's ATN. As long as you have flow to the kidney, it'll work.
So patience is the key in this situation then.
Lot of patience.
Lot of patience.
So I think the hemostasis is achieved.
So So I think the diuresis is there, and we would like to close this session. So, and we'll proceed to the next session.
So are you happy to allow tacrolimus to continue, or since you have already done an ATG induction, and wait for the creatinine to start coming before introducing TAC?
Thank you, Dr. Pankaj Gaur sir, Dr. Shivam Pradyarsi sir, and Dr. Abhijit Pavel sir.
The introduction of tacrolimus. We introduced tacrolimus day 4, 5. We don't really go for therapeutic levels. We'll keep it at a very low dose because with thymo you have some room to play with. We do biopsy these kidneys at 14 days because you can have rejection as the cause of ATN, and it's not just the DGF. So you have to rule out rejection. If you rule out rejection, then you can just wait. Nowadays we have cell-free DNA, so we will do donor-derived cell-free DNA at 14 days. And if that is very high, then we will do a biopsy. So now we don't even do a regular biopsy on day 14 for DGF kidneys. So, no. So thymo will completely deplete your entire T cell repertoire, and you only start seeing T cells come back or lymphocytes repopulate not even in the first 14 days. So the chances that it'll happen 14 days is late is that's been our practice.
Regarding monitoring with CVP, CVP, the patient is having MR or pulmonary hypertension, it can be fallaciously high. So one of the best ways is just to check with an IVC diameter. If IVC diameter is around about 1.5 centimeters, everything is okay. You don't need to push more. Another aspect is about challenge with Lasix. If the kidney is responsive with Lasix, everything is okay. So it is one of our tests basically to check everything is okay.
And that's why we use the Lasix. And another comment about the tacrolimus. So a lot of programs in US have started using belatacept induction So they don't use tacrolimus for these DGF kidneys.
See, if you have done a good anastomosis and output, you are not able to see the output. So there are 2-3 checkpoints at our center. Because many times we have seen that if dialysis is not good, the patient is also acidotic. So we will check the acidosis is there or not, otherwise we will give soda bicarb because there is peripheral pooling, and sometimes there will be not intravascular good volume. And then if there is a need, we will see the IVC diameter and you see that how much volume you have to give more. And sometimes these patients are severely hypoalbuminic also. So the albumin is 1.8, 1.6. So there you have to give some colloid also. So keep the intravascular volume good. So these are the 2-3 checkpoints on the medical front, which we always do if there is no output.
There's always that discussion between the surgeon and the nephrologist about dialyzing these patients with DGF. The surgeon problem is if they take a lot of fluid off on dialysis, you can have renal vein thrombosis in those patients. So you have to keep a very close contact with what is being done on dialysis. We normally don't have any fluid removal of clear requirements that do not remove any fluid without discussing with the surgeon first. And another thing is the DGF kidneys, they recover better in a non-uremic environment. So don't be afraid of dialyzing these patients. I prefer dialysis without fluid removal because they recover better in a non-uremic environment.
So we'd like to move on to the last and final session of this day. For that next session, I'd like to call Dr. Ajay Oswal, Dr. Amit Devra, and Dr. Rajiv Sharma to please chair the session on the stage, please.
So now we are going to start a session, and the first talk is by Dr. Abhijit Patel. He will be speaking on CKD with depleted venous state management options.
Hello. So good evening everybody. I would like to thank Anand Kumar sir and his team for giving me this opportunity. After this whole day of kidney transplant, let's have some focus for vascular access. Though vascular access may seem a meager surgery to us, but it is actually a lifeline for any CKD patients. And for those patients who are not fit for transplant or don't have an access for transplant for them, as the duration of dialysis progresses, the vessels gets hampered and you are in a state where you have one fistula failed, second fistula failed, and now what do we do? So basically this talk is to give you some guidelines about how do you do it. So as everybody knows, AV fistula is anastomosing artery with vein, so that your vein is arterialized, which gives an access for inflow and outflow for machine. What is an ideal fistula is easy to construct and maintain, gives good adequate flow for dialysis, easy to cannulate, allow rotation of cannulation site, should last long, and should be comfortable for the patient, and should be free of complications. There is something known as rule of 6 in maturation of fistula. This is what you should achieve at the end of fistula is you should have a flow which is greater than 600 mils per minute, and the vein should be more than 6 mm size, should not be deeper than 6 mm from the skin, and generally it takes 4 to 6 weeks for the fistulas to mature, and you require a 6 centimeter straight segment of vein for cannulation for dialysis. Now this is an anatomy that everybody should understand for further access that you have to understand. So this talk is if RC is failed, BC is failed, what to do next. So this talk is focused on that. So for that we have to understand, so there is the cephalic system in the lateral aspects, cephalic system of the forearm on the lateral aspect, basilic vein on the medial aspect, again a basilic vein of the forearm and middle aspect, and there's a median cubital vein which connects them. So this is about the upper limb venous anatomy. So the first fistula that anybody does is a distal RC fistula, then we do a proximal, which is brachiocephalic fistula, and then you can have something known as brachiobasilic transposition. So this is how the algorithm goes, that if RC or BC fails, what are the other options? You can still do a proximal RC fistula, you can do a forearm transposition, you can do a brachiobasilic transposition, or again you can have a autologous graft or a synthetic graft. So autologous graft could be a saphenous vein, or you could have a prosthetic synthetic grafts, and then finally if nothing is used, then you can go for a lower limb graft or a fistula. Now these are some of my learnings that I learned from NHS Sheffield Hospital when I was in UK. So coming on to the first index case is a 44-year-old hypertensive hypothyroid female. She's CKD5 for 5 years on maintenance hemodialysis, and now this is her history. Left RC fistula done in 2020, work for 2 years. Left BBT done in 2022, work for 1.5 years. Again right BBT done 2023, work for 11 months, stopped working 15 days ago till the patient came to us. Okay, these were all done outside. Now once what you will think, both BBTs have been done, that means my upper limbs are not usable. So the moral of the story is that you will have to still evaluate the patient. Is there any chance for any fistula in the upper limb? So the basic evaluation, physical examination are normal. In such complex cases, you should always do an arteriovenous mapping. So this was the mapping of that female. This was the basilic vein which was transplanted completely thrombus. But if you see, the previous RC fistula had actually had a very good cephalic vein present over there, and it was around a 2 mm, and it was around 1.6 mm below the skin. So the plan was done to do a right BC fistula. So you can still do a right BC fistula after right BBT, as suppose that everybody thinks after right BBT you cannot do a right BC. You have a separate cephalic system which can still drain to it. But mind you, when you are doing complex cases like this, always rule out central venous stenosis. If a fistula on a certain limb fails again and again, you don't consider that it is a technical failure by the previous surgeon. There could be central venous stenosis which is causing again and again the fistula to thrombose. So in such cases, always rule out central venous stenosis, and this was how, when we had dissected, this was the picture. So this was the basilic vein which was going over here, and it was actually end over here. So we tied it off. This is the cephalic system, and this was the brachial artery dividing into a radial and ulnar artery. So we did a brachiocephalic fistula over here, and the patient had a very good thrill and was discharged in a stable condition. Now the next aspect what do you have is, if your RC BC have failed, then you can do something known as forearm transposition. So forearm transposition, this is your basilic vein which is over here. So if you try to do an anastomosis over here, the patient cannot sit and do a dialysis like this. So you'll have to transpose this vein over to a forearm. So this is how, if we have to show you, so this is the basilic vein which is present, and this is the intended site. The black one that you see, that is the intended site of its path. Now this you have to dissect the basilic vein in complete toto, but it can be done in two ways. You can take a single long incision. It is slightly easier to do, but it is slightly morbid for the patient. As opposed to this, you can take small incision, 3 small incision, slightly difficult for you, taxing for you, but it is obviously beneficial to the patient. So here what you do is, you take an incision, try to dissect off this vein, take care of each and small branch which is present, because once you tunnel this and you do an anastomosis, even a small leak could be disastrous. Now you keep on dissecting this vein. Now this is your first incision which is present. Now you dissect it off. Now once you have done this, what you do is you tie it off distally, and then you check the patency of this vein. And now these are the 3 incisions that you can see. Keep some skin island in between, and now what you do is again follow the same steps and try to dissect off this vein till you reach the proximal aspect of your swing. The swing would be somewhere around the elbow. Again follow the same principle, take care of each and small vein, and now when you reach this place, whenever in the skin island, try to make sure that there are no branches and do something like a shoe shine. Okay. Now if the vein can be moved very easily, that means there are no branches, and just pull it out and proceed proximally. Now this is your last skin incision that you have taken. Now again dissect off the vein over here, and once you dissect this off this vein, this is how you will have a straight segment of the vein. Now what is more important, so this vein was over here. Now this is our intended path for if you do an anastomosis over here, this will get arterialized and then you can do a proper working fistula. What is very important is that one, you have to look the lie, there should not be twist during the tunnel. Second, there should not be any leak. So now what I have done is I have applied a bulldog over here. This is a hydrodistension test. It tells me the leak and also it distends the vein. So could you see there is some small leak over there. So I'll take care of this small leak at this moment, so that once I tunnel there is no bleeding inside. And once I tunnel and do an anastomosis, there will be arterial flow in that vein and it will form a very big hematoma. Now I am using a methylene blue to mark the orientation of the vein, so that once I pass the vein through my tunnel, there is no twisting of this vein. Okay. Now this is the radial artery which is being dissected. These are the venae committents, and you dissect of the artery as you do in RC fistula. And then what do we do is, I generally apply a bulldog just distal to the artery so that it hydro-distance that artery. And during that moment, what I'll do is, I'll try to tunnel this area. So what I'm using, take the largest or the longest artery forceps that you have in your OR, and you try to make a tunnel. So you have to make at least an inch of the tunnel, so that it has a proper space for this vein to come out. Now I am progressing proximally till I come from the most proximal incision. Now once I have made a tunnel, I keep that artery over there. I tunnel the vein through this path. I am making sure that the lie is maintained. Now again I have to check whether there is any kink or any twist of this vein. What I'll do is, I'll just pass some hep saline through this, and I'll again see the thrill. So once I push some saline, I should feel that thrill on my proximal aspect. That means that it is quite intact. Also a point to be noted over is that there should not be kink during the swing of that vein. And once you have done this, this is an RC fistula, general normal RC fistula that everybody does. So anastomosis is as a routine anastomosis that everybody does. So I'll just skip the part of the anastomosis because it would be same in each and every case. So I'll focus on the technique and the decision making aspects. So once this is done, you just remove it off and then you wait for some time. That is how your forearm transposition is done. Now your after 4 to 6 weeks, what will happen? You will have a straight cephalic vein, basilic vein which is present in your forearm, ready for fistula cannulation. Now the second aspect is brachiobasilic transposition. It is done in the arm. So now this video, this can be done in two ways. One is that you do a single stage where you dissect it of the basilic vein, transport it and do an anastomosis with the brachial artery, or you do a stage 1 BBT. Stage 1 BBT means you take a small incision, as you do a BC fistula, anastomose your basilic vein with your brachial vein, brachial artery, and allow it to mature. Proponents of stage BBT say that since it is a morbid operation, let me be sure that this vein will get arterialized, and then I am quite sure that going ahead with the morbid surgery like stage 2 BBT would be worthwhile. Okay, so the video that I am showing is actually of stage 2 BBT, but you can still do a stage 1 BBT, it will be the same. So this is the skin marking. I would just focus over here. So this is the basilic vein. This is the basilic vein which is present. These are my intended skin incision. So this would be this way because I have to dissect the artery over here and the origin of the vein. Then this is the skin island which would be intact. Again I will take an incision over here and over here. So I will dissect off this basilic vein over here and then make a tunnel so that my basilic vein now will get transposed through this path and then is again anastomosed through my brachial artery. Okay. So now this is the video that we'll see. So this is the first skin incision that you see. Now this is actually a stage 2 BBT. So now basilic vein is already anastomosed to your brachial artery. So now it would be a very thick arterialized vein. also a proponent of this stage BBT, they say that they are quite comfortable transposing this arterialized vein because there will be very less chances of kinking or twisting of this vein in the tunnel. Now I just tie it off over here, take an incision, and then now what happens is that once it is arterialized, there are a lot of peri-vein adhesions to this vein. Now what you do is whenever you take dissect this off, keep some amount of fat with the vein. Don't try to bear off this vein. Okay, and now you proceed it same way as you saw in that forearm transposition, and during that island you can use a right angle and keep on dissecting it off. A single incision is actually very easy to do, but it is very morbid, gives a big incision to the patient. Sorry. Okay, now this is how we just keep on continuing. Continue to dissect off this vein. This is the final skin incision. Again deepen it and sequentially try to bring off the vein through a proximal incision. And now once this is done, sorry. Okay. Now once it is done through the proximal aspect, now what you do is you dissect off the brachial artery. You dissect off the brachial artery and pass vascular slings through it. Now your brachial artery is ready. Now comes your aspect of again the same thing that you have to do. You have to check whether there is leak or not. Very less chances you will have a leak over this time. Properly mark the orientation, and you can use, so there are various ways of tunneling. One is this way where you use a long artery, or you have this Romovac drain placers. So you have this Romovac drain introducer. You can even use this Romovac drain introducer to make a tunnel. And obviously you have a good tunnelers. If you see the Western world, they have a very good tunnel system, but these tunnels cost you. So these are some desi jugaads for tunnels. And then finally you have passed your vein through this new tunnel, and then again you do an anastomosis as you would do any anastomosis. And then final you do an anastomosis. This is a parachute technique that you have used, and now you see this is your basilic vein which is transposed, and this is the final picture. You have just three small incision, a drain. You can even drain is optional. If you have done a proper good hemostasis, you can even avoid the drain. Finally what you will have, three small incision and a very good vein, as you can see over here. It's almost ready to use. So this was the basilic transposition. Now sir, what happens is that since your fistulas are not working, the nephrologist will put central lines. Now with long duration of the central lines, you will have a patient where you have a bilateral central venous stenosis. Now what do? Now instead of going to your lower limb, what you can do is something known as hero graft. Now what is hero graft? So hero graft has actually two components. So one is a percutaneous component. So as you see, this is all vein is completely lost. So this is central vein is lost. So there are two aspects of hero graft. Is the percutaneous component when it goes into the central vein, and this is your graft which is anastomosed to your brachial artery, and there is a small connector which connects your the percutaneous arm and your graft. And what it helps is that this graft is readily used for your, it is immediately available for your dialysis. Now then what you can have, you can have a synthetic graft. It could be a straight graft or a loop graft. Okay, so I'll just go ahead and just show you a video of graft. So the graft can be ePTFE or a Dacron graft. So the video that I will show you is of a PTFE graft. So these are the components of it. So what is 4 to 6 is that, so you will have an arterial end which is 4 mm and you will have a venous end which is 6 mm. Why do you have is because if you have a 6 mm graft, there will be a lot of arterial blood steal. So that is why it is 4-6, and the length could be 45 to 60 centimeter based on what you require. So this is again a lady which has got multiple arterial access failures, and now we have to do a graft. So now in this instance what we have decided is we decided to give an arterial inflow from the radial artery, because it was quite around 3 mm of radial artery, and the outflow was somewhere over here which we could have a basilic vein for an outflow. We are ruled out a central venous stenosis in this patient, and now you can see the graft which we are showing. So this is the radial artery which is dissected as you would normally dissect. Then you come for the this is the arterial inflow to the graft. Now you come, you prepare the venous outflow to this graft. So you take an incision just below the elbow. You prepare the vein. So this is the vein which is present. Mind you, whenever you are having a graft, you should have a very good at least a 3 mm of vein so that it has enough space for it to go. Now this is the intended part of the graft. Okay, so the intended part of the graft is such a way. Now this was I am telling is that you can have a Romoac drain introducer. This is a Romoac drain introducer which we throw away. So this you can use to tunnel through it. Now once you tunnel through it, what you have to do is it will come only midway because it's quite a long segment. So it will come in midway, and then you pass this through this, and once you have done through this, so this is that avatar graft that I showed. Now this is the graft which you could see, and then you tie it off over here and pass the graft below the skin, and your graft will come over here, again pass through this so that you come to the radial artery. Now once you have come to the radial artery, this is the 4 mm aspect of it. You have to anastomose it to the radial artery. Mind you, this graft, so when you do an any fistula, your artery or vein will actually contract and cause hemostasis. But this graft don't contract, so you have to do a very meticulous anastomosis so that there is a good hemostasis. So you do an arterial and inflow anastomosis with the graft, and similarly, once this is you have done, what you do is that you come to the venous side of it. So once you have come to the venous side of it, again use a hep saline. So there are two most important things that you have to take care doing a graft is infection and thrombosis. So what you have to do is at every step use lot of betadine to keep that area clean, and second, keep on using lot of heparin saline so there is not thrombus. And so this is the venous outflow that you do an anastomose, and then once you do the anastomosis, this is the final picture that you would see over here. And so this is what a final picture would look: arterial inflow, venous outflow, and this was the bit point where, so this is the graft present over here. Now once this is done, what option do you have finally? If nothing in the upper limb works, is then you have a lower limb. You can either use a fistula or a graft. For fistula, what you can do is you can use a femoral vein or a saphenous vein that you can use, or you can use a graft which is available. So if for want of time, if you agree, I'll show the lower limb fistula. Or okay, so I'll just skip and I'll show you just the video of the lower limb fistula. Generally not commonly done, but this is a video of a saphenous vein lower limb fistula. So what it actually does is that, so now you understand this is the groin and here is your knee. Okay, now you see the surface marking. So this is your intended incision, this is your saphenous vein. Okay, now this is a saphenous vein, this is your intended marking where your saphenous vein would be transposed. Okay, now as you see, you take an incision, you deepen it, and as you deepen you can see the saphenous vein. Okay, so I'll just show you in a minute or so. You dissect off this saphenous vein completely. Again, all the principles remain the same. You have to take care so that all the branches are ligated. Now what we do is we take cotton gauze or anything that you have, cotton tape, any sort of thing, and you make an circular area. So it has to be just below the skin. Okay, now you palpate the femoral artery, dissect off the femoral artery. Okay, this is the femoral artery which is present. Now again this is your intended area. So you have taken two small incision and you have 3 cotton tape to pass your saphenous vein. And now once this is done, your saphenous vein is again checked by the same principle by hydrodistension, and you take small repair if you have to do. And now once this is done, what you will do is you will actually transpose this graft from this area, it will come to this area so that you anastomose with your femoral artery. Now as you see, it is passed everywhere sequentially from the proximal aspect to the distal aspect. Okay, now once it has come over here, now you will do an anastomosis with your femoral artery. What is important, why this muscle is being dissected, is so that you don't have acute kink at your anastomosis area. And now once this is done, this is normal anastomosis as you do with any fistula. And now once it is done, you see, so this is a saphenous vein which is the outflow. This is the area where you will actually do a dialysis, and here is your arterial inflow from your femoral artery. So this is how you can actually, if your RCBCs are failed, you can do a forearm transposition, you can do a basilic vein transposition, you can do a hero graft, you can do a forearm graft, arm graft, or you can do a lower limb fistula or graft. So these are the options or gamut that you have if your primary fistulas have failed. Thank you.
Yeah, can we connect with the OR? There is final message after the transplant. On.
Meanwhile, can we?
So, Dr. Abhijit, why don't you come up here? We'll take some questions.
So, one question that since these are the very difficult patients, so what measure you take in the post-operative regarding antiplatelet or any other precaution or during dialysis so that further thrombosis can be
So sir,
avoided?
if fistulas have been created, then obviously nothing much has to be done. Most important thing in failed fistulas, it is my earnest request that you always rule out central venous stenosis in this patient, and if it is graft, then two things that you have to be aware of is the infection, and second is the recurrent thrombus which can be done. So if there is thrombus in the graft, you can go in number of times, just declot it, but you have to give hypernize the patient, and then you have to start antiplatelets to this patient.
So, do you do any hypercoagulable workup to find out if they have propensity for clotting?
So if a patient comes with recurrent thrombus formation and there is no central venous stenosis, then in that case we
in your first patient that
yeah.
you showed, there was recurrent thrombosis, all the fistulas clotted, there was no central stenosis. So did you do a hypercoagulable workup?
So yes, in that case we did a hypercoagulable state and it was not there. No, not there.
And another one very quickly. So do you have you started using wavelength, the endo AVF or not
No,
yet?
no sir, not yet.
So just everything is open.
Yeah.
2 points to make here, Abhijit. During tunneling, I mean, it is supposed to be the easiest part of the procedure. But during tunneling, one has to be very sure that it should not be very superficial. So there should be some amount of subcutaneous fat should be there.
Yes.
Because the place where it is very superficial, people used to prick there, and suddenly after the dialysis is over, it is very difficult to control for hemostasis. Second thing is, while marking the vein, I would rather prefer to mark before cutting it. I mean, I'll mark with a pen rather than taking it out and then marking it.
Which where sir?
During transposition of a vein, when you take out the vein and you keep on marking the vein with the methylene blue, I would rather mark it before disconnecting it with a pen or with a methylene blue.
No sir, it is marked on the vein.
Yes, on the vein before disconnecting from, suppose you are taking out a basilic.
But till your vein is completely in front of you, you cannot just mark it. It has to come out.
We mark it. I mean, suppose this is a basically this is a basilic vein coming out.
Okay.
I mark it over here and then take it out. It's just a.
So for the first thing, what I always tell my resident is, you have always been taught of raising the fraps during MRM. So what we have been taught is to keep an adequate subcutaneous fat so that there is no skin necrosis. The same principle you have to use while tunneling.
So I'm going to interrupt. So I think we are supposed to be connecting to the OR.
Okay, thank you, sir.
Yeah, thank you.
They have asked for connection. So,
Hello.
Dr. Pragnesh.
Sir, good evening.
Good evening.
We have asked because Dr. Anand wants to show you that how to put a kidney by putting a bowel below it, but it is too late now.
How
We
to
are
keep?
closing it.
Can you just explain the thing what sir wanted to demonstrate?
Sir wants to tell that you can keep the peritoneum and bowel below the kidney. You can just slide the peritoneum and bowel below the kidney, so that kidney will remain like this in an anatomical position.
Okay. So do you fix some peritoneum with the lateral wall?
No, not at all.
Okay. Okay. So thank you very much for a very nice demonstration of transplantation. And we proceed with our session. So
Sure,
should we go for the second talk? Yeah,
Dr. Nitin Daya.
Dr. Nitin Daya, he will be talking about interpreting positive cross match.
Good evening, everyone. I don't have a lot of videos for you. At the outset, I would like to thank Dr. Anand Kumar and team to invite me to share my experience in transplant immunology. It's a complex thing. I don't have any video, but I'll try it to be an interactive session so that we can learn from each other. So this is how my talk will go about. It will start with the basic immunity for the newer residents, then CDC cross-match, flow cytometric cross-match. We'll discuss about something about donor-specific antibody, newer tests which are there in market, and then we can discuss about interpretation of all the tests together. So we'll start with the this slide. So none of us would like to see any of our patient to have this kind of kidney on the table, and in the laboratory will not like to see the slides like this. So this is the reason why we want to do all the transplant immunology test and to check the patient status, immunological status before we transplant the kidney. So we'll start with basic immunity. We know there are two types of immunity, adaptive immunity and innate immunity, and within adaptive immunity we need to know what kind of immunity is needed. Another MSC molecule genes is present on chromosome 6 and it contains class 1 and class 2 we know, and then there is class 3 which encodes for complement system. When we talk about class 1 antibodies, antigens, they comprise of A, B and C, and they are present on all the nucleated cells, whether T cell, B cell or any other body cell. B cell, HLA-B is most polymorphic amongst them, followed by A and then C. When we talk about class 2, only B lymphocytes are having it, T lymphocytes are not having the class 2 antibodies, and amongst them HLA-DR is the most immunogenic antigen. Then we have complement system which forms the MSC, which plays important contribution towards hyperacute rejection. When we talk about the HLA antigen structure, if you see class 1, there is only alpha chain. That's why it is only one chain which we are talking about. But when we talk about class 2, it is a combination of alpha 1 and beta 1, where where the epitopes are there and antibodies attached. So hence they always come in chains. When we talk about HLA antigen, it is preferred that we do the typing at least in intermediate level up to 2 second field. Is preferred if we do complete typing. Antibody structure, we should know there is a constant region, then there is a variable region, where in variable region the antigen is attached, and within antigen there can be multiple epitopes, and these epitope sharing makes this transplant immunology more complex. There are 5 types of antibody, but we'll focus upon IgG and IgM. Why? Because these are the 2 antibodies which can fix complement. I'll just skip this. There are multiple ways by which antigen is disposed of, and one important pathway is through complement fixation, where MSC complex is formed, and once this pore is formed, the cell undergoes death. And this is the major contributor towards hyperacute rejection. There are 2 types of immune response. One is primary immune response. Whenever a person is exposed to some antigen, there is a level of antibody which is formed. But whenever that antigen is exposed in second hit or third hit, there can be amnestic response, and the response of antibody preparation formation is much higher in that case. So this response is mainly contributed because of memory B cells. We have a concept of memory B cell, but we should know that even we have memory T cells, and both of them is difficult to remove from our body. We should know about pre-zoning and prozone phenomena, where when there is a mismatch of antigen and antibody, your test can become weak or negative. There are two types of tests in transplant immunology. One is cell-based assay, one is CDC, in cell-based assays, it is CDC cross-match and flow cytometric cross-match, which we'll be discussing in details. And then we have solid phase assays, which can be done by ELISA or Illuminix. The importance of cell-based assays is that all the antigens which are there in the body are covered on these cells, right? At the same time, solid phase assays, they have good sensitivity, but then it has a limitation that all the antigens are not coated in these beads or ELISA plates. So we'll start with the CDC cross-match. We all know who is he. He is Paul Terasaki, and in 1964, he introduced the CDC cross-match, and it will be a crime if I do not mention this article, which is still a gold standard for all the transplant immunology lab. The protocol which he set in 1969 when he published this article is still followed in the same manner. All we need for CDC cross-match is Terasaki plate and an inverted phase contrast microscope, along with few reagents which can be procured easily. And then what we do is we incubate the donor lymphocytes with recipient serum, and then we add complement and we see the cell death. And we categorize these test results from either we can have percentage positivity or we can give the scoring system. So interpreting CDC cross-match is very simple. If both are negative, that means there is no significant DSA, or very low titer DSA is there, or non-complement fixing antibody is there. If both are positive, that the chances of HLA antibody is high, then there can be non-HLA antibody, there can be auto antibodies, IgM antibodies, and recent treatment with thymoglobin or alemtuzumab. If T cell is negative and only B cell is positive, it could be if in case it is the patient is having HLA class 2 antibody, which is present only on B cells, or low titer HLA class 1 antibodies. The B cell is positive because the concentration of HLA class 1 is more on B cells as compared to T cell, so T cell can be negative. And in case T cell is positive and B cell is negative, so we think about non-HLA antibody. This is pretty simple. Now there are a lot of things, multiple manual steps in CDC cross-match. Hence there are plenty of reasons for false positive and false negative results. And hence the advantages of this test is less as compared to the limitations, right? We need fresh viable donor lymphocytes. There is low sensitivity, low specificity. Non-complement fixing antibodies cannot be detected, and it cannot differentiate between HLA and non-HLA antibodies. Hence, we needed a better technique, and this is why we want a flow cytometric cross-match to be done in all the cases. So it is more sensitive antibody detection assay, detects donor reactive antibodies independent of complement fixation too. It is easier to separate T and B cell in this assay. Standardization is possible, and it brings out more objectivity and reduces the turnaround time of the assays. So again, flow cross-match, the principle is same. We take the donor lymphocyte, we incubate with recipient serum, we add the IgG label, fluorescent label IgG antibody, and what we check is how much shift is there in mean channel shift. We can easily separate out T cells and B cells. The blue one are T cells which are positive for CD3. The green one are B cells, right? And when this is a negative cross match. In positive cross match, you will see the normal cells are there and there is a shift towards right, right? More the shift, more the positivity, right? We know that the antibody level is high in these cases. And we can easily interpret flow cytometric cross match because it brings out some objectivity in the analysis. So there are a lot of advantages. It detects antibodies specific towards the donor because these antibodies which have been detected are present on the donor lymphocytes. It has higher sensitivity and specificity than CDC cross match. It detects only IgG. IgM antibodies can be negated in this and does not depend upon complement activity. So non-complement fixing antibodies can also be detected and it's easier to standardize the panel. The limitation is again we need fresh donor lymphocytes. We need donor to be present for the sample. It is lesser sensitive as compared to DSA, but it can, and also it cannot differentiate between HLA and non-HLA antibodies. So this is how we interpret CDC cross-match and flow cross-match together. If T cell and B cell of CDC cross-match and flow cross-match both are positive, the possibility of anti-class 1 antibody is there, right? Along with class 2 antibody may be present in these cases, and there is a high risk of hyperacute rejection and do not transplant these cases. Next is T cell is positive in both the cases, both the assays, but B cell is negative. Probably it is not class 1 antibodies, and possibly T cell specific antigen can be there. It needs further testing. You can go for non-HLA antibody testing. That will give you more answer than the HLA DSA. Next is if only B cell is positive, if only B cell is positive in CDC cross match and T and B cell both are positive on flow, that means it can have low titer class 1 antibody but can have also anti-class 2 antibody. Can cause hyperacute rejection if anti-class 2 antibody is in higher concentration, and there is increased risk of accelerated acute and acute rejection. If CDC cross match is completely negative and flow cross match is positive, again low titer anti-HLA antibody can be seen, and again you have to refer to above explanation. When only B cell is positive on CDC and flows cross match, the possibility of anti-class 2 antibody is there, or a very low titer anti-class 1 antibody can be there, and there are chances of hyperacute rejection. When CDC cross match is showing positive B cell or positive or negative T cell along with flows cross match completely negative, it can be because of IgM antibody. If a lab is not doing the DTT, if lab is not using DTT for detection of antibody through CDC cross match, and you can repeat after some time to see if there is from IgM to IgG subclass switching. If completely if it is both the CDC and flow cytometric cross match is negative, that means there is no detectable MSC and there is low risk, there is a low risk transplant. Still, even if your CDC cross match and flow is negative, it is saying no detectable anti-MSC antibody. There can be donor specific antibody, but they are in such a low titer that your CDC cross match and flow cytometric cross match are not detecting it. Now further, what we can do after your CDC cross match is coming positive. So we have an option that we can do donor specific antibodies. And why we need to do donor specific antibody? Because there are multiple reasons for cellular rejection, but if you go through literature, you will find that de novo DSAs or preformed DSAs have a bad clinical outcome as compared to patients who are not having DSA. So what we do in single antigen bead assay is we take the cells we have beads which are coated by the antigens, different antigens, and we add on serum of the patient. We do not need the donor sample in this, and we check what is the MFI shift. The more the MFI shift, higher the antibody titer is there. Then we have, we do also have lysate-based assay, which is now not a preferred test to be done. In lysate-based assay, what we do is we take the beads, we coat them by the lysate of the donor, and all the antigens which are present in the donor are coated on these class 1 and class 2 beads. And again, we do the test in Luminex, and if there is MFI shift, that means it is positive, antibodies are there. If it does not shift, antibodies are not there. But this is an obsolete test. Why? Because in class 2, specifically with DQ antibodies, they sometimes fail to coat these beads, and these can become false. The test can become false negative, which we don't want. There are new tests. One is C1q based donor specific antibody and donor derived cell-free DNA assay, which we were discussing in previous talks. And then there are certain kits available in Luminex based platform for non-HLA antibodies. This is a busy slide, I know. What I want you all to focus is that whenever there is negative T and B cell cross match, both the cross matches are negative, the interpretation is low immunological risk, right? If the T or B cell cross match is positive in either CDC cross match or flow cross match, whether it is current or historical, your patient moves from low immunological risk to intermediate or high risk, right? So take home message, no single test can predict immunological status of patient. Combination of appropriate tests in appropriate clinical context are needed to evaluate patient's immunological risk status. And combination of at least one cell-based assay and one bead-based assay is preferred. Each test has its own limitation. So knowing them can reduce not only, it can reduce the rejection, but also it can avoid false rejection of the donor, because in India we do have scarcity of those donors. So we do not want them to be rejected falsely. Flow cytometric cross match has better sensitivity as compared to CDC cross match, and a positive flow cytometric cross match or CDC cross match should be followed by single antigen bead to avoid false rejection of the donor. So in summary and conclusion, I will refer to this article which says nothing's perfect, the art of defining HLA antibodies. And what we can learn from this article, if we go through this article, is that every case is a new challenge, and you need to have a multimodality approach to select the donor and also to avoid the false rejection of the donor. And I would like to thank you all with this last slide. Thank you. Any questions?
So I have a simple question. So do you really need both CDC and flow? Is that going to change your decision? Because in the slide that
so we always say that one cell-based assay should be there, and if it is a sensitive one, it's good. So flow cytometric, if you ask me which one to do, I'll prefer that you do flow cytometric cross match, right?
Yeah, we have
CDC cross match is assay which will give you idea about complement fixation, right?
Is that going to affect your decision of transplant?
The CDC cross match?
If your T and B cell flow single antigen bead is negative,
right,
and your CDC say is positive, you showed that it was IgM only, right? Low immunological risk. So is it going to change your decision?
So in those cases, you need to know whether your lab is using DTT or not. If they are using DTT, then there is a chances that IgM antibody could be there. And in case it is coming out to be positive, you have to go back, take the history of the patient, you see if there is antigen exposure in last 1 month. If it is there, then there is a chances that the new antibody has appeared, and there might be antigenic switching over a period of time, and IgG antibody will follow.
And for class 1 DSA, you guys use rituximab. Isn't that too excessive? Because class 1 we generally ignore.
So if there is only class 1, if there is only class 1 antibodies, to be very frank, if you will see the rejection, hyperacute rejection, class 1 has more role in hyperacute rejection as compared to class 2. Class 2 overall, class 2 has more propensity for rejections, but that is mainly because of chronic rejections.
So if your flow is negative, but you have, say, NT-HLA class 1 DSA, the MFI is 1,500.
So you can go ahead.
You're going to use rituximab?
Still, not rituximab, but it will be a low immunologic status for the patient.
Yeah, we generally ignore class 1 is what I was trying to come to. But what
but
you're
then
saying is
again it all depends what is the MFI of that.
Exactly.
If it is a high titer, then it's a risk.
So high titer is definitely a risk.
Yes.
So why doing a DSA if flow is negative?
Sorry?
So
yeah, you can have, he's the immunologist.
Yeah, please.
He'll tell you.
So you'll do a DSA if flow is negative or not? Will you do a DSA if flow is negative?
So if you want to know the real status, actually if you see, flow cytometric cross match will come out to be positive when your when you compare it with SAB, it's usually beyond 3000 MFI. Then your flow cytometric cross match will come out to be positive. From 3000 to 5000, it depends upon which loci we are talking about, right? So if you do DSA, that will definitely help you out. SAB, if you do SAB, it will definitely help you out in those cases where borderline MFI antibodies are there, right? But as we were discussing, low titer MFI, right, with flow cytometric cross match negative, they have less clinical significance.
I think your question was whether you need to do both even if the flow is negative. We always get both, and for this exact reason.
So borderline things which flow is missing, that you can, identify on that.
My question is, in layman language,
Right, sir.
we depend upon you. When you say transplant is negative,
Right.
and we go ahead with the transplant.
Right.
So saying negative, it means both are negative. When you say it is negative, go ahead with the transplant.
You can have a
you
negative.
You have done flow cytometry, you have done cytoxidol. When you say it is negative.
So when it is negative, the test result is negative, we say both are negative, the patient automatically comes in low immunological risk, right? The chances of hyperacute rejection will be low, very, very low,
No, my
right?
layman question is,
but you can still have DSA.
But you can still have acute
ultimately
rejection
you
and
say
chronic
transplant is
rejections.
negative, and we go ahead with the transplant. We never go for the interpretation of which is positive, which is negative. So once you are saying negative, you say negative only when all T cell, B cell are negative in both tests, or?
No, negative only means the single antigen beat, there was no, like the T and B cell cross match was negative.
Yeah.
But you can still have DSA.
Low titer
DSA
DSA
will prognosticate your post-transplant outcome. Say if you have DQ,
What about
something.
message to surgeon, when he should be cautious?
So it depends.
When he can go, no, I will not do the transplant by problem.
No,
So
we
if
get that
anything,
information.
even if your CDC of flow cytometric cross match is coming out to be positive, go for DSA.
If SAB is negative, then you won't give any induction. Will you give any induction if SAB is also negative? Like how you justify SAB in every case now? Like if you are not giving induction if SAB is negative, then you can at least justify doing SAB in every case.
So this is why we are telling you that if your flow cross match is negative, right, and it's been done with your reliable lab, you can go ahead, right? But there will always be a chance of small amount of antibody which is DSA which is there in those patients.
If you have done DSA SAB and there is no MFI of more than 300 or 500 in particular SAB, then will you not give any induction to that patient in form of ATG or this IL-2?
No, you still, for kidneys, all kidneys, we always use induction regardless. But if you have a DSA, say it is, even if it is class 1 and say the MFI is 3500, so above 2000 we start to pay attention to the DSA. So if you have a DSA that has a MFI that is significant, then we are going to use more effective immunosuppression. We are going to use thymo. If we were planning for basiliximab, we are not going to use basiliximab, we'll go for thymo. So that's how it changes our decision. It's kind of a DSA will prognosticate. If there's a de novo DSA, you have a high chance of rejection after transplant. So you have to pay more attention. We'll do more immune surveillance in those patients post-transplant. We'll do DSAs more frequently to make sure that the titers are rising or not. So we don't just treat the DSA. We'll do more surveillance, but we'll only treat DSA if there is a biopsy indication of rejection.
See,
Rejection may happen in any case, in spite of whatever is the treatment. My question is legal. My question is legal. When surgeon can safely show this was the report of a negative or I have done a transplant?
Yeah. As long as single antigen beat flow cytometry or CDC, whichever you're doing, is negative, you can go ahead with the transplant. Rest is like if your nephrologist is taking care of the patient in the post-transplant period, that's for them to worry, like how they manage their immunosuppression, immune surveillance.
So sir, if you ask me, it all starts from your clinical history. If the patient is not having any history of antigen exposure, and you are sure that there is no antigen exposure, right, in those cases, and your flow cytometric cross-match or CDC cross-match, both are negative, you can go ahead, right? But you know there is an antigenic exposure to this patient previously, and still your cross-matches are negative, there is still a chance that DSA can be there. In those cases, if you do DSA, it is better.
Basically, in spite of CDC negative, if the patient is high risk because of earlier transfusion or multiple pregnancy, or by any means you feel that it is a very challenging or the patient is very sensitive for outcome, then it is better to do the DSA. It will more safeguard your outcome and the prognostically. So it is always better to do the DSA, but to make it cost effective, you many times avoid it. So it is just how sensitive or how high profile your case is. If it is very high profile, it is better to do DSA.
See,
if rejection happens, then they will scrutinize, this was positive, this was negative, we have done my transplant.
That is why if your patient is very sensitive, it is better to do DSA.
So do you normally do CPRAs on all recipients, the calculated panel reactive antibody, which tells you the sensitization status of the recipient?
No, sir. I'll just come up with PRA is like PRA is used in Western country, and you'll get lot of requests for PRA in Western country. Why? Because they have more of cadaveric transplant where they need to triage the patients.
Yeah, we have to do it. Like we cannot not do it.
See here we are talking about CPRA, not PRA. CPRA is, I mean.
So calculated PRA you'll get.
Yes.
You'll get in all SAB reports. You'll have CPRA in those raw sheets. If you go on top, you'll find on right hand side corner CPRA will always be there. But CAPRA, if it is positive or negative, is individual based. If you compare the SAB report with the typing of the donor, you may find that PRA of 50 can be clear in this case, and there will be some cases where your PRA will be less than 10, but still DSA will be there.
Yeah.
So that is something which is, you need to understand that SAB along with a typing of donor is more appropriate as compared to CPRA or PRA.
Your point is very well taken. The benefit of CPRA is to stratify immunological risk, which is very important. Induction decides on an immunological risk category. That's why CPRA is very important. We don't do it routinely in India, obviously. Another point is class 2 antibodies. Class 2 antibodies are very dangerous. After 6 months, most of the rejections are likely because of the class 2 antibodies. So we should be very, very careful about class 2 antibodies. Regarding the DSA level, I mean, one test, if somebody has to do is a flow cytometry. I mean, because it is very, very sensitive. But sometimes a CDC negative, a flow positive, a DSA negative. So one should look for a non-HLA antibodies or class 3 minor HLA antibodies, which we routinely don't screen, like 81AR, MICA, A, B.
Right.
So
in these cases, or another thing which you need to look at is that whether your donors' antigens are really covered in your SAB or not. There are chances that your flow is positive, your SAB is coming out to be negative, but the donors' antigens are not been covered in the SAB. So those are the limited cocktail beads. They have maximum of 200 beads, which antigens which we can detect, and then we know that there are 6,000, more than 6,000, 8,000 alleles which are there. So
that limitation is going to stay always. Whatever beads are available with us, we can do that.
Thank you very much, Dr. Nitin, and we move to next topic.
Thank you.
And this is retroperitoneal donor nephrectomy by Kajanuri Tanabe, Dr. Kajanuri Tanabe. Welcome, sir.
Thank you very much. I assume in this country, most of the donor nephrectomy done by transperitoneal pure laparoscopic or maybe a hand assisted. But our technique is a retroperitoneoscopic live donor nephrectomy. So there are some differences between two techniques, transperitoneal, retroperitoneal. Working space is very narrow, retroperitoneal, but dissection of renal vessels is very easy, and the right nephrectomy easy, and intestinal injury possibly no injury for retroperitoneal approach, and the post-op recovery, resumption of the oral intake is very rapid. The day after the surgery, they can start the meal intake, and technical difficulties is very easy. So we studied up this technique back in 1999, and we summarized the data at the time and reported the AJT. So this is just 1,000 cases of the summary, 2001, 2015. And open conversion at the time, only one case, and the average retrieval time, it's about 2 hours. And warm ischemia time, less than 5 minutes, and quite a long renal artery in the vein. And the slow graft function was only 1.1%, and the delayed graft function it didn't have at the time. And surprisingly, painkiller injection was only 14% of the patients. 85% patients they didn't have any painkiller injection after surgery. Patient position, flat position, no bending of the knee joint like this. It's very much good for the patient. And port position, left side, only 3 ports, and the right side, 4 ports, and take out the kidney from the finesse incision. I just skip this. I just show the video, but this is almost 15 years ago. The apparatus looks very old-fashioned. This is quite long, so I just skip. Develop the retroperitoneal space using the balloon dilation, and dissect out the ureter, the first, and a careful dissection to preserve the renal ureteral blood supply. And we can approach the renal vessels directly from the posterior aspect. Same as the regular nephrectomy. And for severing the tributaries, we don't use any clips because of the GIS staplers cannot be applied. So we use the most of the time the ligature. This is the old-fashioned ligature. And dissect the ureter again, and then dissect out. And make a dissection. These are part of the ureter. And then remove the posterior aspect of the kidney, the fat layer from the posterior aspect of the kidney was removed to take off the kidney, like this. So now kidney and the posterior aspect of the kidney's perinephric fat is removed. Then dissect the anterior surface of the kidney. This is very easy case because of the lady. Oops. Sure. And then just skip this. And then linear hilum, that's up. Shoot. Sorry. And then dissect the ureter. And then make the tract to retrieval of the kidney through the retroperitoneal space to reduce cavity. So maybe you can see here the skin incision of the funnest incision, 5 centimeters. Very small incision because of the we don't grasp the kidney. We just put it in the back to make a funnest incision, and then develop the reduce cavity, and then connect to retroperitoneal space. So this looks like a very small space, but if you put in the kidney in the back, easy to retrieve. So put on the, to keep the pneumo, we need to put on this. Just sure. This is not so expensive. And then put the grab on to keep the pneumo. Like this. And then cut the ureter with the ligature. And then cut the finger and press the endocatch too. Such a small skin incision, so you can't put in your hand. And place the back behind the kidney to shorten the warm ischemia time. So under the direct vision, the assistants put inside the endocatch too, and then open the back here, and then place the. Actually, the Japanese patient is not big, very small, so sometimes back is too big. But most of the time it works very well. Then open up and easy to put in. And then the most of the time the pressure, pneumo pressure is very low, and then kidney looks very nice color and good tension. Then dissected renal artery and vein here, and then this is 15 years ago, so we don't have any automatic GIA at the time, so we use the regular manual GIA at the time. Press so even though the retroperitoneal approach, it's a good, sorry. Maybe around here. So most of the time we do not cut the renal artery very close to the aorta, because something wrong, we need to put the clip on it. So usually I try to leave a couple millimeters of the cuff of the renal artery. Donor safety is most important. Good visualization and very stable condition. We can close it and cut it. Okay, I skipped the vein severing and then put in the back. And the kidney doesn't have any blood, so it easily shrink and easy to take it out from the 5 centimeters of skin incision. Put in the back, no rush, and ureter here. And then assistants pull the string and close the back and carefully pull it out. So quite easy to take it out. So we don't place any drain and close the skin. So sometimes, actually, I don't have much, but sometimes unexpected bleeding we have. So in that case, we increase the pressure and wait the gentle pressure of the bleeding point. And of course, we are preparing for the catastrophic bleeding from the renal vessels for vascular clamp or GI staplers. Like this. We don't close the GIA, but just place the renal film to stop the bleeding. Fortunately, I didn't use this one since in my experience. And this is a very rare case, a case of bleeding from the lumbar vein due to sealing failure of the lumbar vein. Nowadays, the machine is much better, so I don't see this kind of problems, but more than 15 years ago, it was happened. It's already done, and then suddenly it's bleeding. And then the lumbar vein is open up. I'll show you, like this. And then gently press the 5 minutes, and then they stop the active bleeding, And then you can see the sealing was opened up. And then sealing again. This is very unusual, but I had a couple cases in the maybe 10 or 15 years ago. The machine developed much nicer now, so right now we don't have this kind of problems. But once we take out the kidney has a lot of this kind of sealing points. The sealing point is every sealing point are ligated carefully before transplantation. So advantage of retroperitoneal live donor nephrectomy is easy access to renal heme, easy access to the ureter, no intestinal complication, and the earlier resumption of an overall intake compared to transperitoneal approach. No wound hernia, and less post-operative pain compared to transperitoneal approach. So in summary, exact anastomosis understanding by CAT scan, and the safe and the meticulous laparoscopic procedure, of course, and avoid stress to the kidney and the renal artery, reduce carbon dioxide pressure in low, and usually we use the 5 to 10 centimeters and the gentle procedure to the kidney to keep good renal function. And prepare for the bleeding troubles during procedures like a large vascular clamp or GI staplers on the hand. Thank you very much. Questions?
Thank you, Dr. Tanabe. And just I had one question, that you still use GIA stapler for vascular control?
Huh? Answer that.
For vascular control, you still use GIA stapler or something else?
We in Japan, this is mandatory. We cannot use a hemorrhage for donor nephrectomy. So we have to use a GI stapler.
So do you give heparin, because one end is also closed? So do you give heparin before applying the GIA stapler?
Answer what?
You give some blood thinner, heparin for donor, because the other end is closed?
No. Most of the time we don't, because of the in Japanese population, the DVT is very rare, because somehow it's a very difficult to get that kind of complications. So even though the transplantation, we don't give any heparin. So donor, we don't. Maybe you guys, you give the heparin before?
No, because the other end was closed. You have to refreshen it. So there is some pooling off, means blood is retaining there. So to avoid that clot, I thought that you were using.
Okay, but we don't have any such a problem.
We use staplers, we use different staplers, but we heparinize.
Yeah.
So we give 2,500 units of heparin to the donor, and then we, after the kidney is out, we reverse it.
Yeah. So whenever there is a closed end.
Because we use, like, as you said, it's closed. So
even in a very short time, so we don't have any.
To get it out
Yeah.
after.
And other thing that because these are non-diseased kidney, normal healthy kidney, do we really need to put in a bag to remove this?
Well, to keep the small incision, we need to put it in the back. If you grasp it, the skin becomes too big.
So have you had complications with like subcapsular hematomas? Because it looked like a tight pull out the small incision, a lot of trauma pulling the kidney out?
No, we don't. Because the first of the, in the early period, we are very much afraid of that. But kidney become to be shrink. Even though the 300 gram of a big kidney, doesn't matter. But problem is, if the patient, the lady, has a gynecological surgery, sometimes round ligament is very much sticky. So couple times it's stuck. Then we have to open up here. But other than that, no problem.
Retroperitoneoscopic looks very good. Dr. Jamal was telling me that in our population, it might actually be good, like in the higher BMIs, easy access to vessels.
So actually we have a publication on retroperitoneoscopic donor nephrectomies in high BMI individuals, and we find that actually there's better recovery, less pain, better recovery of bowel function. So, so I'm very happy to see your video, because there may be half a dozen centers in our country which practice retroperitoneoscopy, and we do about 300 a year. And we endorse everything said. I think it's actually a very patient-friendly operation, probably more so than transperitoneal. So my question to you is, to what extent is this adopted in Japanese programs? Do most places use retroperitoneal, or do the majority still use transperitoneal?
I think the 80% institution is retroperitoneal approach.
Okay.
Maybe 20% for general surgeon, they prefer to the transperitoneal.
Okay.
But many of them, they move to a retro because of the post-surgical pain is much less. And they're easy to go back to home, maybe a couple of days or 1 day. So much easier.
Yeah, so we typically discharge at 48 hours.
Yeah.
And,
even though the quite a big donor, of course the donor should be slender, not a big one. But sometimes the middle-aged chubby gentleman has a very sticky fat around the kidney.
So, yeah, the toxic fat is there sometimes.
But most of the time we can manage it.
Right. But I mean, again, so I think that in an obese donor, in the flank position, the fat all falls away towards,
Exactly.
and the flank is relatively free of parietal fat.
Yeah, exactly.
Excellent presentation
Thank
and
you.
excellent video. Thank you so much, Dr. Tanada.
Thank you. So this is the end of session now.
Thank you, Dr. Rajiv and Dr. Arun Devra. So that brings us to the end of the session of day 2. We'll begin with the inauguration ceremony. So I'd just like to call upon Dr. Anant Kumar sir, Dr. Anil Kumar, Dr. Gurpreet Singh, Dr. Dinesh Khullar sir, Dr. Rajiv Sood sir, and Dr. Ruchir sir on stage, please.
Somebody should come and do what is there. Sumit sir को बुला लो. Sumit sir को बुला लो. No, पहले से बता. कुछ प्रॉब्लम नहीं है. और भी नहीं, मैं शुरू में सर पहले गंगाराम रहा हूँ. About 18-20 years I was there. For the last about 11 years I've been here in Sarkochi. We joined together. Dr. Nant and we, as a team of surgeon and physicians, we joined together.
So I'd like to welcome the chief guest of the Max Transplant Surgicon. Dr. Anil Kumar, sir. So if you could please join us to the front of the stage, please. Dr. Gurpreet Singh. Dr. Dinesh Khullar. Dr. Anant Kumar, sir. Dr. Rajiv Sood, sir. I'd like to call Dr. Anant to share a few words.
Dr. Anil Kumar, Professor Rajiv Sood, Professor Khullar, Dr. Gurpreet Ruchir, our international guest, Dr. Tanabe, Dr. Rajiv Sharma, friends, colleagues, delegates, ladies and gentlemen, I would like to welcome you all for this Surgicon, Transplant Surgicon 24. Every year we do one academic program. The purpose is to share our knowledge, communicate with each other, and improve our skill and knowledge so that we can provide better care to our patient and improve our own knowledge. Like this year we did on transplant, last year we did on robotic, before that we did on uro-oncology, and this time we changed our format. First day we did training up the 20 young people who wanted to learn transplant. So we took the opportunity of the cadaveric facility at All India Institute, and we taught them how to do laparoscopic donor nephrectomy, open donor nephrectomy, kidney transplant, and AV fistula. So that whole session started from morning with theoretical lecture till 6 o'clock in the evening, and that everybody was very enthusiastic and was very thankful because they liked the whole program and they learned a lot. And this new system of this thought cadaver, that anatomy is very clear and that learning was very good. And we had very good interaction yesterday on the various case discussion, and we are transmitting we transmitted one robotic transplant and one multiple vessel transplant today, and tomorrow we'll be transmitting another robotic transplant where donor and recipient both will be done robotically. We don't do robotic donor. We have done only one for the Harsho kidney, but tomorrow just for the demonstration we will do it, and another open transplant. And we'll have some discussion and some lectures tomorrow also. And this is all happening because we have a very good transplant facility. We have a very good nephrology department, very good nephrology support, good communication, interaction, and big dialysis facility. So we have a large pool of patients, and we do Plus, we also have a very good multi-specialty hospital and very nice ICU imaging facility, so that we can handle any kind of complicated patient with help of our colleagues from gastroenterology, neurology, cardiology, and we have very good ICU facility. So we have seen that very sick patient we have taken care of, and transplant is done. Otherwise, we thought that it will not be possible. And we do all kinds of transplant services, but we lack in two things, and we would like to improve upon these two things. One is our paired donation program, but we are working on it and very hopeful that with the help of our friend Michael Rees, we may be able to develop program and share amongst the Max group of hospital. And one thing, we have very good administrative support, and our director Gurpreet Singh is here, and they also help us in planning and improving this our program. And next agenda is to improve our disease donor program. Actually, disease donor program is doing reasonably well in western part and southern part of the country, but it's not doing so well in Delhi and NCR, and it should have been doing better in Delhi and NCR, because Delhi NCR has the best hospitals in government sector, in private sector, as well as large number of hospitals, maximum number of ICU beds are in Delhi and NCR. We have trauma centers, we have, and our National Transplant Authority, NOTO, is in Delhi, and we have a good support of NOTO, but somehow our program is, we are doing some cadaveric program, but we wish we'll be doing better and more cadaveric program, so that we can take care of many sick patients. In our hospital, we have very good liver and kidney transplant program. I think liver transplant is biggest. We do 400 liver transplant in a year. We also have a heart transplant program and lung transplant program. So if you are doing more disease donor program, probably multi-organ transplant will develop in a better way. But for that, we all have to work hard, and we are working it and hoping that things will become better. And I'm quite happy to see that there was a very good interaction, and we are learning from each other, and every time we learn small points which help us in taking care of our patients. So with that, I would like to welcome you all again for this transplant workshop, and thank you very much.
Thank you, sir, for your kind words. Next, I'd like to call the Director of Max Super Speciality Hospital, Dr. Gurpreet Singh, just to share a few thoughts of his, please.
Good evening, all of you. And first of all, thank you, Dr. Anand, for having me here. And it's a great, I would say, honor and privilege to be a part of this conference and to be among the stalwarts of urology and kidney transplant. What I would just say is that it's all because of the passion that Dr. Anand shares, not just as a urologist and a kidney transplant surgeon, but as a teacher, as an administrator, as a leader. So it's because of this that he's purely involved in the clinical surgical aspects, as well as in ensuring that we from the management side work closely with him to give the best care to his patients, be it infections, infra, equipment, and also, as he's just pointed out, that he taught 20 young budding urologists to get up to that level. So that's what speaks volumes about Dr. Anand. So thank you, sir. Thank you for being with us, and thank you for organizing this conference. It's really an honor to be here. Thank you.
Thank you, sir. Next, I'd like to call Head of Department, Nephrology Department of Max Super Speciality Hospital, Dr. Dinesh Kullar, to share his thoughts, please.
Dr. Anil Kumar, Dr. Rajiv, Dr. Gurpreet, Dr. Anand, Ruchir, ladies and gentlemen, on behalf of Institute of Renal Sciences, Max Super Specialty Hospital. It's my proud privilege to welcome you all for this wonderful meeting, which has become almost synonymous with the tremendous work which Dr. Anant Kumar and his team have been doing over the years. You all know, and in fact, I probably would be the odd man out today as a nephrologist, but you know it's a perfect symbiosis when we look at the relative roles played by the urologists, the transplant surgeons, and the transplant physicians. So it's a tremendous kind of teamwork, which certainly will not lead anywhere unless you have the support of the institution, and Dr. Gurpreet, whom you just heard, provides just about that. When I say we are fortunate, and I am speaking on behalf of my department, to have such a wonderful team, bunch of probably the best surgeons that I know of, ably led by Dr. Anant Kumar. It's not without reason I'm saying that. I'll share a few thoughts, the kind of confidence which you can repose only once you are sure that your surgical team will deliver the goods. And I'm reminded of when we were offered the landmark Transform trial, and we gladly accepted the opportunity. But why I am in particular talking about that is, Transform was with everolimus, and everolimus started de novo. Now, one of the biggest problems which one would always try to club the therapy of everolimus with would be the higher incidence of lymphocyles, of wound dehiscence, impaired wound healing. So such was the faith in this surgical team that I went ahead and accepted the trial without even asking Dr. Anand whether he would agree with that or not, which means that majority of the centers were petrified to go in for such a trial where you have to give everolimus de novo and accept the risk of all those wound-related problems. But that was just when we, as a team, had joined Max Super Specialty Hospital almost about a little over 10 or close to 11 years now. But it's been a journey, and seeing from a distance the marvelous kind of surgical feats which they have achieved, it's tremendous. The kind of spectacular surgeries which I have witnessed, because even in my previous hospital, that's the Gangaram Hospital, I had the chance of seeing some of the best surgeons. But this was an ongoing journey where I really could see what more could actually be achieved via surgical skills. And every time we were thrown in with some kind of pleasant surprise. And you all know, and what you are all discussing, you know it better than me, the challenges thrown by robotic-assisted transplants, and they're pioneers. And look at the phenomenal surgeries they have all performed. And he, as Dr. Gurpreet was saying, is a great teacher. So everyone in the department, I'm sure, is quite able to perform this kind of complicated surgery quite ably. Whether it's accepting a horseshoe kidney as a donor, that I thought was crazy, but then the results were quite good, and all that apprehension faded away within no time. Or whether it was retrieving the kidney per vaginum, the donor kidney, or every time he would come in with a surprise. So when the patients will say the surgery got postponed by maybe a week or so, and when I will confront Dr. Anand why this surgery was delayed, the answer would be, I was busy teaching people in either Switzerland or USA. So that would make us so proud that I said, okay, Dr. Anand, granted, pardoned. Even if the surgery was delayed, it's okay because you have really brought laurels to the institution. But going apart and moving away from what he has done for the department alone and the institute alone, I think it's what the passion is all about, to disseminate knowledge and disseminate the nitty-gritties which he has learned, and he's always eager to disseminate that kind of knowledge. But at the same time, he's also eager to learn from others, even beyond his own speciality, and that makes it a wonderful right blend, I would say. And it's not just him, it's the entire team, and we, as I said, in the department are so fortunate to have him here. But one thing which you touched upon is the way we collectively as nephrologists, transplant physicians, and you as urologists and transplant surgeons have to accept our responsibility is to expand the deceased donor program. We all know how poor are we behaving, and we can't hold our heads high when we are in international meetings, because we have to accept that just about 10% of the Indian transplant recipients get a kidney from the deceased donor, while everyone else has to look for within the families. So while on one hand we are desperately trying to expand this pool, yes, deceased donor is one, but equally important is what he had alluded to, is the tremendous part which can be played by the paired kidney donation. And I think I'll go one step ahead now to say what kind of role can the management support can play. When we insisted on Dr. Gurpreet and his other team members that we must invest into having a software which has been very nicely designed by Dr. Michael Rees, which Dr. Anand Kumar mentioned about, there was some hurdles involved. The institution was quick to remove them, and we could actually acquire that impressive software. We can't, I must confess, we cannot improve upon our transplant rates when we are using our own mind and not taking the help of these wonderfully designed softwares which help us in making the correct kind of bringing the two families together, or more than two families together, for and in fact the domino and whole lot of so on and so forth. And it's not just about blood group matching, we have to now start thinking beyond blood group matching and the epitope matching. And I often say, so many times you would be actually ignoring the so-called real brother and going for a transplantation, accepting probably unrelated, and you would say that brother lost in the Kumbh Ka Mela would probably now come forward, would be identified, and you can actually go ahead with a perfect matching. So that will certainly improve the results. But while we talk about improving upon the results, we definitely have to expand the pool. And no one better than the person sitting right in front of you, Dr. Anil Kumar. I would say he hats off to him as a Noto director. He has left no stone unturned in promoting the cause of deceased donor. And with people as passionate as him at the helm of affairs, I am certainly quite optimistic about what we are going to see in the years to come. And equally important would be the role played by people like Dr. Rajiv Sood, because they, being a urologist who have achieved so much in life, they have achieved the pinnacle of becoming vice chancellor of a university. They are the people who matter, and if they carry forward our requests and they are part of the decision making, I'm sure the day is not very far when we will have some very effective results coming out of what we have really been investing over the last so many years. So I'm sure you have found it very, very enlightening and a wonderful learning experience so far, and I'm sure you have also been equally contributing towards and sharing your pearls of wisdom amongst your peer group. With these words, I welcome you once again, and I'm sure you're going to have a wonderful time even tomorrow as well. And of course, if we as non-surgeons become so excited to see these kind of wonderful surgeries being performed for you, I think it's probably be even better, and I'm sure you will take back home some great learnings, and so that the message keeps on getting propagated. Thank you very much, and I'll once again thank Dr. Anand Kumar for this wonderful opportunity given to me. Thank you.
Thank you, Dr. Khuller sir, for that heartwarming speech. Next, I'd like to call upon the Director of Noto, Dr. Anil Kumar, on stage, please, to share a few words.
Good evening. Thanks to the organizer for inviting me here on this Max Transplant Surgicon update which they are organizing. And I was going through the agenda, and literally it covered everything which is modern and the latest techniques of the surgical techniques of the kidney transplantation. It is all covered. And I was really, I think it has provided very high level of learning opportunities to all of you. So thanks especially to Dr. Anant Kumar, who has been a pioneer in the field of kidney transplantation, and since very long, when the act was not there, like when he was at SGPGI MS, so that from that time he has been he has been doing these transplant surgeries. So he's a great teacher, and he has been spreading this learning to all of you and teaching others. So that is also really very commendable. Thanks to the Max director, Dr. Gurpreet, for taking it forward, and Dr. Khullar. He is also very passionate about the program and keeping this organ donation and transplantation, because that is, and Professor Rajiv Sood, who was earlier in government and now he has moved to the Vice Chancellor, and again spreading the capacity building in kidney transplantation, he is doing it. I can see many young urologists who have come. We have last year, 2023, we crossed around 13,000 kidney transplants in the country, 13,300 something, out of which 1,635 they came from deceased donors. So rest were from living donors. Delhi NCR is leading in the kidney transplant number, but it is mainly living donation only. So majority is only living donor transplant in the Delhi NCR, and we need to improve upon that, as already highlighted by some of the speakers, and that we should promote deceased organ donation. Some of the government institutions are also now coming forward. I see Army Hospital Research and Referral doing very good results, outcomes of the kidney transplantation they are doing. While transporting, they are using a perfusion system in their transport machine, so, and which is bringing very good results on the table when they are transplanting. Similarly, now we have our government institution in Safdarjung and RML also doing some few number of kidney transplant. They are doing living as well as now they have started doing the deceased donation kidney transplant. So that is also now improving. And Delhi NCR, we have lot of very skilled surgeons who are available all over the NCR region, but definitely we need to improve upon deceased organ donation. That number is very less, especially in this part of the country, and it is last year total number of transplants we see was around more than 18,000, including all organ transplants. So which out of which around 3,000 were from the deceased donors. So so we need to improve further, and so that for that we are we have launched a registry also. Those who wish to register their wish to donate after death, they can do so very easily now. And there is a website noto.abdm.gov.in, and by verifying your identity through Aadhaar, you can easily register, and your that registration certificate, like a COVID certificate, it is generated, and that you can even post on your social media. The information goes to your family members simultaneously. So that kind of a has to be propagated, and I'm happy to inform you that since 17th September last year, it is now more than 1,82,000 people in the country have registered through that registry of the they have voluntarily pledged for organ donation, and it is Aadhaar authenticated. So and basically it is also now the message has gone to these 1,82,000 families also, because the information goes there. So we need to promote deceased organ donation. So that is one area. We have shortage of surgeons in the country. I think we have 5,000 urologists, if I'm not wrong, in the country, but out of which only few hundreds are doing transplantation, or like they are trained from those institutions where transplants are being done. So that leads to, because we require a lot more surgeons. So we don't have that many surgeons. And one surgeon we have allowed to work in more than one institution. But sometimes when you are doing too many surgeries at different institutions, the care suffers. So care of the patient, post-transplant work care sometimes is, that gets jeopardized in some situations. So we need to build capacities in the kidney transplantation, and basically these surgical skills, particularly we need to be more, these departments have to be more active. They need to be, more residents, more PG seats, more super specialty seats in these departments. And so we are working with NMC to improve upon these numbers, and gradually these teaching facilities are improving, the numbers are improving, and so we need to do more because the requirement is huge, and definitely there is a shortage of surgeons in the country at present, and it is not only in the north part, it is also in the southern and the western part of the India also, and definitely in the eastern and the northeastern part. So the opportunities which are provided by such conferences, they are a great opportunities of learning, which I think bring all these surgeons together, and they have an opportunity to learn the latest in the field and take it forward. So all the best to you, and hope that you will be taking what you have learned here, you will be implementing further and spreading the message of organ donation. Basically we promote that ultimately everyone has to die, and death is something which is inevitable truth. So it cannot be, everybody has to die. But when we are alive and kicking, and that time if we register our wish to help others, so that registry can be done very easily now. It has been very easily done now. It is easily can be done by anybody who is the citizen of the country. So that should be done, and so that once you are in the ICU at the end of your lifetime, and somebody else will be taking decision for you. So rather, why not decide for yourself? Once we are, can decide, and we are conscious, and connect with this cause, and let the organs which can be donated not be wasted. And so these donated organs, they can save many lives, not only kidneys. You can donate liver, heart, pancreas, intestine, lungs. So hands are also being donated now. So all these organs we can think of donating, and we can spread this message around to our friends, family members, and your colleagues who are working with you, and let everybody contribute to this social cause and take it forward. So thank you so much for having me here, and really honored to be here among all of you, and thank you very much. Okay.
Thank you, sir. Next, I'd like to call upon the Vice Chancellor of Punjab University and ex-Dean and Head of Department Urology at RML Hospital, New Delhi, Professor Dr. Rajiv Sood, sir.
Good evening, Dr. Anant Kumar, Dr. Anil, and Dr. Gurpreet, all the dignitaries, and off the dais also I am seeing Dr. P.V. Singh, Dr. Aditya Pradhan, Dr. Oswal and Vashni and all. This is a great occasion. I am thankful. I bring greetings from Baba Farid University, which is the State Health University, one of the 13 health universities of the country. And as far as the transplant program is concerned, Dr. Anant Kumar is there, and I became the member long back of transplant societies, and I think he was instrumental long back. I think 20, 30 years back I became the member. And I'm fortunate to be in touch with Dr. Anil. Dr. Anil made it possible for Urology Department of RML to start transplant program. And there has been, Max is always leading today, thanks to the stalwarts and very good surgeons, skilled surgeons. Today is the time of skilled education and training. And this is one field where a lot of skill-based education, competency-based education, outcome-based education and training is going on. The diseased organ program, I remember Dr. Aditya was next door in BLK when I was there, and he was again and again insisting, why don't you start, why don't you start? And we started in RML hospital, the diseased kidney transplant program. And Ministry of Health is always passionate. I remember when the act was created and a special DG was made the responsible person who was also urologist. And thereafter, today in our crowd, when you were talking about Urological Society of India, there are two stalwarts presidents of USI, Dr. P.V. Singh and Dr. Anant Kumar, who has guided the Urological Society of India, and when I was president, then I made this happening round the year, and Dr. Oswal is there when we were able to do it as the program for continuous 5 years. I was discussing with Dr. Anil. Our main problem is not the shortage of surgeons only. It is shortage of nephrologists also. And that is bigger problem for us. There are many transplant surgeons who are sitting, but they are not able to start the program because of good packages in the private versus the government sectors. I am seeing the urologist and transplant surgeon from AIIMS Bhatinda, which is very near in Punjab, but because of the problem, certain problems, somewhere nuclear medicine department is not there. So Baba Farid University offered that, MOU has been signed, and in the big state, you will be surprised. In the Soto Center, there is no nephrologist, no transplant surgeon. And in Punjab, there is problem. So I am trying to solve that, and with the guidance from the stalwarts like Anil Kumar is very active. I had been in great association for, I think, 2 decades with him already. And we are, yesterday also I was discussing, and fortunately he is here, and we have discussed, taken this opportunity. So this is to be done at every center, that every hospital, and it is more important how to organize the whole system. The system has some problems. It is not that willingness is not there. I want to bring to your notice that some certain places transplant program collapse because of the nephrologist also, because they leave for the better pay packages. We have to create, when we say that more MBBS doctors are to be created, now there is again budge statement that earlier it was that we create immediately certain number, and now in next 1 or 2 years 75,000 more MBBS doctors are to be created. In the super specialties also, there are certain super specialties where there is a big problem, And I am advocating in National Medical. I am not only in as Vice Chancellor. At present, I am the Governing Council of National Medical Commission also. There we are advocating, and very soon it is going to be notified that more and more integrated programs are going to be there, degree programs, where MD and nephrology will be combined. So that right from the beginning, we have more people who are dedicated to some discipline, urology, nephrology, and we are working on them. And in the state where all the medical colleges I am responsible, I take guidance from the stalwarts like Anant Kumar also. And he has worked in the government sector and excelled, and also in private sector he is excelling. And similarly, Dr. P.V. Singh, Aditya Pradhan, you are all the cream of the urologists and surgeons who are dedicated to transplant also. I wish all the best for this program, continuously training program, which Dr. Anant is, I am seeing that year after year, he is doing better programs and best programs of the year every time on transplant. So all the best for these efforts, and also to the transplant program future in India. Thank you. I'll only mention one thing, that when diseased transplant program was advocated in 2014, Aditya Pradhan helped me from BLK. And you need to involve the celebrities also. And Kapil Dev is one of the registered, amongst the first registered, our famous cricketer, and from Collegium Supreme Court judges also has already registered. And they have written it very proudly on their biodata. If you go on internet, they have written, we have donated it, we have registered. We should take advantage of this also. And thank you very much. Thank you for calling me. Thank you.
Thank you, sir, for your kind words. I would request all the honorary dignitaries to please make their way to the end of the stage to light the ceremonial lamp, please. Next, I would request the organizing secretary for this Max Transplant Surgicon, Dr. Ruchir Maheshwari, to please share his few words, please.
To start with, I would like to thank Professor Anant Kumar and the entire administration, the organization of Max Saket, which allowed us this wonderful meeting. So all we are here. We are honored that we had dignitaries from Japan and US, Professor Tanabe and Dr. Rajiv, who traveled all the way here to share valuable thoughts and broaden our outlook over this transplant. May I ask Professor Anil and Professor Dr. Dinesh Khullar to please facilitate Professor Tanabe. Thank you, Professor Tanabe, for your visit. May I request Dr. Rajiv Sood and Dr. Gurpreet Singh to please facilitate Dr. Rajiv Sharma, please. So no conference can be deemed successful if there are no delegates and the faculty members. So I would like to especially thank all the faculty members who took time out of their precious time and come here for the conference, and the delegates. Without you, it cannot be successful. So I would like to thank our secretary, Mr. Ayush Kumar Singh, who slogged in day in and day out, took everything on his head, took all the beatings and scoldings from us for all the job he has done at the backstage. I would like to thank my friend and colleague Dr. Samit, Dr. Pragnesh, and entire department of urology at Max Saket, including all the consultants, residents, fellows who worked day in and day out for this conference to happen. So surgery cannot be successful without the anesthetist. So we are especially thankful to our Department of Anesthesia for being there, taking all the challenges and ensuring that the surgery goes smoothly. And obviously the OT staff, and without patients we cannot do anything. And for any conference we need funds. So I would like to thank the industry, the pharma industry, especially Mankind, Novartis, Sanofi, Concord Biotech, Zydus, Sun, Cipla, Emcure, Intas, Medtronic, Intuitive, and all the others who were generous enough to give us academic grant to make this possible. So thank you all. Now I would like to invite you all to join us for the cocktail and dinners. Thank you.